Bom dia a todos. Muito obrigado, Sra. Presidente. Cabo Verde alcançou um marco histórico ao ser certificado pela OMS como país livre do paludismo em janeiro de 2024. Este feito posiciona o país como modelo regional na luta contra a doença, demonstrando que a eliminação é possível, mesmo em contextos africanos com desafios estruturais. O paludismo em Cabo Verde é um paludismo de moderada intensidade e está muito relacionada com a mobilidade da população. Inclusivamente, desde 1954, temos vindo a desenvolver ações no sentido da sua eliminação. Por isso, tivemos 3 períodos de eliminação, de suspensão da infecção, de 67 a 72, de 83 a 85, e a partir de 2018 até hoje não temos transmissão autóctone do paludismo. Para isso foi desenvolvido já há muito tempo um sistema forte de vigilância resiliente. Por isso, Cabo Verde implementou um sistema robusto de vigilância epidemiológica e entomológica com foco na detenção precoce de casos importados e o controlo do vetor. Neste momento, o país está a executar um plano nacional para evitar a reintrodução da doença com ações coordenadas entre a saúde, ambiente e educação. Reconhecemos que, tão difícil como a eliminação e a erradicação do paludismo, as estratégias tomadas para a sua manutenção também são desafiantes. Nós, neste momento, estamos a trabalhar os casos importados. A maioria dos casos recentes são importados de países vizinhos.
Merci, Cabo Verde. Merci. 2 minutes.
Thank you very much.
Merci. Voilà, Zimbabwe a la parole, les Seychelles se préparent. Merci. Zimbabwe.
Thank you, Chairperson. Honorable Chairperson, distinguished delegates, Zimbabwe welcomes the report on malaria elimination efforts and commends the regional office for its comprehensive work. We reaffirm our commitment to the 2030 targets of the Global Technical Strategy for Malaria. Over the years, Zimbabwe has made notable progress in reducing malaria incidence and mortality through the effective use of indoor residual spraying, distribution of insecticide-treated nets, and strengthening case management. These gains are the result of strong collaboration between government partners and communities. However, in the 2024-2025 season, we experienced a resurgence of cases, driven not by funding shifts alone, but by a combination of contextual challenges. Exceptionally high rainfall created extensive breeding sites, artisanal mining activities altered environments and increased exposure to vectors. The misuse of insecticide-treated nets for fishing undermined protection at household level, and the discontinuation of DDT coupled with emerging resistance to other insecticides has reduced the effectiveness of vector control. These realities illustrate the complex and evolving nature of malaria transmission. The proper use of vector control tools, expanded access to testing and treatment, and is exploring alternative insecticides and innovative approaches to strengthening control measures. Our experience underscores the importance of sustained domestic investment, operational research, and regional cooperation. together we can protect the gains made and ensure that by 2030, malaria is no longer a threat.
Merci Zimbabwe. Merci
you.
Zimbabwe. Seychelles a la parole. Le Togo se prépare. Merci.
Honorable Chair, in spite of the continuing high human and economic cost of malaria on our continent, Seychelles is encouraged by the reduction in incidence and mortality in some parts of our region. Seychelles is free from endemic malaria, but we remain vigilant due to the risk of imported cases and climate-induced vector proliferation. Seychelles emphasizes enhanced surveillance and rapid response to prevent reintroduction, leveraging our experience in vector control. Climate adaptation strategies as rising temperatures may expand mosquito habitats. Regional partnerships, including support for high malaria burden nations through knowledge sharing and other support. We echo the resolution's call for stronger political will, data-driven strategies, and equitable access to tools like the new malaria vaccine for children and diagnostics. Seychelles also stresses the need for domestic resource mobilization in endemic countries, community education to sustain prevention efforts, including environmental sanitation, cross-section collaboration to tackle underlying drivers like instability, poverty, and environmental degradation. It's only through relentless united action can we achieve the 2030 malaria targets. Thank you, Madam Chair.
Merci beaucoup aux Seychelles. Togo a la parole, le Libéria se prépare.
Merci Madame la Présidente. Le Togo s'est engagé dans la lutte contre le paludisme conformément à la stratégie technique mondiale 2016-2030 et contribue aux efforts régionaux pour une action urgente afin d'accélérer la lutte antipaludique. En matière de prévention, notre pays met en œuvre la chimioprévention saisonnière du paludisme dans 4 régions sanitaires. Le traitement préventif intermittent chez les femmes enceintes a introduit la chimioprévention du paludisme pérenne chez les nourrissons dans 16 districts sanitaires et se prépare l'introduction dès le 1er septembre 2025 du vaccin antipaludique et à sa 6e campagne de distribution de masse de moustiquaires imprégnés d'insecticides en 2026. En capitalisant la digitalisation, un référentiel national de données sur le paludisme est en cours de mise en place afin de centraliser et harmoniser les données issues de multiples sources. Aussi, une adaptation infranationale des interventions initiées pour orienter les décisions stratégiques et optimiser les ressources. Le Togo promeut également la collaboration multisectorielle associant les collectivités locales, les organisations communautaires, le secteur privé et les partenaires techniques et financiers afin d'améliorer la couverture et l'efficacité des interventions. Toutefois, des défis importants restent à relever, notamment la résistance aux insecticides et aux antipaludiques. Le Togo réaffirme son engagement à contribuer activement à la mise en œuvre de la déclaration de Yaoundé appel à une mobilisation collective accrue ainsi qu'au partage d'innovation de bonnes pratiques pour atteindre les objectifs de lutte contre le paludisme. Le Togo prend note des actions proposées. Je vous remercie, Madame la Présidente.
Merci au Togo. Le Libéria a la parole et le Gabon se prépare.
Honorable Chair, distinguished delegates and colleagues, Liberia reaffirms its unwavering dedication to combating malaria in alignment with the Yaoundé Declaration and the 2030 malaria target. Key milestones achieved include the introduction of Mercury's malaria vaccine in April 2024 and the establishment of the Malaria Council and Fund in April 2025 to facilitate domestic resource mobilization. Our strategy encompasses the distribution of insecticide-treated bare nets through antenatal care programs, community health workers in 5-kilometer radius, and expanded program on immunization in schools. A successful mass distribution campaigns in 2024 resulted in over 2 million RTN distributed, achieving 88% coverage. Furthermore, Liberia actively promotes prompt diagnosis and treatment, including intermittent preventive malaria treatment. A recent pilot project in Buyao-Nima County showed a fourfold increase in uptake. National Malaria Control Program has employed multiple first-line treatment to mitigate the risks of anti-malaria drug resistance. These efforts have yielded significant results, reducing malaria prevalence from 28% in 2013 to 10% in 2022. Despite the substantial progress, challenges remain. To further advance our malaria control program, Liberia respectfully requests WHO technical support, particularly in integrated vector and case management. Specific areas require assistance include surveillance on Anopheles staphylococcus and studies on RTN durability. Additional support is crucial for implementation of updated technical guidelines and supportive supervision. Achieving the 2030 target necessitates a unified support from government, communities, researchers, and Liberia is committed to collaborate with all member states to accelerate the progress toward a free malaria world for all. Thank you.
Merci, Oliveria. Le Gabon a la parole et l'Angola se prépare. Donc, si l'Angola, le Gabon a la parole. Donc, l'Angola.
Muito obrigado, Sra. Presidente. Gostaríamos de reafirmar aqui, nesta magna Assembleia, que a República de Angola, o paludismo continua a ser a principal causa de morte. A prevalência nacional é de 1,7%, de acordo com o inquérito de indicadores múltiplos de saúde, elaborado em 2023-2024. A transmissão é maior na região norte do país, sendo o grupo mais afetado crianças menores de 5 anos, que concentram 49% dos óbitos. Angola está empenhada em implementar as ações do plano estratégico alinhado com a estratégia técnica global 2016-2030. Neste contexto, estamos a ampliar a distribuição de redes mosquiteiras de nova geração de rotina e campanha de distribuição em massa, implementando o tratamento preventivo em grávidas e formando os adectos para diagnóstico e tratamentos comunitários. Angola continua também empenhada na introdução da vacina da malária, de rotina, para acelerar a médio e longo prazo a redução sustentável da mortalidade por malária. Angola acolhe as medidas propostas no relatório e reitera o seu compromisso com o reforço do Sistema Nacional, visando a garantia e resiliência do Programa de Controlo do Paludismo, na ampliação e implementação de iniciativas multissetoriais emblemáticas. Muito obrigado, Sra. Presidente.
Merci à l'Angola, le Mali, et Gambie se prépare.
Merci Madame la Présidente. Le Mali est un pays à charge élevée et s'est engagé dans la lutte contre le paludisme à travers plusieurs initiatives. L'objectif de développement durable, stratégie mondiale 2016-2030 et l'initiative charge élevée et impact élevé et la déclaration de Yaoundé. Les actions prioritaires incluent la prévention, le diagnostic gratuit pour les populations vulnérables et la subvention au traitement. En 2024, le Mali a réalisé une distribution de plus de 1,5 million de moustiquaires imprégnés en routine, le traitement préventif intermittent avec une couverture de 53% chez les femmes enceintes en dépit du recours tardif aux consultations prénatales. La chimioprévention saisonnière avec une couverture de 81% chez les enfants de 3 à 59 mois dans 58 districts sanitaires et l'introduction du vaccin dans 19 districts à forte transmission pour les enfants de 5 à 36 mois. Malgré ces progrès, le Mali fait face à des défis structurels et une incidence en hausse localisée. La pérennisation des actions nécessite un engagement politique renforcé et des soutiens internationaux pour l'atteinte des objectifs mondiaux d'élimination du paludisme. Le Mali, après examen, préconise l'adoption du dit rapport par le présent comité. Je vous remercie.
Merci au Mali. Gambie a la parole, le Kenya se prépare.
Thank you, Madam Chair. The Gambia recognizes the Global Technical Strategy for Malaria 2016-2030 adopted by the World Health Assembly in May 2015. The strategy set the target of reducing global malaria incidence and mortality rate by at least 90% by 2030. The Ministry of Health of the Gambia has made significant noticeably progress in addressing threats and mobilizing collective action towards achieving the 2030 malaria target. To meet the 2030 malaria target in the Gambia, a multifaceted approach has been adopted to tackle the complex nature of malaria. The Gambia, like many other countries in sub-Saharan Africa, faces significant challenges, but also has opportunity to galvanize opportunity towards malaria control and elimination. The Gambia has achieved significant gains in reducing the malaria burden over the last decade. The number of confirmed cases of malaria dropped by more than 50% in 2024. During the second quarter of 2025, the Gambia was able to distribute 1.5 million new generation of insecticide-treated nets to the general population. As part of our elimination effort, the Ministry of Health, through the National Malaria Control Program in 2023, started malaria case-based surveillance in 2 health regions where lowest case of malaria were recorded over the last 5 years. Hence, every case of malaria detected at health facility in this region is followed up to the household level, investigated, and all households members treated accordingly. Furthermore, fighting malaria in all its forms and addressing emerging threats from insecticides and anti-malaria resistance require forming alliance through cross-border collaboration initiatives.
Merci à la Gambie, merci à la Gambie. Le Kenya a la parole, le Tchad se prépare.
Thank you, Chair. Kenya welcomes the technical paper on strengthening Africa's health security and commends the focus on enhancing event detection, build resilient systems, and fostering partnerships against malaria. Malaria remains a major public health threat in Kenya. In response, we have aligned our national strategies with the WHO Global Technical Strategy for Malaria and High Burden to High Impact approach through digitalized surveillance and community thresholds and predictive analytics. We have improved early detection and response to outbreaks, particularly in endemic regions. The RTTS malaria vaccine has been rolled out in 10 counties, reaching over 10 million children under 5, significantly reducing severe cases. We are also deploying next generation dual active ingredient insecticide treated nets and enhancing digital platforms for vector surveillance. To build resilience, Kenya has scaled up community health services, strengthened primary care networks, and integrated supply chain tools to reduce stockouts. Our end malaria mobilizes private sector supports and domestic finance to competent donor funding. We urge continued support from WHO partners through technical assistance, resource mobilization, action to combat drug insecticide resistance and prevent cross-border spread. I thank you, Chair. Asante sana.
Merci au Kenya. Le Tchad a la parole et le Mozambique se prépare. Le Tchad.
Merci, Madame la Présidente. Nous avons un souci avec l'ordinateur. Si on peut repasser après. Merci.
Il n'y a pas de problème. Donc, le Mozambique a la parole et l'Afrique du Sud se prépare.
Muito obrigado pela palavra, Sr. Presidente, e todo o protocolo observado. Malária continua sendo grande problema de saúde pública em Moçambique. O inquérito, Moçambique é dos 5 países da região africana com maior número de casos de malária. O inquérito demográfico de saúde de Moçambique mostra que a prevalência da malária em Moçambique é de 32%. Apesar desta prevalência, é importante realçar que reduzimos a mortalidade pela malária em cerca de 2%. O Ministério da Saúde dispõe de um plano estratégico nacional da malária 2023-2030, o qual contempla atividades e metas a serem cumpridas rumo à eliminação da malária. Apesar dos progressos alcançados até o momento, vários desafios se impõem ao país, dentre os quais podemos destacar a resistência antimicrobiana, a insuficiência de recursos humanos e de diagnóstico, as alterações climáticas e entre a resistência também dos vetores aos inseticidas. Por isso, Moçambique continua a advocar estratégias face à resistência de vetores aos inseticidas, mas também intensificar a informação, educação e comunicação com engajamento a todos os níveis, e reforçar a cadeia de abastecimento de medicamentos a todos os níveis e também fortalecer o Sistema Nacional de Saúde. Muito obrigado pela atenção dispensada.
Merci au Mozambique. L'Afrique du Sud a la parole et le Congo se prépare.
Thank you, Madam Chair. The global fight against malaria faces significant hurdles, and tragically, it is the African continent that suffers the most. Globally, in 2023, the number of malarial cases estimated 63 million, and our continent accounted for an alarming 94% of all cases and 95% of all deaths. Malaria is preventable and curable, and increased efforts are dramatically reducing the malaria burden in many places. We therefore fully endorse the proposed actions presented in the resolution, which call upon strengthening primary health care supply chains and data systems, scale up resistance management and community engagement, mobilize domestic resources, and foster multi-sectoral collaboration. However, Chair, based on our history in South Africa and experience with malaria control, South Africa wants to add a note of caution, particularly regarding the transition away from indoor residual spray with DDT. We were one of the first countries that phased out DDT in residual spray in 1996 due to environmental concerns. This decision led to a devastating epidemic, where cases skyrocketed, resulting in tens of thousands of infections and hundreds of deaths, especially of pregnant women and children, including even cerebral malaria. It was only reintroduction of DDT in residual spray that brought it under control. We therefore propose that in the short term, while we work towards finding alternatives, the African region should consider developing the capacity to manufacture DDT. This will reduce our reliance on single global manufacturer who always threaten to quit or to stop manufacturing. We need to ensure a consistent supply to protect our people while we transition to safer methods. Thank you.
Merci à l'Afrique du Sud. Le Congo a la parole et le Burkina Faso se prépare.
Madame la Présidente, le Congo salue le rapport présenté sur la lutte contre le paludisme et remercie l'OMS ainsi que d'autres partenaires, le Fonds mondial, Rollback Malaria, ALMA pour leur appui constant. En République du Congo, l'incidence du paludisme est restée pratiquement stable. 2015 cas pour 1000 habitants en 2015, 2012 cas en 2024. Cela démontre que malgré les efforts considérables, nous devons accélérer et diversifier les interventions au Congo. Le Congo a déjà mis en place plusieurs mesures essentielles, la distribution gratuite des moustiquaires imprégnés, tant en routine qu'en campagne de masse, le traitement préventif intermittent chez les femmes enceintes, la chimioprévention saisonnière introduite en 2015 pour les enfants de moins de 2 ans, des actions communautaires de lutte antivectorielle ainsi que des études régulières de résistance conduites par la Fondation congolaise pour la recherche médicale. Par ailleurs, la surveillance épidémiologique s'est renforcée avec l'utilisation des cadres de score conformément aux orientations de ALMA. Cependant, l'absence de baisse significative de l'incident démontre que les défis persistent. Le Congo prépare donc l'introduction de 2 interventions supplémentaires, la vaccination et la pulvérisation intradomiciliaire. Nous considérons également que la surveillance de la résistance des vecteurs aux insecticides et les parasites antiparasites doit être mieux intégrée au niveau régional en s'appuyant sur déjà des capacités techniques dans ce domaine. Enfin, nous insistons sur la nécessité de maintenir et diversifier la mobilisation de ressources pour garantir la durabilité de la lutte. Le Congo réaffirme ainsi son engagement à contribuer à l'atteinte de la cible 3B des objectifs de développement durable d'ici 2030 et rappelle que c'est une action collective intégrée et durable que nous pourrons vaincre le paludisme sur notre continent. Madame, je vous remercie.
Merci au Congo. Le Burkina Faso a la parole, le Niger se prépare.
Madame la Présidente, distinguée déléguée, la délégation du Burkina Faso félicite le secrétariat pour la qualité de son rapport et salue les efforts conjugués de l'OMS et de tous les autres acteurs pour accélérer les progrès vers l'atteinte des cibles fixées à l'horizon 2030 dans le cadre de la stratégie mondiale de lutte contre le paludisme 2016-2030 et les objectifs de développement durable. Face au fléau du paludisme, le Burkina Faso déploie une stratégie intégrée de lutte contre le paludisme dont les actions majeures sont les suivantes. La distribution gratuite tous les 3 ans des moustiquaires imprégnés avec une couverture de plus de 90% du territoire national malgré le contexte sécuritaire et humanitaire. Ces moustiquaires étant à double principe actif depuis 2025, cela en vue de réduire la résistance aux insecticides. L'introduction du vaccin antipaludique en 2023 et sa généralisation courant août de cette année 2025. L'organisation des campagnes de chimioprévention du paludisme saisonnier, la prise en charge des cas, les tests de diagnostic rapide et les thérapies à base d'artémisine ont été largement disponibilisés. Nous avons aussi lancé tout dernièrement la brigade Labal pour l'assainissement du cadre de vie qui va constituer une importante mesure pour catalyser la lutte. Sur le plan institutionnel, le programme national de lutte a été transformé en secrétariat permanent directement rattaché au cabinet et nous venons de mettre en place le comité national de lutte contre le paludisme qui est un comité multisectoriel pour davantage mettre en avant les facteurs environnementaux qui sont favorables à la lutte contre le paludisme. Pour terminer, ma délégation prend note des mesures proposées et exhorte l'OMS à poursuivre ses efforts de renforcement de la mobilisation des ressources, de l'assistance technique ainsi qu'au soutien à la coordination des interventions. Je vous remercie.
Merci au Burkina Faso. Le Niger a la parole et l'Éthiopie se prépare.
Merci, Madame la Présidente. Madame la Présidente, le Niger fait partie des 11 pays d'une charge élevée à un fort impact qui représente à eux seuls 70% de morbidité et 70% de mortalité. Le Niger, avec l'appui de ses partenaires, multiplie les efforts pour répondre présent à l'objectif d'élimination du paludisme à l'horizon 2030. Ces efforts se traduisent notamment par un fort engagement politique au plus haut niveau et ont permis la mise en œuvre des stratégies suivantes. D'abord, la lutte antivectorielle, les campagnes de distribution de couverture universelle en Melda. Il y a eu une distribution de plus de 15 millions de moustiquaires donc, à travers le pays. Les interventions de prévention spécifiques également, notamment la chimioprévention du paludisme saisonnier chez les enfants de 3 à 58 mois, 59 mois, le traitement préventif du paludisme intermittent, la vaccination avec les vaccins contre le paludisme dans 12 districts du pays, la prise en charge des cas confirmés. Le gouvernement du Niger a rendu la prise en charge gratuite du paludisme pour toutes les populations sans aucune discrimination. La communication pour un changement de comportement a été faite en vue de l'implication et l'adhésion des populations à toutes les interventions. Cependant, malgré ces efforts, force est de constater que le nombre de cas ne diminue pas d'année en année. C'est pourquoi le Niger a décidé de matérialiser l'adhésion à la déclaration donc, de Yaoundé, décidé cette année pour la CPS de passer de 67 districts à 72 et de renforcer la lutte contre les vecteurs. Le Niger a décidé du passage à l'échelle à la vaccination aux autres districts. Je vous remercie de votre attention.
Merci au Niger. L'Éthiopie a la parole et Eswatini se prépare.
Thank you, Honorable Madam Chair. We would like to express our sincere appreciation to the Secretariat for preparing this comprehensive and timely technical paper. In Ethiopia, malaria remains one of the major public health and socio-economic problems, with 69.1% of the population at risk of malaria. Ethiopia initiated the Subnational Malaria Elimination Plan, intensifying efforts in enhancing coordination, resource mobilization, supply chain management of malaria commodities, public health emergency response mechanisms, vector control and surveillance of drug resistance. Efforts are also underway to initiate the anti-malarial vaccine in children below 5 years of age in selected intervention areas. Despite the positive achievements, the geographical expansion of the new and potent vector, the high-level resistance of vectors to insecticides, suboptimal usage of interventions by target communities, and shortage of complete and timely data for evidence-based decision-making are also remain as a challenge and among the reasons for the surge. Ethiopia believes that the current situation warrants a united front and collaboration more than ever. Ethiopia stands ready to work on the proposed actions and call for the continued support from WHO and partners. Thank you.
Merci à l'Éthiopie. Eswatini a la parole et la Guinée équatoriale se prépare.
Thank you, Honorable Chair. The African region bears about 94% of global malaria cases and 95% of deaths. Yet progress towards the Global Technical Strategy GTS 2030 targets is off track for a sizable number of our member states. Challenges such as weak health systems, humanitarian crisis, inadequate domestic funding, climate change, insecticide and drug resistance, and weak coordination continue to retard progress in the region. The document presented proposes actions that include strengthening primary health care-based malaria services, securing supply chain systems, scaling up malaria surveillance, and mobilizing domestic resources, among others. Eswatini is among the 8 countries earmarked for elimination of malaria, E8, and has made strides towards ending malaria as a public health threat. While malaria elimination remains a reachable target for our country, progress is slow due to the risk of resurgence of malaria cases through cross-border migration and importation from neighboring endemic areas. In a bid to ensure a sustainable malaria response, Eswatini has established the End Malaria Fund that has been key in mobilizing domestic and private sector funding for the malaria response. This sustainable funding is earmarked for scaling up malaria surveillance, strengthening border screening, and integrating climate risks data into malaria preparedness. Eswatini endorses the proposed actions in the document and recommendations and recommends strong cross-border collaboration between member states and sustaining financing for surveillance and vector control in border areas.
Guinée équatoriale a la parole et la République démocratique du Congo se prépare. Guinée équatoriale.
Merci, Madame la Présidente. Nous félicitons le secrétariat pour l'élaboration de ce document soumis au comité régional pour lutter contre le paludisme à l'horizon 2030. Au cours de ces dernières années, le paludisme s'est maintenu comme la maladie la plus répandue et la deuxième cause de mortalité en Guinée équatoriale. Dans la région insulaire du Bioko, où se trouve la capitale Malabo, d'importants progrès ont été réalisés pour la réduction de l'incidence de la malaria grâce aux interventions mises en œuvre par le Programme national de lutte contre le paludisme du ministère de la Santé, mises en œuvre de façon continue depuis 2004, avec l'appui financier des partenaires du secteur pétrolier et du gouvernement de la Guinée équatoriale. Grâce à ces interventions, la parasitique du paludisme sur l'île de Bioko a été réduite à 16,9% en 2024. En revanche, dans la région continentale du pays où ces interventions ont été interrompues ces dernières années, la parasitémie du paludisme est restée beaucoup plus élevée, atteignant 59%, alors que certaines zones rurales atteignent même 70 à 76% de la parasitémie. En raison de cette forte charge de morbidité, la prévention et le contrôle du paludisme ont toujours été constitués une priorité au sein de la planification stratégique nationale de la Guinée équatoriale. En 2023, le ministère de la Santé et du Bien-être social a publié un plan stratégique de lutte contre le paludisme 2024-2028 qui établit un cadre d'intervention combinant le contrôle et la prévention du vecteur à travers des campagnes massives de pulvérisation intradomiciliaire associées à la distribution de moustiquaires imprégnés des insecticides de longue durée, le renforcement du diagnostic, de la prise en charge et du traitement des cas, la mobilisation sociale et le changement de comportement et l'amélioration du système de surveillance et d'évaluation. L'objectif fixé par ce plan est de réduire à 50% l'incidence et la mortalité du paludisme d'ici 2028 par rapport au niveau du...
Merci, le temps. Merci à la Guinée équatoriale. La République démocratique du Congo a la parole et Zambie se prépare. Merci.
Merci, Madame la Présidente. La République démocratique du Congo approuve le cadre pour faire face aux menaces et mobiliser l'action collective pour atteindre les objectifs de lutte contre le paludisme et lui en remercie. Le paludisme continue de demeurer un problème majeur de santé publique en République démocratique du Congo. Il constitue la première cause de morbidité et de mortalité dans la population générale et chez les enfants. L'RDC a enregistré plus de 27 millions de cas de paludisme durant l'année dernière. Parmi eux, 48,7 concernaient les enfants de moins de 5 ans, soit près de 13 millions de cas. Pour lutter contre ce problème de santé publique, la RDC a mis en place des mesures de prévention classiques, à l'instar de la distribution gratuite des moustiquaires imprégnés d'insecticides, le traitement préventif chez la femme enceinte, l'administration de la chimioprévention saisonnière. Pour compléter ce paquet d'interventions, et suite à une charge accablante de cette maladie chez les enfants, le gouvernement de l'RDC, à travers son programme national de lutte contre le paludisme et celui du programme élargi de vaccination, a introduit le vaccin antipaludique R21 comme intervention spécifique visant à protéger les enfants de moins de 5 ans contre le paludisme depuis le mois d'octobre 2024, en administrant plus de 693 500 doses dans les 31 zones de santé de la province du Congo central, en espérant étendre cette vaccination d'ici 2026 dans 9 autres provinces prioritaires. L'RDC exprime ses vifs remerciements aux différents partenaires, dont l'OMS, pour l'accompagnement tant technique que financier dans la lutte contre le paludisme. Je vous remercie.
Merci à la République démocratique du Congo. Zambie a la parole et l'Ouganda se prépare.
Thank you, Chairperson. Zambia remains malaria remains a disease of public health concern in Zambia. We therefore support the ambitious targets set by the World Health Organization because they will definitely help us achieve what we need to be achieving as a country. In Zambia, malaria elimination has been hampered by several serious challenges. Among these are the growing resistance of mosquitoes to commonly used insecticides, which diminishes the effectiveness of insecticide-treated nets, and indoor residual spraying. Financial gaps. We continue to face financial gaps in the implementation of our malaria intervention. Zambia is now faced with also limited resources, like I've alluded to, affecting the coverage and program sustainability. We are also facing a lot of challenges as a result of climate change, leading to expanded mosquito breeding habitats. This was considered a low-risk area, but as a result of that, because we're just having so many places where mosquitoes are breeding, so this is a huge risk. Zambia remains committed to the 2030 malaria elimination agenda. Despite these challenges, we continue to mobilize resources, strengthen surveillance, adopt innovative tools such as new generation of insect-treated nets, enhance community strategies, and integrate climate-resilient interventions into malaria programming. Furthermore, we recognize the need for regional solidarity in combating this disease. Therefore, we remain open to enhance cross-border cooperation in surveillance, vector control, and knowledge sharing.
Merci à la Zambie. Et voilà. L'Ouganda, la parole, et la République centrafricaine se prépare. L'Ouganda. La République centrafricaine a la parole et le Bénin se prépare.
Merci, Madame la Présidente. La République centrafricaine félicite le secrétariat pour la qualité de son rapport et voudrait mentionner que le paludisme demeure la première cause de consultation et de mortalité des enfants de moins de 5 ans en République centrafricaine. L'incidence du paludisme est passée de 351 pour 1000 habitants en 2015 à 310 en 2014. La mortalité de 122 pour 100 000 habitants en 2014 à 92 pour 100 000 en 2023. Malgré ces progrès réalisés, le pays reste au-delà des cibles fixées par l'OMS. En réponse à cette situation, des actions courageuses sont entreprises Je voudrais citer, entre autres, la mise en place des cadres stratégiques, dont le plan stratégique 2024-2028, la politique et le plan stratégique de l'engagement communautaire, la formation d'environ 4000 agents de santé communautaire, d'environ 2000 chefs de villages et quartiers sur les principales stratégies de lutte contre le paludisme en milieu communautaire, l'introduction du vaccin antipaludique dans le programme élargi de vaccination, la création d'une ligne budgétaire nationale dédiée couvrant l'achat de réactifs et des antipaludiques. Malgré ces efforts, la République centrafricaine reste confrontée à des défis marqués par l'émergence de la piqûre diurne des moustiques, la résistance aux insecticides. Nous appelons à une solidarité accrue et à une mobilisation renforcée des ressources pour accélérer la marche vers l'atteinte des cibles fixées, conformément à la stratégie régionale de l'OMS. La République centrafricaine approuve le rapport présenté et invite les États membres à l'adoption des stratégies proposées. Je vous remercie.
Merci à la République centrafricaine. Le Bénin a la parole et Botswana se prépare.
Merci, Madame la Présidente. Le Bénin salue la pertinence et l'actualité du rapport présenté qui met en lumière les enjeux de l'atteinte des objectifs de la lutte contre le paludisme à l'horizon 2030. Quoique encore élevé, le Bénin connaît une baisse de l'incidence et des décès du paludisme ces 5 dernières années. L'incidence a baissé de 41% entre 2022 et 2024. La mortalité due au paludisme a baissé de 37% dans la même période. Ces résultats sont le fruit de la mise en œuvre des stratégies complémentaires, notamment la distribution systématique chaque 3 ans de moustiquaires imprégnés d'insecticides, dont celle tenue en 2023 a permis de distribuer 9 millions de moustiquaires, soit une couverture des ménages de 92,27%. Cette campagne a été digitalisée depuis 2022, ce qui a permis un meilleur contrôle des opérations de dénombrement des ménages, l'extension de la chimioprévention saisonnière à 1,2 million d'enfants de 3 à 59 mois, l'introduction de la vaccination antipaludique en 2024 au profit des enfants de 6 à 24 mois, avec une couverture de 87% pour la première dose et 50% pour la 3e dose. Les stratégies en cours intègrent la surveillance renforcée de la résistance aux insecticides et médicaments. Le Bénin réaffirme son engagement et exhorte les pays de la région africaine de l'OMS à l'action collective pour atteindre les objectifs de lutte contre le paludisme à l'horizon 2030. Je vous remercie, Madame la Présidente.
Merci au Bénin. Le Botswana a la parole et la Tanzanie se prépare. Botswana.
Thank you, Madam Chairperson. As Botswana, we are noting that this call couldn't have come at a more critical time for us and indeed for the continent. Botswana was well on track to meet its targets to eliminate malaria. However, due to unprecedented amounts of rainfall in the past year, we found ourselves with a more than 10-fold increase in malaria cases, including in areas that had not had malaria for the past 15 years. Botswana, as one of the countries earmarked for elimination by 2030, aims to address growing threats that can jeopardize malaria elimination efforts, including insecticide and drug resistance, climate change, and fragile healthcare systems. This challenges call for collective key strategies and actions through strengthened health systems by investing in capacity building for healthcare workers, particularly community healthcare workers, revitalizing primary healthcare, strengthening the malaria epidemic containment mechanisms, and improving supply chains to ensure universal access to quality malaria prevention and treatment services. There is the need for increased funding and resource mobilization to address the financial gap. Botswana's malaria response has been financed mostly by the government, but we will explore innovative funding mechanisms and partnerships to support malaria programs. The multi-sectoral collaboration to engage various sectors, including health, local government, and traditional affairs, environment, finance, private, international partners, and other civil society organizations is vital for a comprehensive approach to malaria control. We appreciate, Chairman, that community engagement and participation is vital, and we welcome the report. Thank you.
Merci, Botswana. Tanzanie a la parole et Madagascar se prépare.
Thank you, Chair. The United Republic of Tanzania reaffirms its commitment to addressing all threats to malaria control efforts and reducing the burden of malaria morbidity and mortality. Our robust malaria surveillance system guides key interventions, including monitoring disease burden, treatment efficacy, and vector dynamics. Based on evidence, we shifted from pyrethroids-based insecticide nets to piperonyl butoxide nets, and we are also planning to introduce dual active ingredient nets in 2025. Furthermore, we're also planning to change our first-line malaria medicine from artemether lumefantrine to artesunate amodiaquine as interim measures towards use of multi-first-line strategy. Chairperson, to improve the access, we have scaled up malaria by providing malaria testing and treatment through community health workers in underserved areas, ensuring early diagnosis and care. Tanzania recognizes the role of climate variability in transmission and has begun engaging research institutions to integrate climate data into malaria programming. Amid declining international financing, the government has increased domestic funding and established the End Malaria Council to mobilize local resources. Chairperson, we thank WHO and partners for their continued support and fully align with the technical paper's recommendations. I thank you.
Merci beaucoup à la Tanzanie. Madagascar a la parole et la Mauritanie se prépare.
Merci, Madame la Présidente. Madagascar salue l'action collective régionale partagée par le secrétariat sur la lutte contre le paludisme. Le paludisme demeure l'un des principaux défis de santé publique à Madagascar, présentant la cause majeure de morbidité et de mortalité, en particulier chez les enfants de moins de 5 ans et les femmes enceintes. À l'intérieur du pays, les profils épidémiologiques sont différents d'un district à un autre. L'année dernière, Madagascar a mené des campagnes de distribution de masse de moustiquaires imprégnés d'insecticides. Un programme de prévention spécifique est dédié couramment aux femmes enceintes dans le cadre de soins de santé primaire. Malgré les efforts réalisés en termes de surveillance et de prévention, Madagascar n'a pas atteint les objectifs d'élimination du paludisme. La situation est aggravée par plusieurs facteurs, entre autres la situation géographique même de Madagascar, la dépendance financière vis-à-vis du financement extérieur, la résistance aux insecticides et aux traitements, les effets du changement climatique. Face à ces défis, Madagascar s'aligne sur les orientations régionales et mondiales et s'engage à déployer les innovations, à intensifier la mobilisation des ressources, renforcer la résilience face aux crises et au climat et favoriser la coopération régionale et internationale. On note que le paludisme fait partie des maladies mises en œuvre dans le cadre d'interventions multisectorielles avec l'approche One Health. Ainsi, Madagascar réaffirme son engagement à contribuer à atteindre les objectifs régionaux et mondiaux de réduction de 90% de l'incidence et de la mortalité due au paludisme d'ici 2030, en s'inscrivant pleinement dans la dynamique du cadre intégré de lutte contre les maladies à transmission vectorielle en Afrique et de la déclaration de Yaoundé pour mettre fin aux décès dus au paludisme. Je vous remercie.
Merci Madagascar. Mauritanie a la parole et la Guinée se prépare.
Merci Madame la Présidente. La Mauritanie félicite le secrétariat sur la qualité du document AFR RC 7508. L'année dernière, notre pays a traversé une épreuve difficile avec une épidémie de paludisme sans précédent. Fort de cette expérience, nous avons cette année mis en œuvre un plan de prévention rigoureux pour protéger nos concitoyens et éviter toute nouvelle épidémie. En effet, après la vague épidémique 2024, le pays a entrepris une série d'actions parmi lesquelles on peut citer la transformation du programme national de lutte contre le paludisme en programme d'élimination du paludisme, la mise en place d'une stratégie de riposte, l'acquisition de moustiquaires, environ 1 200 000 distribués, la formation sur les nouvelles directives de prise en charge du paludisme, une formation des formateurs nationaux, comprenant formation de formateurs régionaux, formation interrégionaux, la formation en cascade, l'impression de nouvelles directives, la distribution des médicaments et des TDR au niveau de toutes les structures de santé, parallèlement à une campagne de sensibilisation et de communication. Une campagne de CPS dans les 3 Mokata'a les plus exposés. L'instauration de la surveillance générale. Ainsi, la Mauritanie approuve le document en question et invite les pays à l'adopter. Je vous remercie.
Donc, merci à la Guinée, à la Mauritanie, la Guinée a la parole et le Tchad se prépare. L'Ouganda, on a vu, vous êtes revenu, mais on vous a remis en bas. Vous allez suivre, vous allez attendre. OK, merci.
Merci, Madame la Présidente. Mesdames et Messieurs les représentants des États membres, chers partenaires. En Guinée, le paludisme reste la première cause de morbidité et de mortalité. Des progrès importants ont été réalisés ces dernières années grâce à des interventions ciblées. Distribution de moustiquaires imprégnés d'insecticides, MILDA, chimiothérapie préventive saisonnière, CPS, généralisation des tests de diagnostic rapide, TDR, et utilisation des traitements à base d'artémisinine, ACT. Ces efforts ont permis de faire passer la prévalence 5. La Guinée a intégré le vaccin RTSS du paludisme dans son programme élargi de vaccination. Cependant, plusieurs menaces persistent. Dépendance au financement extérieur, risque croissant de résistance aux insecticides et aux antipaludiques. Impact des changements climatiques et vulnérabilité du système de santé face aux crises sanitaires. Face à ces défis, la Guinée recommande le maintien d'un fort engagement politique, le renforcement de la mobilisation des ressources nationales, l'anticipation des résistances et l'introduction d'outils innovants. La consolidation du système de santé et la mise en œuvre d'approches multisectorielles et communautaires. La Guinée réaffirme son soutien à la proposition AFR RC 75-8 de l'OMS et appelle une mobilisation renforcée pour atteindre les cibles de la stratégie technique mondiale de l'horizon 2030. Je vous remercie.
Merci à la Guinée. Le Tchad a la parole et le Nigeria se prépare.
Merci Madame la Présidente. Le Tchad remercie le secrétariat de l'OMS pour ce rapport très riche et chargé de défis pour notre continent et pour le Tchad en particulier. Au Tchad, le paludisme est endémique avec une prévalence de 41% dans la population générale. L'incidence du paludisme était de 129 cas pour 1000 personnes en 2024. Cette maladie demeure le premier motif de consultation et la première cause de décès hospitalier sur 27% environ. Le programme national de lutte contre le paludisme a renforcé ses actions par l'introduction du vaccin antipaludique en octobre 2024, la mise en œuvre des campagnes de chimioprévention du paludisme saisonnier et la distribution des moustiquaires de routine pour les enfants et les femmes enceintes, ce que nous considérons comme un des piliers de la prévention. Le Tchad réaffirme son engagement ferme à éliminer le paludisme d'ici 2030, conformément aux orientations du plan stratégique national 2024-2028. Cet objectif ambitieux traduit notre volonté de protéger durablement nos populations contre cette maladie endémique. Dans cette perspective, nous appelons à une meilleure intégration des services de santé primaires et à une surveillance renforcée des menaces biologiques. Une approche coordonnée et multisectorielle est essentielle pour anticiper les risques et améliorer la réponse sanitaire. Le Tchad invite à une coopération régionale renforcée, notamment dans les zones frontalières affectées par les crises humanitaires qui impactent très sérieusement toute la planification. La coordination entre pays voisins est indispensable pour une lutte efficace contre le paludisme et les autres menaces sanitaires. Les différents efforts consentis se heurtent à des défis majeurs qui sont l'insuffisance des ressources financières, le faible accès aux soins dans les zones reculées et la résistance croissante aux outils traditionnels de lutte. Ces obstacles compromettent la progression vers l'élimination du paludisme. C'est pourquoi nous sollicitons le soutien renforcé de l'OMS ainsi que des partenaires techniques et financiers pour accompagner ces actions et concrétiser l'objectif d'un Tchad sans paludisme d'ici 2030. Le Tchad prend note du rapport et invite les autres pays à en faire de même. Je vous remercie.
Merci au Tchad. Le Nigeria a la parole et les Comores se préparent.
Thank you, Chair. Despite being a preventable and treatable disease, malaria continues to pose a grave challenge across the continent. In Nigeria, it remains one of the leading causes of illness and death, accounting for more than 60% of outpatient consultations. These figures are deeply concerning and unacceptable, especially given that the tools and knowledge required to prevent these deaths are already available to us, and they underscore the urgent need for renewed and collective commitments across the entire region. The impact of malaria is not limited to health. It has profound economic and development consequences, draining an estimated $1.1 billion annually from the Nigeria's GDP. Clearly, addressing malaria is both a public health and a development imperative. We acknowledge that significant progress has been made in the past 15 years, a milestone worth celebrating. However, progress has slowed in recent years, and new challenges have emerged that threaten to erode this gain. As a government, we are exploring innovative solutions to mitigate these emerging threats. Through initiatives such as Rethinking Malaria Strategy and the establishment of Malaria Advisory on Malaria Elimination in Nigeria, we are aligning interventions more effectively with local contexts. We recognize the indispensable role of partnerships. Our collaboration with communities, development partners, and the private sector remains central. Nigeria is committed to sustaining momentum towards malaria elimination, but no country can succeed in isolation. Malaria knows no borders, and it will require shared responsibility, solidarity, and sustained investments to achieve our collective 2030 targets. We therefore call for strengthened regional collaboration, innovative financing, and continued support from all stakeholders to ensure that malaria becomes a disease of the past. Thank you, Chair.
Merci au Nigeria. Que Comores la parole, la Namibie se prépare.
Madame la Présidente, l'Union des Comores adhère aux mesures proposées aux États membres. Mettre en œuvre les mesures suivantes pour galvaniser la lutte contre le paludisme et accroître les efforts de renforcement du système pour rendre les programmes résilients. À cet effet, l'Union des Comores participe actuellement au système d'achat groupé et elle travaille déjà sur l'amélioration des informations sanitaires efficaces et fiables en utilisant les nouvelles technologies dans plusieurs programmes. L'extension de l'utilisation de ces nouvelles technologies pour la surveillance du paludisme par un système de géolocalisation des cas est la prochaine étape avant le deuxième trimestre 2026. Également, l'introduction de la technique GenDrive est en réflexion afin de pouvoir contrôler efficacement la situation du paludisme dans notre pays. Ainsi, le programme national de lutte contre le paludisme organise de manière régulière, chaque 2 ans, une étude sur l'efficacité thérapeutique des médicaments antipaludiques en utilisant les procédures de l'OMS. Nous allons donc poursuivre ces efforts pour le renforcement de la mobilisation des ressources domestiques et auprès des partenaires pour la lutte antipaludique. L'Union des Comores présente un faciès épidémiologique différent selon les îles. Ainsi, sur les 3 îles, 2 d'entre elles sont en phase d'élimination depuis plus de 5 ans, tandis que la 3e reste en phase de contrôle. Compte tenu des mouvements des populations d'une île à une autre, des efforts colossaux doivent être déployés pour éviter la réintroduction du paludisme dans ces 2 îles déjà éliminées. L'Union des Comores encourage donc la mise en œuvre d'initiatives multisectorielles phares, notamment l'initiative E2025, et elle va continuer à travailler sur ces nouvelles stratégies innovantes pour accélérer l'élimination du paludisme dans notre pays. Je vous remercie.
Merci aux Comores. La Namibie a la parole et les îles Maurice se préparent.
Thank you so much, Madam Chair, and good morning, everybody. We definitely thank the Secretariat for the comprehensive reports, for the quality reports that are put at our disposal, and no doubt this set of guidelines, this set of documents will aid and assist our national intervention strategies. We acknowledge the fact that achieving malaria-free Africa demands unwavering commitment and innovative approaches at the country level. Namibia has demonstrated this potential, Madam Chair, because way back in 2019,
One of our health districts, the Korihas Health District in the central western part of Namibia, has demonstrated that success and has become a beacon of success for earning the SADC Simon Konene Award in 2024, marking 3 consecutive years of 0 malaria cases. This achievement shows that it is possible. If we have targeted interventions and dedicated community engagement, it is possible to eliminate malaria from our midst. But despite that triumph, Madam Chair, and early ambitions, malaria remains a persistent public health challenge for Namibia, and our comprehensive interventions entails the toolkits as other member states have put on the table. It's the IRS spraying, it's the insecticides treated net, the long-lasting insecticidal treated nets in the high-risk areas, the surveillance and all the mechanisms. But we continue to contend with the outbreak of malaria. We have seen this in 2024, continuing to this year, and our toolkits is what we will continue to mobilize to deal with this. So in conclusion, Madam Chair, it is Namibia's commitment to continue deploying these measures, and we look forward to the collaboration with member states and other states.
Merci à la Namibie. Les Maurice ont la parole et l'Ouganda se prépare.
Thank you, Chair. Mauritius remains malaria-free since 2012, but continues to face the risk of imported cases from endemic countries due to travel and labor migration. Active surveillance is conducted by the Public Health Inspectorate Unit for passengers arriving from malaria endemic countries, including screening, blood smears, and rapid diagnostic testing. Robust surveillance at points of entry at the airport and the seaport includes fever screening, passenger locator records, and prompt testing of symptomatic passengers. Vector control measures are sustained throughout the year, including larviciding, residual spraying, and source reduction, particularly in areas with migrant worker accommodation. We also have rapid response team who are activated for immediate investigation and containment of any suspected malaria case. Collaboration with WHO and neighboring countries for cross-border surveillance and technical support remains essential to prevent re-establishment of malaria. Thank you, Chair.
Merci, Osil Maurice. L'Ouganda a la parole.
Thank you, Chair. Malaria remains Uganda's most significant public health and social economic challenge, accounting for 30 to 50% of outpatient visits and costing the nation an estimated $577 million annually at health expenditure and low productivity. Despite the progress made in the last 25 years, including an 80% reduction in malaria prevalence, the recent years have marked by stalled progress and devastating epidemic in 2022, which saw over 3.3 million additional cases. This reversal underscores the fragility of the past gains and the urgent need for the shift from malaria control to malaria elimination. The Ministry of Health has a vision for malaria-free Uganda to enable socio-economic transformation. Interventions are deployed through a decentralized, stratified, and data-driven model, recognizing Uganda's highly heterogeneous malaria transmission landscape. Key interventions including high-quality diagnostics, effective treatment at community level, and facility recent introduction of malaria vaccines, chemoprevention for vulnerable population, integrated vector management using insecticide-treated nets, indoor reducer spraying, and larval source management have been deployed. It's anticipated that the deployment of these interventions to scale will lead the country towards malaria elimination. However, there is a number of growing biological and weather threats, and the resource envelope shrinking. The government of Uganda has re-energized advocacy towards both domestic and international resource mobilization, including through innovative financing mechanisms to sustain financing for malaria whilst deploying robust accountability mechanisms and efficiency. I thank you.
Merci à l'Ouganda. Donc, merci, distingués délégués. Je pense que tous ceux qui voulaient parler ont eu à parler. Et là, j'invite les représentants des États membres d'autres régions, d'institutions du système des Nations Unies et d'autres organisations intergouvernementales qui souhaitent s'exprimer à lever leur plaque nominative. Et je vous rappelle que vous avez 2 minutes par intervention. Merci. La parole est à Alma.
Thank you, Madam Chair. African Leaders Malaria Alliance welcomes the framework addressing threats, galvanizing collective action to meet the 2030 malaria targets. Now is the moment to confront a hard truth. We are not on track and we face a perfect storm of threats, insufficient resources, rapid population growth, climate change, biological risks, and humanitarian crisis. Our heads of states are committed to malaria elimination on the African continent. The AU summit in February endorsed the AU roadmap to 2030 and beyond, envisioning accelerating the catalytic framework on ending HIV and TB, as well as eliminating malaria. It is imperative that Africa secures the resources necessary to combat malaria with renewed energy, scaling up budget allocation, innovative financing through national and malaria councils and funds, which AMA is ready to support countries to set up. We urge countries to call for an IDA Malaria Booster 2 program, as well as leveraging platforms like the Green Climate Fund. African countries must support the replenishment of the Global Fund. Strategic data must guide decisions so that the most impactful packages of interventions are tailored subnationally to maximize impact. Scorecard tools can strengthen accountability and action at all levels and help ensure that country commitments are realized. Working together through the Yaoundé Declaration, the ministerial champions, and this declaration, you honorable ministers are unleashing a big push that enhances the political commitment and multi-sectoral engagement and resource mobilization to target and maximize impact and foster the rapid introduction of new fit-for-purpose tools, including through local manufacturing. The time for hesitation is over. Now is the time to act with unity, urgency, and unwavering resolve. Zero malaria starts with all of us. Thank you, Madam Chair.
Merci beaucoup, Alma. Et maintenant, c'est Rollback Malaria. Vous avez 2 minutes.
Thank you, Madam Chair. Excellencies, ministers, ladies and gentlemen. Congratulations to WHO and all of you for keeping malaria high on the Africa's agenda. Thanks to our collective efforts, 12.7 million lives have been saved over the last 2 decades. Despite the progress is stalling. Drug resistance, climate change, conflict, underfunding threaten our gains. Last year, 4 billion investment was just half of what was needed. Closing the $4.3 million gap isn't just moral, it is economic. Meeting malaria targets by 2030 could boost Africa's GDP by $127 billion. We know what works. We have the tools. We applaud Africa's role in local manufacturing and strengthening its health systems. The RBM partnership in support is launching a new strategy focused on country-led leadership, sustained financing, data-driven innovation. Let's act together with agency, with solidarity to end malaria. To our partners, your support is not just saving life, it is unlocking Africa's full potential. Now is the time to step up, fully fund the fight. Let us be the generation that turns the tide, not just against malaria, but for a healthier and stronger Africa. The time to act is now. Zero malaria starts with all of us. I thank you.
Merci beaucoup. Et je comprends que plusieurs acteurs non étatiques ont demandé de faire des déclarations sur le point de l'ordre du jour. Et je les invite à prendre la parole et ils n'auront qu'1 minute. On va commencer par le réseau de recherche sur les médias africains et le paludisme, AMREN, et la Fédération internationale des associations d'étudiants en médecine se prépare.
Thank you, Madam Chair. The African Media and Malaria Research Network applauds the efforts of the WHO and different actors to eliminate malaria in Africa. Unfortunately, the disease remains one of Africa's most persistent public health challenges, claiming lives, limiting productivity, and perpetuating poverty. AMREN believes that achieving the 2030 malaria targets requires not only scientific tools and political will, but also the power of communication. Journalists amplify evidence-based messages, demystify new tools such as vaccines, and keep malaria high on the public agenda. The media gives voice to communities and help them to understand and identify issues around miscommunication, and also hold leaders accountable for the promises they make. Without strong, sustained communication and political...
Merci. Et la Fédération internationale des associations d'étudiants en médecine a la parole et la Fondation des Nations Unies se prépare. 1 minute.
Honorable Chair, distinguished delegates, we, the IFMSA, are deeply concerned that malaria remains one of the greatest failures of equitable health in our time. According to the 2024 WHO World Malaria Report, 94% of the 263 million global cases and 95% of the 597,000 malaria deaths in 2023 occurred in Africa. Over 3/4 of these deaths were among children under 5. We witnessed surging drug resistance and insecticide resistance in countries such as Zambia and Uganda, community surveillance gaps, and school absenteeism due to recurring infections. We believe youth are powerful partners, and we call on member states and WHO to designate medical students as official members of national task forces, call for and fund youth-led innovation pilots, and accelerate school-based malaria vaccine rollouts, especially in high-burden zones. This is a call not just to treat malaria, but to trust young people to lead its elimination. Thank you.
Si la Fondation des Nations Unies et Medicines for Malaria Venture se préparent.
Thank you. Honorable Chair, distinguished delegates, the United Nations Foundation celebrates the progress made in malaria control and elimination over the past 20 years, with about 2.2 billion cases and 12.7 million deaths prevented. This demonstrates that when African countries and partners collaborate, extraordinary gains are possible. Yet, as Afro's technical leaders have warned, interconnected crises threaten to reverse these achievements. We must act decisively to sustain progress and renew the fight against malaria. The UN Foundation supports Afro's call to increase investments in resilient health systems to accelerate progress on malaria control and reach the 2030 malaria targets. We also urge the international community to support the Global Fund's 8th replenishment campaign to meet its $18 billion goal to save 23 million lives between 2027 and 2029. With sufficient resources, African countries can continue driving critical progress toward malaria elimination in the region. Thank you, Chair.
Merci beaucoup. Medicine for Malaria Venture, vous avez la parole.
Medicines for Malaria Venture supports Liberia's statement, especially on the protection of pregnant women from malaria. In 2023, 12.4 million pregnant women were infected with malaria in Africa. Although intermittent preventive treatment has been shown to reduce malaria infection and improve birth outcomes, uptake has been slow. Results from an IPTP pilot project in Buyao district of Liberia demonstrates that community and civil society ownership of malaria interventions, as well as regional and national level advocacy, improves uptake of these interventions by more than fourfold. We encourage African countries to promote investments in malaria, as well as community and civil society ownership of malaria interventions. We thank the government of Liberia, the RBM Partnership, and the Christian Health Associates for their support. Thank you.
Merci beaucoup. Merci pour votre attention. Et je ne vois plus de demande de prise de parole. Et le secrétariat a-t-il des observations à faire?
And thank you, Madam Chair. We received feedback from 35 member states, which really highlight the commitment to malaria. So like once again to express our sincere thanks to all member states for this useful contribution. I'm going to summarize some of the key points that are emerging from this exchange. They can be broadly categorized into 4 to 5 areas. One is the commitment from all member states to scale up existing new interventions, be it ITN use or chemo prevention, particularly in the most vulnerable population. Two, it's the need for the commitment to new intervention, namely malaria vaccines, which have been introduced and rolled out in some of the member states. So we're going to continue providing the support to ensure that many of our member states can introduce and roll out this game changer. The third one is the need to strengthen surveillance, particularly in countries that manage to eliminate malaria. I'm referring to Cape Verde. The need to strengthen surveillance to prevent the re-establishment of malaria. The third category is really the request for technical support or technical assistance in a number of areas, such as DDT transition. This was highlighted by South Africa, vector surveillance, epidemic preparedness and response, but also the need for coming up with a support that should help countries to address the issue of drug resistance. In terms of innovative strategies, we also mentioned, I think, the need for digitalization of health campaigns, the need for digitalizing surveillance systems so as to be able to early detect and respond to malaria outbreaks. And then lastly, it's really what I can say, a call to WHO to not only strengthen regional surveillance, but also support the cross-border collaboration on malaria. So this is I'll say, a high-level summary of the discussions we've been having this morning. Thank you, Madam Chair. Merci beaucoup.
OK. Merci pour votre attention. Et devrais-je considérer que le secrétariat a pris note des observations et que le comité régional est disposé à adopter la résolution contenue dans le document AFR-LC 75-WP2 qui prévoit l'adoption des mesures proposées dans le document intitulé « Faire face aux menaces et renforcer l'action collective pour atteindre les cibles fixées pour 2030 en ce qui concerne le paludisme », tel qu'il figure dans le document AFR-RC 75-8. Il en est ainsi décidé. Merci à vous tous et toutes pour votre contribution d'importance. Et nous voici parvenus à la fin de nos délibérations sur le point 11 de l'ordre du jour. Et nous poursuivons directement avec le point 12 de l'ordre du jour qui est intitulé « Personnel de santé publique et d'intervention en cas d'urgence en Afrique. L'état des lieux au titre du pilier 2 ». Je vais vous référer au document AFR RC 75-9. Je donne la parole au docteur Abdou Salam Gueye, directeur du niveau régional pour les situations d'urgence, pour qu'il nous présente le document. Docteur Gueye, vous avez 5 minutes. Merci.
Thank you, Madam Chair. On behalf of the Secretariat, it is my privilege to introduce document IFR-RC 75-9, entitled Status of Public Health Emergency Workforce in Africa. This paper highlights the state of our health workforce, the urgent challenges we face, and the action needed to build resilience in the face of growing health emergencies. In the context, Africa's health workforce density is 1.55 per thousand population, far below the global threshold of 4.45 per thousand needed for universal health coverage. The consequences are clear. Emergencies such as COVID-19, Ebola, Mpox, cholera, Marburg, and others have exposed serious gaps in our ability to prevent, detect, and respond. Looking ahead, the situation is even more pressing. By 2030, the continent faces a projected shortfall of 6 million health workers. This threatens both essential health services and the health security of our nations. Through the Joint Emergency Preparedness and Response Action Plan, along Africa CDC, WHO Afro are preparing to improve coordination during health crisis. A key achievement is AVONC Surge, which is deployable workforce combining Africa CDC AVONC and WHO Surge to ensure rapid, skilled responses in emergency. To date, over 2,300 people are trained in 30 countries, ready to respond to their own emergency, but also to support other countries. Challenges are in several factors. Training capacity is limited, especially in outbreak response, infectious disease, rehabilitation, mental health. Many institutions lack responses and updated curriculum. Talking about training, in epidemiology, we know that there is a cultural function that have impact on the outbreak. It may be positive or negative impact. And those cultural functions, having it in a display manners, are lacking in many our training centers. Workforce planning is weak and SR system fragmented, hampering effective deployment. Retention remain poor because the salaries are low, job security is a problem, there's burnout, urban-rural disparity, and drive many skilled workers to go somewhere else they feel better. Recommendation. The report proposed practical action. Member states to expand investment in training institutions, integrate emergency preparedness and mental health into curricula, and provide fair wages, incentive, and stable contracts. Harmonize regulation and adopt a continental protocol for free movement of healthcare workers. Formalize integrated emergency medical team, AVONC, and also integrate the Global Health Emergency Corps. WHO offer technical guidance, establish regional center for excellence, support digital and e-learning platform, and work with the African Union and the African Continental Free Trade Area to harmonize certification and enhance workforce mobility. Partners, support training and retention through scholarship, fellowship, digital tools, and promote ethical recruitment and help integrate trained health workers into national system. Closing. Chair, strengthening Africa public health emergency workforce is not optional. It is central to achieve universal health coverage, safeguarding the health security of our continent. I invite the regional committee to review the technical paper and not the proposed action. Thank you.
Merci. Donc, j'invite maintenant les États membres à formuler leurs observations. Merci. Donc, la Guinée va prendre la parole et Namibie se prépare.
Merci, Madame la Présidente. Au nom de Monsieur le ministre de la Santé et de l'Hygiène publique, Son Excellence Monsieur le Président de la République de la Guinée, le général Mamadi Doumbouya, remercie son homologue de la Zambie pour l'accueil et la bonne organisation de la présente session. Par la même occasion, réaffirme sa reconnaissance et son soutien à l'OMS à travers le Bureau régional Afrique pour la qualité du rapport et la vision stratégique dans le cadre des urgences sanitaires et prend note. La Guinée, comme tous les autres pays de la
de la zone afro de l'OMS a intégré la stratégie de la surveillance intégrée de la maladie et la réponse depuis 2000 avec la première édition, respectivement révisée en 2008 et 2009. Malgré la disponibilité de guides techniques pour la surveillance intégrée de la maladie et la réponse, la Guinée reste confrontée à de façon récurrente aux épidémies et aux événements de santé publique. En vue de pérenniser l'utilisation de la stratégie de la surveillance intégrée de la maladie et de la riposte en Guinée, un plaidoyer mené en Guinée en 2018 par le Bureau régional de l'OMS a permis d'intégrer l'enseignement de la surveillance intégrée de la maladie et la réponse dans 40 écoles et institutions de formation des professionnels de la santé. Action en cours, la formation des agents de santé de premier niveau à la SMIR et la formation en cascade sur la stratégie 717 a été faite au niveau central. Le renforcement de l'ISMIR dans les formations sanitaires et dans les régions. L'intégration à grande échelle des structures sanitaires privées dans la formation en SMIR et l'utilisation efficace des outils de la SMIR du pays, dans tous les pays. Au regard des succès et des défis, la République de Guinée invite tous les pays de la région à adhérer à l'initiative des Afro à cet effet. Je vous remercie.
Merci à la Guinée, la Namibie a la parole et le Sénégal se prépare.
Thank you very much, Madam Chair. Namibia welcomes this report on the status of the public health and emergency workforce in Africa. The report highlights persistent workforce shortages in the region, with the health worker density as presented at 1.55 per 1,000 population, far below the universal health coverage threshold of 4.5, Madam Chair. Namibia recognizes this challenge and has undertaken at the country level reforms to expand the structure of its workforce to meet our national commitments. A 50% increase in the staff establishment is approved at national level to provide for human resources for health. However, the funding of this increased provisioning is only to be undertaken gradually over a medium-term period due to the limited fiscal space. Namibia continues with workforce development efforts for health security. Field epidemiology and laboratory training program, frontline and advanced tier, continue to strengthen our public health system by improving disease surveillance, enhancing outbreak response, increasing data-driven decision-making, and increased collaboration through a One Health approach. To ensure the availability of trained cadre at all levels of emergency response, the second cohort of SAGE is scheduled to be trained this year, which will include a wider professional variations. We will continue with the capacity building at all levels as we implement our improved structure with the purpose of enhancing overall capacity of the system. We thank the Secretariat, we welcome this report, and we provide and submit our support for the report, Madam Chair. Thank you.
Merci à la Namibie. Avant de passer la parole au Sénégal, je voudrais lire la liste et ceux qui ne sont pas inscrits, qui nous disent qu'on le fasse. Donc, il y a le Sénégal, le Bénin, le Kenya, Capo Verde, Seychelles, Éthiopie, Centrafrique, Côte d'Ivoire, Togo, Capo Verde, Ouganda, Madagascar, Angola, Mali, Tanzanie, Algérie, Gambie, South Sudan, Nigeria et Malawi. Est-ce qu'il y a des pays qui veulent, qui n'ont pas? Voilà, il y a d'autres pays qui sont en train de lever, qui n'ont pas été inscrits. Et après ça, on va arrêter dans le Tchad, dans les Comores, Centrafrique. Centrafrique est déjà là. Mozambique. Guinée équatoriale. Autre. Ok. À côté de Guinée équatoriale, c'est quel pays? RDC. RDC. Les autos aussi. Les autos au Kenya. Au Kenya. Madagascar. Madagascar. Ok, d'accord. Donc, le Sénégal a la parole et le Bénin se prépare.
Merci, Madame la Présidente. Messieurs et Mesdames les distingués délégués, le Sénégal a examiné avec attention le document AFRC 75-9 portant sur le personnel de santé publique en cas d'urgence en Afrique, état des lieux. Notre pays partage les défis soulevés dans le document, notamment les défis liés à la répartition équitable du personnel de santé, la formation de qualité et la fidélisation des ressources humaines en santé. Conformément à la vision de l'agenda national de transformation Sénégal 2050, qui est un Sénégal souverain, juste et prospère à l'horizon 2050, le gouvernement du Sénégal, à travers le ministère de la Santé et de l'Action sociale, travaille pour une répartition plus équitable du personnel de santé. La réflexion sur la motivation du personnel de santé dans les zones difficiles et éloignées est entamée et va bientôt porter ses fruits. Le gouvernement porte une attention particulière aux conditions d'exercice de nos agents, à leur bien-être et à leur santé mentale. Nous adhérons à la standardisation de la formation des personnels de santé avec des exigences hautes en matière de qualité. Concernant la disponibilité du personnel dans les interventions d'urgence, le Sénégal félicite le bureau régional de l'OMS pour la mise en œuvre de l'initiative SURGE. Notre pays dispose déjà d'une équipe multisectorielle et pluridisciplinaire capable de se déployer en 24 à 48 heures suivant la déclaration d'une urgence. Poursuivant nos efforts pour plus d'équité, nous mettons actuellement en place des équipes d'intervention rapide au niveau intermédiaire. Ainsi, 8 régions sur 14 disposent désormais de ces équipes pour une approche multisectorielle. Enfin, notre pays prend acte des mesures proposées. Je vous remercie, Mesdames et Messieurs, de votre aimable attention.
Merci au Sénégal. Le Bénin a la parole et Kenya se prépare.
Madame la Présidente, le Bénin salue la pertinence et l'actualité du rapport présenté et partage l'analyse du secrétariat quant aux défis persistants, notamment le défi de personnel qualifié et les inégalités de répartition géographique. Conscient de ces défis, le Bénin a engagé ces dernières années plusieurs initiatives pour renforcer son capital humain en santé publique. Il s'agit notamment des interventions suivantes: le recrutement dans la fonction publique et les recrutements sur les ressources propres des formations sanitaires, qui a permis de doubler le ratio de ressources agents qualifiés pour 10 000 habitants, le faisant passer de 6 à 12 ces 10 dernières années. Le renforcement des capacités, y compris des exercices de simulation pour une meilleure préparation des équipes d'intervention rapide. De l'utilisation progressive des solutions numériques pour la surveillance épidémiologique, la surveillance des événements à travers la mise en place de 13 000 relais communautaires et de 556 agents de santé communautaire qualifiés, et la coordination intersectorielle avec la mise en place du comité national Une seule santé pour la préparation et la réponse aux crises et urgences sanitaires au Bénin. Le déploiement progressif de mesures d'incitation différenciées suivant les zones d'affectation afin d'augmenter la couverture des zones rurales et enclavées. Le Bénin soutient pleinement les mesures proposées dans le rapport par le secrétariat et appuie leur adoption. Je vous remercie.
Merci au Bénin. Le Kenya a la parole et Cap-Vert se prépare.
Thank you very much, Chair. Kenya commends the WHO Regional Office for the report that has come in and that is very timely. A resilient and well-trained and fair distribution of health workforce is fundamental to achieve universal health coverage, which is a key agenda in the Kenyan government. Kenya has adopted a data-driven and needs-based approach to workforce planning using our health labor market analysis. And as you know, we have the National Public Health Institute in Kenya that has finalized its second National Action Plan for Health that is informed by our SPA and our JEE that was conducted last year. And it addresses the gaps in workforce tracking, coordination, surge capacity under One Health framework. Kenya has also made progress in operationalizing our surge mechanisms.
We had the training of our AVOC surge initiative that was done in 2023, and they were trained again in 2024 and now lead over 70% of our response. Finally, to strengthen our frontline service delivery, Kenya has community health promoters who have been deployed to over 100 primary healthcare centers and networks, enhancing early detection and community-level response. Chair, Kenya urges the WHO to support institutionalizing surge workforce systems, integrating mental health, developing cross-border deployment platforms, and establishing regional training hubs. Kenya remains committed to build an inclusive, emergency-ready health workforce that leaves no one behind. Thank you.
Merci au Kenya. Capo Verde a la parole et Seychelles se prépare.
Muito obrigado, senhora Presidente. Na linha do desenvolvimento centrado na pessoa humana, a que o senhor Ministro da Saúde de Cabo Verde se referiu ontem, em Cabo Verde, apesar dos nossos dados estatísticos de 2022 apontarem para uma densidade da força de trabalho no setor da saúde de 7,25 por 1000 habitantes, a transição epidemiológica, o envelhecimento populacional, o aumento da procura por cuidados especializados e os compromissos com a cobertura universal da saúde impuseram os compromissos ao país uma resposta inovadora, resiliente e sustentável em termos de recursos humanos para um sistema de saúde resiliente, inclusivo e sustentável. Isso traduziu-se desde logo na elaboração do Plano Estratégico de Desenvolvimento dos Recursos Humanos, de onde destacamos o processo dos planos, carreiras, funções e remunerações dos profissionais da saúde, cujo cerne é valorizar os profissionais da saúde como médicos, enfermeiros, técnicos e auxiliares de saúde, incluindo a valorização significativa do salário em 40% a 60% e subsídios jurídicos para todas as categorias profissionais da saúde, criação de carreiras especiais e aprofundamento do diálogo entre governos e sindicatos. Igualmente, na sua fase final, a regularização dos vínculos precários, atingindo cerca de 50% do pessoal da saúde. Em 2026, pretendemos iniciar a formação médica especializada no país, com o objetivo de formar médicos especialistas até 2045, reduzindo a dependência de missões médicas estrangeiras, construindo um ecossistema de saúde mais robusto, soberano e preparado para os desafios das próximas décadas. Apoiamos o documento apresentado e estamos disponíveis para partilhar com todos os interessados estes e outros processos em curso na matéria de força de trabalho na saúde em Cabo Verde. Muito obrigado.
Merci beaucoup, Cap Verde. Seychelles a la parole et la République centrafricaine se prépare.
Merci, Madame la Présidente. Les mesures décrites dans le document dont nous sommes saisis peuvent effectivement changer la donne et nous les appuyons aux Seychelles. Il est essentiel d'investir dans la formation et le développement d'un grand nombre de professionnels de santé publics en proposant des programmes prioritaires et attractifs. Il est crucial d'améliorer les conditions de travail en proposant des horaires plus humains, des équipements adéquats, des salaires compétitifs, des stratégies de fidélisation et un environnement sûr afin de retenir les professionnels et d'attirer de nouveaux talents. La gouvernance et la planification stratégique doivent être renforcées en élaborant des politiques adaptées aux besoins locaux et en assurant une gestion efficace de ressources. La mobilisation de financement durable par le biais des budgets nationaux est essentielle pour soutenir ces initiatives. Les Seychelles estiment qu'en combinant ces actions, l'Afrique sera mieux à même de répondre aux urgences sanitaires, d'améliorer la santé publique et de mettre en place un système de santé plus résilient et plus équitable. Je vous remercie.
Merci aux Seychelles. La parole est à la République centrafricaine et l'Éthiopie se prépare.
Merci, Madame la Présidente. La République centrafricaine remercie le directeur régional pour avoir autorisé d'aborder la question cruciale des personnels de santé publique et d'intervention en cas d'urgence et félicite le secrétariat pour la qualité du document présenté. La faible densité en ressources humaines qualifiées fragilise les capacités de la République centrafricaine à anticiper et à répondre efficacement aux urgences sanitaires sur toute l'étendue du territoire national. Cependant, grâce au soutien de l'OMS, de Africa CDC en particulier, nous avons pu réaliser des avancées notables dans les domaines de la formation, des équipes d'intervention rapide, des épidémiologistes de terrain, de la mise à disposition d'outils normatifs, d'équipements, de kits médicaux, de la réalisation d'exercices de simulation pour tester et améliorer la capacité de réponse de notre centre des opérations d'urgence sanitaire. Et enfin, la formation des milliers d'agents communautaires pour appuyer la détection et la réponse de proximité. Ces acquis constituent un socle, mais il demeure encore une forte vulnérabilité dans un contexte de crise que demeure un des défis majeurs. Nous appelons la communauté régionale à renforcer les mécanismes régionaux de mobilité et de mutualisation des compétences à travers les programmes SURGE, AVOC, FTP et accroître les investissements dans les solutions numériques pour compenser l'inégalité de répartition et améliorer la préparation des urgences. La République centrafricaine appelle à une solidarité renforcée et prend note des mesures proposées. Je vous remercie.
Merci à la République centrafricaine. L'Éthiopie a la parole et la Côte d'Ivoire se prépare.
Thank you, Honorable Madam Chair. Ethiopia commends the Regional Office for the comprehensive and timely report that underscores the urgent need to strengthen our continent's health workforce to achieve universal health coverage and health security in the face of multifaceted challenges. Ethiopia recognizes that a skilled, equitably distributed, and resilient public health and emergency workforce is the backbone of the health system and the first line of defense against health threats. We have strengthened our public health emergency response through multidisciplinary rapid response teams at national and subnational levels and are working on the international classification of emergency medical teams. We have also aligned our national strategy and plans with the WHO Global Strategy on Human Resources for Health and the Joint Emergency Preparedness and Response Action Plan. We continue to invest in primary health care, expanding training, offering incentives, empowering health workers, integrating technologies, and supporting health worker mobility. Despite this progress, challenges persist, including workforce attrition, uneven geographic distribution, limited access to continuous professional development, and insufficient funding. We believe a lot could be done to synergize available capacities across the region and leverage on what we have. To this end, we call upon member states to also leverage the EMT training and knowledge hub in Addis Ababa for building context-relevant capacities within the region. Ethiopia therefore welcomes and supports the technical paper, proposed actions, and looks forward to its accelerated implementation. I thank you.
Merci à l'Éthiopie. La Côte d'Ivoire a la parole et le Togo se prépare.
Madame la Présidente, la Côte d'Ivoire félicite le secrétariat pour la qualité du rapport et partage ses conclusions. Depuis 2016, avec l'appui de partenaires, la Côte d'Ivoire met en œuvre le programme de formation en épidémiologie de terrain afin de renforcer les capacités des professionnels de la santé dans la prévention, la détection et la riposte aux épidémies et autres priorités de santé publique et aussi accélérer les progrès du pays vers la réalisation de l'objectif de la sécurité sanitaire mondiale, soit un épidémiologiste de terrain pour 200 000 habitants et un vétérinaire épidémiologiste de terrain pour 400 000 unités d'animal. Cette formation qui se réalise selon l'approche Une seule santé comprend 3 niveaux, dont un Master 2. Elle renforce les capacités des agents de la santé humaine, animale, environnementale, de l'agriculture, des eaux et forêts et des forces armées. À ce jour, plus de 500 professionnels de la santé ont été certifiés. Par ailleurs, d'autres professionnels de la santé mentale ont été formés dans le cadre d'une cohorte intermédiaire sous-régionale réalisée cette année. Ces formations ont un impact réel sur l'amélioration de la surveillance épidémiologique dans les districts et régions sanitaires, avec l'amélioration de la qualité des données, des analyses, des investigations et la production de bulletins épidémiologiques. La formation FTP Côte d'Ivoire s'impose désormais comme un pilier essentiel de renforcement des capacités des acteurs du système de santé publique ivoirien, en mettant à disposition une masse critique d'épidémiologistes de terrain capables de répondre efficacement aux menaces sanitaires. Grâce à son ancrage dans l'approche Une seule santé, le programme de formation en épidémiologie de terrain contribue à la sécurité sanitaire nationale et régionale. Je vous remercie.
Merci à la Côte d'Ivoire. Le Togo a la parole et Capo Verde se prépare.
Merci, Madame la Présidente. Le Togo remercie le secrétariat pour la qualité des documents sur les personnels de santé publique et d'intervention en cas d'urgence en Afrique. Au Togo, dans le cadre de l'approche One Health, des activités ont été réalisées, notamment la formation de 130 professionnels nationaux sur le centre d'opération d'urgence de santé publique, le système de gestion d'incidents, la formation de 195 membres d'équipe d'intervention rapide prêts à être déployés dans les 39 districts sanitaires, la formation de 5 épidémiologistes de terrain en FLTP avancé et la formation de 150 agents de santé animale communautaire et de 50 paraprofessionnels vétérinaires à l'aide précoce et au service de santé animale. Toutefois, le Togo est confronté à la lacune dans les capacités de son personnel de santé à détecter, évaluer et répondre aux menaces pour la santé publique. Le ratio de personnel essentiel de santé est de 7,83 pour 10 000 habitants en 2023, dont une minorité a suivi une formation intermédiaire et avancée dans le cadre du FLTP. Le Togo fait du développement des ressources humaines pour la mise en œuvre du RSI 2005 une priorité dans le cadre de la mise en œuvre de son nouveau plan d'action nationale de sécurité sanitaire 2025-2027. Convaincu que le renforcement des ressources humaines pour la santé publique est la pierre angulaire d'un système de santé résilient, le Togo réaffirme son engagement à atteindre la cible fixée par l'OMS dans le cadre du RSI 2005. Le Togo prend note du rapport. Je vous remercie, Madame la Présidente.
Merci au Togo. Et Capo Verde a la parole et Luganda se prépare. Ah, vous n'allez plus intervenir? Ok, merci. Donc, l'Ouganda va prendre la parole et Madagascar se prépare.
Thank you, Chair. Uganda receives the report from the director. Early this year, Uganda recorded an outbreak of Ebola. The outbreak had a cumulative number of 14 cases, 12 confirmed and 2 probable cases. Sadly, 2 confirmed cases passed away, resulting in a case fatality of 28.6%. On a positive note, 10 patients recovered. These were identified within the quarantine that we had done for all the contacts. Madam Chair, the lessons learned from Uganda are critical in assessing and preparing for outbreaks. The know-how is available. Within 87 days, Uganda was able to declare an outbreak which had been in 3 cities and 7 districts over. The challenge remains as we organize financing for emergency response. Even when you have the human capital and capacity, the funding must be available in real time. We need to review and revise the way we resource financing for outbreaks. I thank you.
Merci. Merci à l'Ouganda. Madagascar a la parole et l'Angola se prépare.
Merci Madame la Présidente. Nous louons la qualité du document présenté par le secrétariat. La question des ressources humaines en santé est au cœur du système sanitaire malagasy, notamment dans la situation d'urgence. Grâce à l'appui des partenaires, 329 FITP Frontline et 8 masters en FITP sont répartis dans tout le territoire, formation dans le cadre de One Health. 84 agents de différents secteurs ont été formés en search, appuyés par le MSAFRO. 170 agents sont dans le cadre de gestion, formés dans le cadre de gestion des centres d'opération d'urgence en santé publique. Nous avons également 5 institutions de formation académique en épidémiologie permettant de disposer des épidémiologistes, ressources humaines qualifiées pouvant être disponibles au niveau du pays. La valorisation des agents communautaires de santé constitue un maillon indispensable entre la population et les systèmes de santé formels, notamment en situation d'urgence. D'ailleurs, nos agents communautaires sont des ressources qui assurent la surveillance basée sur les événements. Face à ces efforts, des défis majeurs restent affrontés. Il y a la pénurie et la répartition inégale en termes de ressources humaines, une concentration des personnels de santé dans les grands centres urbains, laissant les zones rurales et enclavées sous-dotées, voire dépourvues. L'autre défi est la motivation et la rétention des agents, dont un grand nombre sont partis à l'étranger. Face à ces défis, il est essentiel de poursuivre la décentralisation et de mettre en place des incitations attractives pour encourager le déploiement des professionnels dans les zones rurales ou de forte insécurité. Enfin, nous réaffirmons notre engagement à disposer des personnels qualifiés et suffisants, mobilisables, notamment dans la surveillance et la prévention des urgences sanitaires, avec l'appui des partenaires et dans la multisectorialité. Je vous remercie.
Merci à Madagascar. L'Angola a la parole et le Mali se prépare.
Muito obrigada, Senhora Presidente. Angola acolhe com entusiasmo os dados propostos e constantes no relatório e reitera o seu compromisso com o fortalecimento da força de trabalho em saúde pública e emergências, alinhado com os objetivos da Estratégia Regional da OMS. Gostaria de partilhar algumas ações concretas que o nosso país está a implementar. A Angola aumentou nos últimos 7 anos 46% da sua força de trabalho com a admissão de 46 mil novos profissionais. Está em curso um programa ambicioso de formação especializada de quadros que prevê especializar 38 mil profissionais em 5 anos, em que as especialidades ligadas aos cuidados primários de saúde e saúde pública não são exceção. Também temos estado a formar epidemiologistas de campo, gestores em emergências e vigilância, em colaboração com a OMS e instituições acadêmicas regionais. Criamos núcleos provinciais de equipas de resposta rápida, dotadas de técnicos treinados e equipados capazes de atuar em emergências. Criação de equipas multissetoriais no âmbito da abordagem de uma só saúde. Mapeamento e gestão da força de trabalho em saúde pública, com foco nas áreas rurais e difícil acesso. Reforço das condições de trabalho e incentivo de fixação de profissionais nas áreas recônditas. Apelamos à criação de mecanismos regionais de apoio técnico e financeiro para apoio dos países a formar e a reter profissionais de saúde na linha da frente, incluindo mecanismos de partilha de experiências interpaíses. Angola manifesta a total disponibilidade para continuar a trabalhar com Estados-membros, OMS e parceiros. Muito obrigado.
Merci à l'Angola. Le Mali a la parole et la Tanzanie se prépare.
Merci, Madame la Présidente. La 75e session du Comité régional de l'OMS pour l'Afrique place au cœur des débats un enjeu capital: le renforcement du personnel de santé publique et d'intervention d'urgence. Le Mali, fortement concerné par les crises sanitaires récurrentes, soutient pleinement cette priorité. Notre pays rencontre des défis: pénurie de personnel qualifié, charge de travail élevée et difficultés de rétention des compétences. Ces faiblesses entravent notre réactivité face aux épidémies et menacent la résilience de tout notre système de santé. Le Mali saisit cette opportunité pour plaider en faveur d'investissements durables dans la formation, le recrutement et la protection des agents de santé. Nous appelons à un engagement renforcé des partenaires techniques et financiers pour soutenir la stratégie africaine visant à créer une nouvelle donne en santé publique. La coopération régionale, le partage d'expériences et l'innovation sont nos meilleurs atouts pour bâtir une main-d'œuvre sanitaire robuste, capable de protéger les populations et de faire face aux urgences de demain. Je vous remercie.
Merci au Mali. La Tanzanie a la parole et l'Algérie se prépare.
Thank you, Chairperson. The United Republic of Tanzania applaud the World Health Organization Regional Office for Africa for the ongoing efforts on the public health workforce and take note of the report on the agenda item. The United Republic of Tanzania remains committed and has made significant milestone on implementation of the regional and global workforce strategies. Tanzania acknowledges the importance of trained and skilled workforce in the attainment of national, regional, and global health security targets in the realization of the Global Strategy on Workforce 2030. The country has employed the use of telemedicine, eco-distant learning platform initiative, and other learning platforms to improve health service delivery, strengthen workforce capacity in emergency and disaster management. Chairperson, to sustain skill sets and capacities, the country introduced mandatory electronic continuous professional development program and has made initiatives to put strategies to ensure sustainable development, availability, and the retaining of public health emergency workforce. We call for joint efforts to address the low investments in the workforce, specifically in the current context of increasing frequency and complexity of emergency overwhelmed health systems. Chairperson, Tanzania reiterates its commitment to collaborate with member states and the WHO on proposed action toward the attainment of regional goals. Thank you.
Merci à la Tanzanie. La Gambie a la parole et le Soudan du Sud se prépare.
Thank you, Madam Chair. We thank the Secretariat for the technical paper on the status of public health and emergency workforce in Africa. The Gambia recognizes the profound importance of a robust public health and emergency workforce as the bedrock for achieving universal health coverage and ensuring health security across Africa. The insights presented in the technical paper acutely highlight the severe challenges currently impeding our collective progress towards this vital goal. These acute shortages of health workers not only strain existing health system, but also severely undermine emergency preparedness and overall health service delivery. Recent crises have revealed the limited workforce capacity and the urgent need for a prepared and well-equipped health workforce. We note the challenges detailed in the document, and the Gambia is ready to collaborate closely with the WHO, WAHO, Africa CDC, and all developing partners and academic institutions to implement these bold and strategic action points. By working together, we can ensure equitable access to competent, motivated, and resilient health workers, fundamentally strengthening health system for health security. Thank you all.
Merci à la Gambie. Le Soudan du Sud a la parole et le Nigeria se prépare.
Thank you, Excellencies. South Sudan faces one of the most severe health workforce shortages in the world. Our doctor-to-patient ratio is just 0.5 per 100,000, the lowest in the region and globally. The public health workforce is overstretched by recurrent outbreaks such as cholera, malaria, Ebola, threats, Mpox, and a growing burden of non-communicable diseases. This crisis stems from conflict, brain drain, under-resourced training institutions, poor incentives, and weak health systems management. The consequences are stark. Limited access to care in rural areas, high maternal and child mortality, protracted outbreaks, and heavy reliance on NGOs, national and international, often at high cost and with risks of parallel systems. Despite these challenges, South Sudan has developed a national health workforce strategy, created a surge capacity department, introduced workforce regulatory instruments, expanded community health worker training, and invested in in-service capacity building, digital surveillance, and emergency response teams across all states. We align fully with African regions' status report and support proposal actions to expand training institutions, harmonize standards, integrate surge workers into permanent roles, and mobilize resources to strengthen workforce capacity and resilience. South Sudan stands ready to work with WHO, Africa CDC, and partners to bring a stronger, better prepared health workforce for our country and our continent. Our country, South Sudan, supports the proposed actions to adopt and implement continental protocols. Thank you.
Merci au Soudan du Sud. Le Nigeria a la parole et le Malawi se prépare.
Thank you, Chairperson. Nigeria commends the World Health Organization for presenting the report on the status of the public health and emergency workforce in Africa. The COVID-19 pandemic recurrent outbreaks such as Lassa fever, cholera, and meningitis, as well as the increasing frequency of climate-related health emergencies have underscored the critical importance of a well-prepared, skilled, and resilient health workforce in Africa. The availability of trained public health and emergency personnel is central to strengthening our regional health security. Chairperson, in Nigeria, we have made significant effort to build this workforce through initiatives such as presence of dedicated workforce for epidemic preparedness and response at the National Center for Diseases Control and Prevention, implementation of Nigerian field epidemiology and laboratory training program, which has trained hundreds of field epidemiologists now serving across states. Expansion of training for emergency medical teams, community health workers, and other cadres deployed during outbreaks and humanitarian crises. Chairperson, despite this progress, gaps persist. We face shortages in specialized skills, uneven distribution of personnel, inadequate financing, and challenge of retraining highly trained professionals. Chairperson, Nigerian therefore support WHO effort to advance a coordinated regional approach for strengthening the public health and emergency workforce. We particularly emphasize the need for sustainable financing and investment in training institutions, regional accreditation and mobility mechanism for emergency response.
Merci au Nigeria.
Thank you, Chairperson.
Le Malawi a la parole et Comores se prépare.
Chair, thank you very much for giving Malawi the opportunity to comment on this document, which it welcomes and which it supports, because Malawi on our own has actually suffered a series of public health emergencies in the past 2 years. And indeed, because of that need, we discovered the need for a trained and purposely developed workforce that would be able to help to respond to the emergencies. On our own, together with partners, Malawi has had a 2-year emergency preparedness and response flagship roadmap, which has allowed it to train a series of healthcare workers. Specifically, Malawi has been able to train targeted healthcare workers, in particular initially supporters that are going to be responding at community level. We have had multidisciplinary sector officers that have been trained in public health emergency operations, community health workers that have been trained to be able to respond at community level, including through the IDSR. Since the Mpox outbreak came, a number of health workers, 322 in particular, and some senior officers have been trained in Mpox management as well as surveillance and response. Also, 28 trained basic emergency care persons have already been trained in order to be able to be available to respond to future outbreaks. But Malawi needs support to be able to sustain the numbers as well as to certify the courses that have been initiated.
Merci au Malawi, merci au Malawi. Les Comores ont la parole et le Tchad se prépare.
Madame la Présidente, l'Union des Comores, comme beaucoup de pays africains, font face à une pénurie critique de personnel de santé, limitant la mise en place de la couverture sanitaire universelle, la préparation aux urgences et la sécurité sanitaire. Malgré des efforts sur le peu d'effectifs existants, la motivation insuffisante du personnel, l'usage limité des technologies numériques et l'absence d'harmonisation continentale des normes et de formation et de mobilité freinent les progrès. Dans ce contexte, l'Union des Comores a réalisé quelques progrès, notamment sur la formation de plus de 80 professionnels de santé dans le cadre du programme FITP One Health, renforçant les capacités de surveillance épidémiologique, formation en spécialité de médecine et de cadres de haut niveau, existence de 3 membres formés par CDC Afrique et des professionnels en santé formés par la Banque mondiale aptes à intervenir en cas d'urgence, engagement national dans les initiatives OMS CDC Afrique et un capital humain jeune et mobilisable. Malgré ce tableau reluisant, le pays note des faiblesses qui ne sont pas les moindres. Manque de motivation du personnel de santé, insuffisance d'effectifs, surtout dans les zones rurales et reculées, faible recours aux technologies numériques, absence d'alignement sur les normes continentales de formation et de mobilité, contrats précaires et manque de perspectives de carrière qui alimentent la démotivation. Toutefois, et eu égard à tout ce qui précède, le pays recommande de renforcer la motivation et la fidélisation, investir dans la formation spécialisée, promouvoir l'usage des technologies, aligner les initiatives continentales, renforcer la planification et la ressources humaines en modernisant les systèmes de suivi, en anticipant les besoins et en intégrant les personnels contractuels dans des fonctions permanentes. Je vous remercie.
Merci aux Comores. Le Tchad a la parole et Mozambique se prépare.
Merci, Madame la Présidente. La situation des ressources humaines de la santé au Tchad est caractérisée par une pénurie de personnel de santé en quantité et en qualité et leur répartition inégale à l'échelle du pays. Le Tchad dispose d'un plan national de développement des ressources humaines en santé dont la mise en œuvre aura besoin des appuis multiformes des différents partenaires. En 2023, le Tchad comptait 10 777 agents de santé, toutes catégories confondues. Or, il faut un minimum de 40 000 agents de santé, toutes catégories confondues, pour l'atteinte des objectifs de la couverture santé universelle d'ici à 2030, ce qui est un grand défi au vu des autres défis auxquels le Tchad fait face de nos jours. Pour faire face à la pénurie criarde et croissante en ressources humaines qualifiées et la fuite des cerveaux au Tchad, surtout du côté des médecins envoyés en formation à l'extérieur, il faut souligner d'une part que plus de 1724 agents de santé, dont 425 nouveaux médecins, ont été recrutés à la fonction publique cette année et affectés directement dans les provinces. Et d'autre part, pour renforcer sa souveraineté sanitaire et réduire les évacuations sanitaires, le Tchad a créé 5 CHU. Aussi, le Tchad, qui fait des soins de santé primaire un des piliers pivots pour accélérer la mise en œuvre de la couverture sanitaire universelle, dont le démarrage effectif a été lancé depuis février 2025, a fait le choix de renforcer la qualité des paramédicaux, notamment les infirmiers, les sages-femmes et autres, par l'institution depuis 10 ans environ d'un examen unique de certification des diplômes des paramédicaux. Et cette stratégie est complétée par l'encadrement du statut des agents de santé communautaire. Le Tchad appelle au renforcement des programmes de formation régionaux en santé publique et en gestion des urgences afin de mieux préparer les professionnels aux défis actuels et futurs. Je vous remercie, madame.
Merci au Tchad. Mozambique a la parole et Guinée équatoriale se prépare.
Muito obrigado, Sr. Presidente. Todo protocolo observado. Moçambique saúda a excelente visão estratégica do documento. Iniciamos a implementação do Plano Nacional de Desenvolvimento de Recursos Humanos, com ênfase na formação acelerada de especialistas e na sua retenção em relação aos desastres naturais. O mapeamento de técnicos para a composição de equipas multidisciplinares de resposta rápida a nível nacional, que possam responder aos surtos de doenças tais como epidemiologistas, técnicos de medicina preventiva, de laboratório em saúde pública. Capacitação de profissionais de saúde e agentes comunitários de saúde em matéria de vigilância sanitária integrada de doenças e gestão de incidentes, fortalecendo as suas competências para detectar, monitorar e responder aos eventos de saúde pública. Estas ações terão impacto no seguinte: maior prontidão e capacidade de resposta, fortalecimento da vigilância e controle de doenças, a melhoria na coordenação interinstitucional e gestão de crise. Moçambique apoia a adoção do documento apresentado. Muito obrigado pela prestimosa atenção. Vamos trabalhar.
Merci beaucoup à Mozambique. La Guinée équatoriale a la parole et les autos se préparent.
Merci, Madame la Présidente.
Nous félicitons le secrétariat pour ce rapport soumis au comité régional. La Guinée équatoriale a été exposée ces dernières années à des situations d'urgence de grande envergure comme la pandémie de Covid-19, l'explosion des bombes du 7 mars 2021 à Bata, le flambeau de l'Mpox et de la fièvre hémorragique du Marbourg en zone rurale du pays en 2023, ont prouvé le besoin urgent de compter avec un système de réponse et de gestion efficace des crises et urgences sanitaires dans le pays. À cet effet, le ministère de la Santé a conçu un plan d'action national de sécurité nationale et un plan d'action sanitaire pour les désastres et émergences sanitaires, lesquels ont établi les bases pour la création d'un système national de réponse aux urgences et émergences sanitaires appelé SUMRE et COES. Les objectifs de ce programme consistent à diminuer la mortalité face aux émergences et urgences en santé publique, de diminuer le temps de réaction face aux urgences sanitaires, d'améliorer la qualité de la prestation sanitaire et extra-hospitalière, de renforcer la coordination interinstitutionnelle et communautaire face aux urgences et émergences sanitaires, de renforcer les capacités techniques des ressources humaines qualifiées. Et d'autre part, nous souhaitons concevoir un plan de collaboration conjointe transfrontalier avec les pays voisins, étant donné que la plupart des émergences sanitaires et en santé publique se produisent en zone rurale où passent nos frontières qui sont très poreuses. La Guinée équatoriale soutient le rapport soumis par le secrétariat du comité régional et propose son adoption. Je vous remercie.
Merci à la Guinée équatoriale. Les autos à la parole, la République démocratique du Congo se prépare.
Thank you very much, Chair. Lesotho's health workforce reflects Africa's broader reality, strong foundations in community and primary care, but critical shortages in specialized cadres essential for emergency preparedness. We have over 8,000 community health workers and 3.2 nurse midwives anchoring services, with government financing training through 5 nursing colleges and 1 national university. Our workforce totals 20,899 across 18 occupations as recorded in the 2024 National Health Workforce Account Survey. Yet capacity remains uneven. We have only 455 medical doctors, mostly generalist and acute shortages of anesthesiologists, trauma, critical care specialists, laboratory and imaging staff. In public health, there are just 9 epidemiologists and 144 FETP frontliners. In short, while community-based cadres are strength for universal health coverage, the lack of specialized leaves Lesotho vulnerable to emergencies. Addressing the imbalance alongside tackling health work unemployment is vital for continental health system strengthening. I thank you, Chair.
Merci beaucoup pour les autos. La République démocratique du Congo, vous avez la parole et le Kenya se prépare. Merci.
Merci, Madame la Présidente. La République démocratique du Congo approuve le document de l'état des lieux sur le personnel de santé publique et d'intervention en cas d'urgence du secrétariat de l'OMS et l'en remercie. Le gouvernement de la RDC, ensemble avec ses partenaires, a mis en place un mécanisme de renforcement des capacités du personnel de santé à travers l'Institut national de santé publique INSP en sigle. En rapport avec la réponse aux urgences sanitaires, l'INSP assure la formation des épidémiologistes de terrain du niveau avancé en collaboration avec nos écoles officielles de santé publique, la formation des FLTP du niveau intermédiaire pour les cadres des provinces et le frontline pour le personnel des zones de santé. La formation de plus de 100 gestionnaires des urgences de santé publique, FEM, la formation des épidémiologistes, la formation plutôt des équipes d'intervention rapide. Plus de 202 AVOC Surge ont été aussi formés. Mais les gaps demeurent encore importants. À titre d'exemple, nous avons 250 épidémiologistes de terrain formés du niveau avancé sur un besoin de 519 attendus. Au vu de l'immensité de la RDC et de la complexité des situations d'urgence, le personnel formé pour répondre aux urgences de santé publique, surtout les femmes, demeure insuffisant, surtout au niveau périphérique. Nous notons une répartition inéquitable de personnel formé, avec une grande concentration dans les grandes villes, avec des conséquences sur la détection des événements de santé publique. Ainsi, la RDC reste optimiste par rapport au diagnostic fait par le secrétariat de l'OMS et mettra en place des stratégies adéquates avec l'ensemble des parties prenantes pour augmenter la masse critique du personnel qualifié afin de répondre aux urgences de santé publique selon l'approche Une seule santé. Je vous remercie.
Merci à la République démocratique du Congo. Le Kenya, vous avez la parole et la Mauritanie se prépare.
Thank you, Chair, but Kenya has already delivered her statement.
Et donc, la Mauritanie.
Merci, Madame la Présidente. La Mauritanie félicite le secrétariat sur la qualité du document intitulé Personnel de santé publique et d'intervention en cas d'urgence en Afrique, état de lieu. Sans doute, un personnel de santé publique est essentiel pour mettre en place la couverture sanitaire universelle et assurer la sécurité sanitaire. C'est ainsi que la Mauritanie a enregistré les forces suivantes et les initiatives en cours. Présence d'un personnel d'intervention d'urgence, SERGE et MTT actifs, notamment dans les réponses Covid et inondations, collaboration avec l'OMS et le CDC Afrique sur la formation, exemple AVO, HC, SURGE, utilisation croissance de teams et d'outils numériques pour la coordination multisectorielle, Zoom, disponibilité d'une plateforme d'apprentissage numérique au CNUSP, engagement dans les exercices SIMX et TTX pour renforcer la préparation. Quelques défis continuent, pénurie de personnel qualifié en santé publique, surtout en zone rurale, manque de formation continue structurée, faible intégration des personnels formés dans les structures permanentes, contrats en cours, système des ressources humaines peu numérisées, limitant la planification et la mobilité interne, migration des professionnels vers d'autres pays. Perspectives et recommandations, renforcer la formation et la spécialisation, intégrer des modules de préparation aux urgences dans les curricula des écoles de santé, développer des programmes de formation continue via Team Academy, structurer l'absorption de la fidélisation, créer un cadre national de gestion et de ressources, intégrer des personnels investir dans la santé numérique, déployer des solutions de télémédecine, mettre en place un système de cartographie, mobiliser les partenaires. C'est ainsi, je termine sur cela et je vous remercie.
Merci beaucoup à la Mauritanie. Merci à tous les distingués délégués. Et je vois que s'il n'y a pas d'autres interventions, on invite les représentants des États membres d'autres régions, d'institutions du système des Nations Unies et d'autres organisations intergouvernementales qui souhaitent s'exprimer à lever leur plaque nominative. Et je vous rappelle que vous avez 1 minute par intervention. Merci. Donc maintenant, nous passons aux acteurs non étatiques qui ont demandé à faire des déclarations sur ce point de l'ordre du jour. Et je les invite à prendre la parole maintenant. Donc la première intervention, International Society of Physical and Rehabilitation Medicine, et qui sera suivie de International Service Public PSC. Merci.
Thank you, Chairperson. Distinguished delegate, the International Society of Physical and Rehabilitation Medicine, member of the World Rehabilitation Alliance, a WHO-hosted networks, welcomes the technical document on the status of public health and emergency workforce in Africa, which highlight the urgent need to scale and strengthen Africa's public health and emergency workforce. We recommend that rehabilitation professionals be explicitly included in emergency workforce planning and surge capacity models as AVOC surge, recognizing their crucial roles in recovery, continuity of care, and resilience after emergencies. Embedding rehabilitation competency within training, deployment, and retention strategy will help ensure that health security measures address both survival and long-term functioning in African region. Thank you.
Merci beaucoup. Et on revient un peu en arrière. Ils ont levé les plaques un peu tardivement. Donc, IFRC et MSF. Donc, IFRC, on va commencer par vous. Merci. Vous avez 1 minute.
The International Federation of the Red Cross and Red Crescent Societies commends the WHO for the good report on the status of public health and emergency workforce in Africa. Community health workers and community-based volunteers are key actors in prevention, preparedness, early detection, and response to humanitarian and public health crises. These volunteers are consistently providing vital community-based surveillance and fast response actions during epidemics and pandemics, even in the hard-to-reach communities. However, they face significant challenges, including being under-resourced, limited capacities, they lack recognition, and lead fragile livelihoods as volunteers. In alignment to the 2017 AU's commitment to scale up a people-centered and integrated community health workforce, it's important for governments to systematically integrate community health workers and volunteers into the national health systems, into preparedness plans, and build their capacities for emergency preparedness and response.
Merci bien, merci. MSF.
Yeah, thank you, Chair, for the opportunity. MSF notes and appreciates the discussions on this very important thematic, ensuring the comprehensive health care, protection, and standards of decent work for healthcare workers. However, MSF notes that there is little mention within these important discussions of absolute imperative of protecting healthcare workers in volatile humanitarian settings. We operate in more than 70 countries, and we see this happening over and over again. Tragically, we note more and more instances in which healthcare workers, healthcare settings, health infrastructure are not protected, indeed are actively attacked. Chair, we therefore call on all members to collectively call for and enforce the respect of the safety of health and care workers across the world, the respect of the international humanitarian law. Special emphasis must be made by all states of those health and care workers operating in humanitarian and unstable conflict-affected settings. These people are risking their lives.
Merci à MSF. Merci à MSF. Yeah. Maintenant, International des services publics. Merci.
L'International des services publics salue la pertinence du rapport. La pénurie de personnel de santé en Afrique est criarde, compliquant gravement la mise en place d'une couverture sanitaire universelle et compromettant la préparation au système d'urgence. Nous exhortons fortement les États membres à investir dans le personnel de santé et à améliorer notablement les salaires, les techniques, par une augmentation du financement public de la santé, conformément à la déclaration d'Abuja, pour enrayer la gangrène de leur migration. Nous appelons les États membres à respecter les principes fondamentaux du travail dans le secteur afin de limiter les conflits sociaux dans les pays. Nous exhortons les blocs sous-régionaux et le bureau régional de l'OMS Afrique pour nouer des partenariats au niveau national avec des organisations de santé telles que le Conseil africain des professionnels de santé, les réseaux des professionnels de santé d'Afrique de l'Est, d'Afrique de l'Ouest et d'Afrique australe. Je vous remercie.
Merci. La Fédération internationale des associations d'étudiants en médecine. La fédération d'abord, la Fédération des associations des étudiants en médecine d'Afrique, FAMSA.
Honorable Chair, today Africa faces a shortage of nearly 6 million health workers, with many young professionals leaving due to limited career opportunities. This gap weakens our health system and compromises universal health coverage. We call on member states to prioritize sustainable financing for health workforce and guaranteeing self-working environments. Competitive salaries, job securities, and incentives for rural service are essential to retain skilled professionals. As future health workers, We are committed to serving our communities, but we need governments to match our commitment with investments, policies, and incentives that make staying and saving at home the better choice. A resilient workforce is the foundation of resilient health systems. Our continent cannot afford to lose its greatest asset, its own people. Thank you.
Merci. Maintenant, la Fédération internationale des associations d'étudiants en médecine, IFMSA.
Honorable Chair, distinguished delegates, Africa has faced more public health emergencies in the past decade than any other region, from cholera outbreaks to climate-driven disasters. Our resilience is continually tested, and across IFMSA networks, young people are already stepping in. In Nigeria, medical students supported flood relief efforts. In Sudan, they assisted with triage during conflict. In DRC and Madagascar, they led outbreak education. In Malawi, youth-led teams responded during Cyclone Freddy. We urge member states and WHO for the inclusion of medical students in national emergency preparedness and response plans, youth-led public health corps at sub-national levels, and regional training hubs for early career professionals. Therefore, we call for true partnership to transform our communities. Thank you.
Merci. Maintenant, the African Forum for Research and Education in Health, AfriHealth.
AfriHealth commends the WHO in its report focusing on Africa's emergency preparedness and public health workforce, but points out the lack of specificity on Africa's health workforce. The African Forum for Research and Education in Health, AfriHealth, is the convening body of health professions education and research in Africa and is dedicated to the development and transformation of Africa's health workforce through education and research. AfriHealth, realizing that there is no health without a health workforce, will support WHO Africa region to improve the health of the people of Africa through interprofessional, multi-country, multilingual, and harmonized health professions education and research that will focus on Africa's women, children, and adolescents, public health and emergency preparedness, health workforce security, severe non-communicable disease management, and provision of essential health services at the district level and the integration of disease management in primary health care. Thank you.
Merci beaucoup. Union internationale contre le cancer.
Greetings. Africa's health workforce density remains at 1.55 per 1,000 population, far below the 4.45 needed for universal health coverage and effective cancer control, causing serious implications for cancer prevention, diagnosis, treatment, and palliative care. Without enough trained professionals, many patients face late diagnosis and limited access to life-saving services. We support greater investment in recruitment and retention of health workers, adequate remuneration, and opportunities for growth, while addressing abuse, discrimination, and burnout, which erode morale. We urge increased mobilization of resources and integration of new technologies to link specialists to underserved areas, maximizing existing infrastructure. Finally, collaboration with civil society and regional organizations is essential to strengthen health systems. With a strong workforce, we can reduce inequities and bring Africa closer to comprehensive, people-centered care. Thank you.
Merci beaucoup. Merci pour votre attention. Je ne vois plus de demande de prise de parole. Est-ce que le secrétariat a-t-il des observations à faire?
Yes, Madam President, just a small little. Thank you very much. Just to sincerely thank all the intervention and for the document AFR-RC 9 regarding the emergency workforce. Your feedback and commitment are essential as we strengthen our collective preparation and response capacities. It is encouraging to note that all countries are actively engaged in various initiatives related to emergency workforce development, including the establishment of emergency medical team, surge capacity framework, training through FETP, and other programs. We recognize the importance of enhanced regional coordination to streamline this effort and foster knowledge sharing and ensure more effective response strategy. It is also clear that WHO must work closely with partners and stakeholders to support this initiative and complement national action. Additionally, there is a pressing need for increased funding and resource mobilization to sustain and scale this effort. Strengthening the emergency workforce must be viewed as long-term investment in health security, requiring collaboration, coordination, financial support from all partners. We have also noted the declaration of non-state actors, including the need for healthcare workers' protection against violent attack and all hazard. We remain committed to supporting your leadership and working together to ensure a prepared, resilient, and responsive health system across Africa. Thank you very much.
Merci pour votre attention. Le secrétariat a pris note des observations formulées et le comité régional est-il disposé à prendre note du document et adopter les mesures proposées dans le document AFR RC 75-9 intitulé « Personnel de santé publique et d'intervention en cas d'urgence en Afrique, état des lieux ». Donc, je ne vois pas d'objection. Il en est ainsi décidé. Donc, on va continuer. Et sur le point 13 de l'ordre du jour, qui a pour titre « Renforcer la sécurité sanitaire en Afrique, améliorer la détection des événements, mettre en place des systèmes résilients et favoriser les partenariats stratégiques ». C'est le document AFR RC 75-10. Donc, nous allons y passer. Je donne une fois de plus la parole au docteur Abdou Salam Gueye, directeur de niveau régional pour les situations d'urgence, pour qu'il nous présente ce document. Docteur Gueye, vous avez 5 minutes.
Thank you very much. On behalf of the Secretariat, I have the privilege to introduce document number IFR RC 75-13, entitled Strengthening Africa's Health Security, Enhancing Event Detection, Building Resilient System, and Fostering Strategic Partnership. The purpose of this document is to advocate for accelerated, innovative implementation of regional strategies to strengthen early detection, build resilient health system, and forge strategic partnership. I will commence with the context. In 2024, Africa responded to around 150 health emergencies, which have strengthened the ability of health system to deliver service. Regional committees have adopted various strategies in the previous year, including the Regional Strategy to Health Security and Emergency 2022-2030, which include emergency preparedness and response flagship for strengthening preparedness pros, detection tasks, and response surge, as well as framework for sustaining resilient health system 2023-2030. Regional partnerships were also strengthened, including with Africa CDC and the regional economic committees. But their implementation are constrained by limited resources, weak multi-sectorial collaboration, and slow rollout of emerging technologies such as artificial intelligence. Specifically, on the issue of surveillance, IDSR implementation is a challenge. Weak laboratory capacity, lack of well-established interoperable on-health information system, lack of well-trained staff. On preparedness and health system is the issue of weak health infrastructure and its ability to recover from shock. And in partnership is fragmenting coordination mechanism, over-reliance of external donors, limited domestic financing, and competing priorities in a region that has complex partnership landscape. In order to address this issue, we recommend member states to accelerate rollout of IDSR at subnational level and enhance the use of digital technology for real-time data collection and analytics to achieve full implementation of the IDSR. Strengthen laboratory capacity, including genomic sequencing and genomic surveillance. Adopt legal and regulatory framework. Strengthen on-health all-hazard surveillance, adopting emerging technology. Invest in workforce development. Enhance resilience of health system fragile and conflict area and community level. Enhance partnership and financing. For WHO, we urge to provide strategic leadership and technical support, support member states to build IHR core capacity and implement of IHR amendment. Facilitate cross-border collaboration, support member states to mobilize resources. I may invite the regional committee to review the technical paper or not the proposed action. Thank you.
Merci infiniment, docteur. Donc, j'invite à présent les États membres à formuler leurs observations. On va commencer immédiatement pour gagner du temps au fur et à mesure. Donc, Capo Verde a la parole et Malawi se prépare.
Muito obrigada, senhora vice-presidenta. Cabo Verde enfrenta vulnerabilidades acrescidas de riscos climáticos e riscos de doenças emergentes e reemergentes, requerendo uma capacidade integrada de prevenção e resposta com foco em sistemas resilientes e parcerias estratégicas. Cabo Verde adotou a terceira edição da Vigilância Integrada e Resposta a Doenças e validou diretrizes de vigilância baseado em eventos para operacionalizar a vigilância comunitária. Além disso, o sistema de DHS2 foi introduzido em todos os concelhos, embora não seja utilizado por toda a estrutura. Cabo Verde expandiu a sua capacidade laboratorial e implementou a vigilância genômica, contudo, enfrentamos rupturas de reagentes e limitações de recursos humanos. O país encontra-se no processo de nacionalização das emendas ao Regulamento Sanitário Internacional. Cabo Verde dispõe de uma plataforma para a operacionalização da abordagem Uma Só Saúde, mas os sistemas de informação ainda não estão integrados entre setores. Cabo Verde tem investido na formação em saúde pública e o programa de epidemiologia de campo ainda mantém-se a necessidade de recursos humanos especializados para a preparação e resposta a emergências sanitárias. O financiamento é assegurado pelo governo com forte participação dos parceiros, cujo apoio continuaremos a contar. Assim, Cabo Verde reafirma sua determinação em reforçar a segurança sanitária em África e aprova as medidas propostas. Muito obrigada.
Merci beaucoup, Cap Verde. Malawi a la parole et le Burundi se prépare.
Thank you, Honorable Madam Chair. Malawi joins those that are supporting this document and the interventions therein specified, particularly because it enunciates very rightly the biological, environmental, as well as humanitarian aspects of health security. Despite many challenges, Malawi, with WHO support, has taken a number of bold steps towards this particular objective of preparedness and recovery. 2 years ago, in 2020 and 2023, Malawi, with WHO, conducted a mission that informed the 2-year emergency preparedness and response roadmap, which is now in its second year of implementation. Again, with support from WHO, Malawi secured a US $2.7 million multi-country pandemic fund, and we are in the process of drafting a country-level grant worth $25 million. The pandemic fund that will help to strengthen genomic surveillance, biosafety and security, sample referral systems, community-based surveillance, as well as One Health capacity. Malawi has also initiated development of a One Health policy, serving as a national blueprint for emergency preparedness and response. We recently conducted a joint prioritization of One Health's zoonotic diseases that require urgent multi-sector action. Further to the above, Malawi successfully contained the cholera outbreak, which had gone on for 2 years, and we have built capacity of subnational public health emergency committees across the country with resounding success. We have also strengthened health cluster coordination for improved multi-sector action. Chairperson, the public of Malawi, therefore, notes the proposed actions, and we seek WHO support in advancing One Health by strengthening the national coordination framework to ensure coordination and
Merci
also
beaucoup.
collaboration.
La machine n'était pas correctement mise. Donc, avant de donner la parole au Burundi, je vais citer la liste des pays et ceux qui n'entendront pas leur nom voudront bien demander pour qu'on les inscrive. Donc, il y aura Burundi, Mali, Ghana, Rwanda, Niger, Éthiopie, Lesotho, Nigeria, Togo, Mauritanie, République centrafricaine, Seychelles, Bénin, Sénégal, Angola, Zambie, Kenya, Mozambique, RDC, Tanzanie et les îles Maurice. S'il y a un pays que j'ai oublié, qui n'a pas ses noms, Comores. Burkina Faso et Comores. Burkina Faso, Comores. Madagascar aussi. South Sudan. Il y a le Soudan du Sud. South Sudan. OK. Est-ce que c'est tout? D'accord. Donc, merci au Malawi et Burundi à la parole et le Mali se prépare.
Merci, Madame la Présidente. Le Burundi salue le soutien multiforme de l'OMS dans le renforcement de la sécurité sanitaire au niveau national comme régional. Et comme beaucoup d'autres pays africains, nous continuons à faire face à de multiples urgences de santé publique, comme l'épidémie du choléra, le paludisme, la polio et plus récemment le Mpox, et géré grâce à une bonne collaboration avec toutes les parties prenantes sous le lit de l'OMS. Et pour renforcer la sécurité sanitaire face aux multiples épidémies, le Burundi a mis en place des mesures clés comme le renforcement des capacités diagnostiques au laboratoire national et dans les districts, la capacitation du centre des opérations d'urgence de santé publique qui vient récemment d'être doté de son plan stratégique 2026-2030 et déploiement d'équipes d'intervention rapide dans tous les districts, la formation d'épidémiologistes au terrain et l'intensification de la surveillance épidémiologique, sans oublier la gestion des situations humanitaires via des cliniques mobiles et suivi dans les cas de déplacés. Nous félicitons donc les conclusions du rapport AFR RC 75/10 et prenons note des recommandations relatives à l'intensification de la surveillance, à la mise en échelle de la SMIR 3, au renforcement des capacités laboratoires et de génomique ainsi qu'à l'approche One Health qui rejoignent nos priorités nationales. Le Burundi enfin exhorte l'OMS à poursuivre ses efforts en matière de sécurité sanitaire afin de renforcer la détection et la riposte rapide aux événements de santé publique en Afrique. Je vous remercie.
Merci beaucoup, Burundi. Le Mali a la parole et Ghana se prépare.
Merci, Madame la Présidente. Le profil épidémiologique du Mali au cours des 10 dernières années a été marqué par la recrudescence d'un certain nombre de maladies à potentiel épidémique, à savoir la fièvre hémorragique Congo-Crimée en 2019, le choléra en 2021 et la dengue depuis septembre 2023. À cela, il faut ajouter les inondations et autres catastrophes naturelles, les mouvements importants des populations du fait de l'insécurité. Ce contexte a nécessité l'élaboration d'un plan robuste de préparation et de réponse aux urgences sanitaires, la révision du guide des outils et de la surveillance intégrée de la maladie et riposte, la formation des équipes d'intervention rapide au niveau des districts sanitaires et la formation des acteurs de la plateforme Une seule santé sur le programme de formation en épidémiologie de terrain de première ligne, de deuxième ligne et du niveau avancé. Ce qui a permis d'améliorer la surveillance épidémiologique à travers la détection, le diagnostic, la riposte, la résilience dans la gestion des urgences de santé publique et faciliter la coordination opérationnelle des partenaires sur le terrain. Le Mali sollicite l'OMS à consolider davantage son partenariat stratégique et la collaboration avec le CDC Afrique en vue d'assurer une approche unifiée et coordonnée dans la gestion des flambées épidémiques de maladies et des crises humanitaires dans la région africaine, en vue de renforcer la résilience des systèmes de santé et des communautés dans la réponse humanitaire. Le Mali approuve le présent document et recommande son adoption par le comité régional. Je vous remercie.
Merci au Mali. Et Ghana, la parole, le Rwanda se prépare. Oui, Ghana. Ils sont pas là?
Yes, we are. Thank you, Madam Chair. Ghana thanks you for the opportunity to take the floor to contribute to the discussion on agenda item 13. We commend the Secretariat for presenting this important technical paper. The issues outlined resonates deeply with our national experience. Madam Chair, Ghana has invested heavily in surveillance as the backbone of our health security. Electronic integrated disease surveillance and response platform based on the 3rd edition of the IDSR guidelines is now operational in all 261 districts. This has significantly enhanced real-time detection and response to public health threats across the country. Over the past few years, Ghana has reported and managed several health threats, including outbreak of avian influenza in humans and animals, COVID-19, cholera, Lassa fever, Marburg virus, and Mpox. Our surveillance system successfully detected these outbreaks and rapid response measures were instituted to contain them. However, challenges remain. We continue to face limited coverage of event-based surveillance, occasional stockouts of laboratory reagents, inadequate cross-border collaboration, and overstretched health workforce and low public awareness on health threats. Madam Chair, Ghana successfully completed the 2nd round of the joint external evaluation this year. Building on this, we will develop a national action plan for health security. On strengthening Africans' health security, we call for 1, accelerated rollout of the IDSR at sub-national levels, including laboratory capacity, workforce development, and events-based surveillance. Leveraging digital technologies to enhance real-time surveillance and data sharing. And lastly, investing in resilient health systems, particularly at the community level, to withstand shocks and sustain external services during crisis. We note the proposed actions and the recommendation therein. Thank you.
Merci bien, merci Ghana. Le Rwanda a la parole et le Niger se prépare. Rwanda.
Thank you, Madam Chair. Rwanda welcomes the WHO Regional Committee report on strengthening Africa's health security, which underscores the urgency of investing in preparedness and response. Rwanda has taken concrete steps in this direction, including completing its 2nd joint external evaluation this year and reinforcing our One Health coordination mechanisms. We have also launched a cutting-edge health intelligence center, a real-time data hub, integrating information from health posts to referral hospitals, emergency response, supply chains, and civil registration, which is fully linked with our surveillance systems to enable early warnings and timely evidence-based decision-making. Emerging threats such as the Marburg virus and Mpox remind us that outbreaks can strike without warning, with severe health and economic consequences. Our experience in responding to these threats has shown that early detection, rapid coordination, and sustained investment are critical to protecting lives and livelihoods. Partnerships are central to this progress. A strong example is the Pandemic Fund, a global financing mechanism created to close critical gaps in preparedness. Rwanda's Minister of Health, Dr. Sabin Nsanzimana, serves as co-chair of this governing board, ensuring that the fund delivers real impact. Through its country-driven model, the fund has already supported over 28 African countries, including Rwanda, to strengthen disease surveillance, laboratory system, workforce training, and outbreak readiness. In Rwanda, this support was instrumental in bolstering our ability to swiftly detect and contain outbreaks. This experience, combined with our enhanced digital infrastructure, demonstrates how global solidarity and country leadership can come together to build a safer, healthier, and more resilient Africa. Rwanda supports this important document. Thank you.
Merci au Rwanda. Le Niger a la parole et l'Éthiopie se prépare.
Merci, Madame la Présidente. Le Niger
à l'instar des autres pays de la région africaine, est confrontée de façon récurrente à des menaces de santé publique d'origine biologique, environnementale et chimique exacerbées par des crises humanitaires provoquées par les inondations et l'insécurité. Dans le cadre de renforcement de la sécurité sanitaire, le Niger a adopté la stratégie transformer les systèmes de santé en Afrique. Et c'est ainsi qu'il y a eu la formation de formation
to the national and regional training in the country. The capacity assessment of health regulations pointed out shortcomings in detecting and surveillance system and the interoperability of platforms in the One Health that is not yet operational. As regards preparedness and response to public health emergencies, the country established multi-sectoral and multidisciplinary rapid response teams and emergency medical teams. And these inputs are prepositioned at the decentralized level. Furthermore, in 2025, the country submitted its proposals for the pandemic funds and the World Bank's health security program. Niger endorses the proposed document and invites member states to adopt it. Thank you, Niger. Ethiopia, you have the floor, followed by Lesotho.
Thank you, Honorable Madam Chair. Ethiopia commends the Secretariat for the technical paper and the proposed recommendations. They align with our health sector medium investment plan, commitments to the international health regulation. Ethiopia has nationally rolled out an integrated disease surveillance and response, integrating community-based surveillance into primary health care, although challenges remain in remote areas and those affected by humanitarian emergencies. We have advanced laboratory and genomic surveillance, establishing our first integrated center for bioinformatics and genomic sequencing in 2024. Our electronic IDSR and One Health are through the steering committee are also integrating data across human, animal, and environmental sectors. Ethiopia is also enhancing workforce and system resilience by addressing shortages through targeted deployment and training. Ethiopia calls for enhanced collaboration for cross-border surveillance, operational readiness, and strengthened core capacities, as outlined in the recommendations. Ethiopia takes note of the recommendations and reaffirms its dedication to work with all stakeholders to advance the regional health security agenda. I thank you.
Thank you, Ethiopia. Lesotho, you have the floor, followed by Nigeria. Lesotho.
Thank you, Chair. Lesotho reaffirms its commitment to strengthening Africa's health security and accelerating the implementation of regional and global frameworks for emergency preparedness and response. The African Public Health Emergency Fund has been vital in responding to crises, yet with arrears of 88 million USD by December 2020. Its sustainability is threatened. Lesotho urges member states to honor commitments, clear areas, and strengthen reporting to safeguard the fund's readiness. Lesotho has undertaken a risk assessment using the strategic tool for assessing risk. It has completed its second self-assessment and will undergo a joint external evaluation in October 2025 to inform the National Action Plan for Health Security. We are advancing the establishment of Public Health Emergency Operations Center and preparing for the state party annual assessment reporting. Our priorities include the strengthening community-based surveillance and electronic IDSR, expanding laboratory capacity and sample transport, investing in a skilled workforce and enhancing cross-border collaboration. Lesotho calls for regional solidarity, innovative financing, and stronger governance to sustain the African Public Health Emergency Fund and align national actions with international regulations, amendments, and the pandemic agreement. I thank you, Chair.
Merci, Lesotho. Thank you, Lesotho. Nigeria, the floor is yours, followed by Togo.
Thank you, Chairperson. Nigeria commends the World Health Organization and the Regional Office for Africa for prioritizing strengthening Africa health security. The agenda is timely and essential for safeguarding the health and well-being of our population. the threat posed by emerging and re-emerging infectious disease from Lassa fever to Ebola, cholera, and most recently COVID-19 remind us that health security in Africa requires robust systems for early detection, rapid response, and sustained resilience. In Nigeria, we have taken deliberate steps to strengthen our health security architecture through the Nigerian Center for Disease Control and Prevention, which continues to coordinate surveillance laboratory network and emergency operations. The integrated disease surveillance and response system expanded to enhance event-based detection at subnational levels. The investment in genomic sequencing capacity and digital platform to improve real-time data sharing, ongoing efforts to strengthen primary health care and build resilient systems that can withstand shocks while delivering essential services. Nonetheless, gap remains, limited financing, health workforce shortages, and fragmented partnership continue to undermine our collective preparedness and response. Nigeria strongly supports the calls for deeper regional solidarity and cross-border collaboration. We emphasize three priorities going forward, enhancing event detection capacity through strong community-based surveillance and data system, building resilient system by integrating emergency preparedness into routine service delivery and enhancing sustainable financing. Foster strategic partnership across government regional bodies. Nigeria reaffirmed the commitment to workforce with WHO, the African
Nigeria.
Thank you, Nigeria.
Thank you,
Thank you, Nigeria. Togo, you have the floor, followed by Mauritania. Thank you very much, Madam Chair. Togo initiated efforts to strengthen the participation of communities in the fight against health emergencies. Togo has a health community division, including that deals with public health emergency. Togo is adopting the new approach 7171 and the implementation of surveillance-based event that will enable the country to early detect all public health events and measure their impacts. To support this process, the preparation of emergency response, Togo has a search team that can be easily mobilized, that can facilitate the participation of community in response. However, efforts have to be guidelines for integration and participation of communities in health systems and technical and financial support of the WHO and other partners in implementing these activities. Togo knows the proposals that have been proposed. Thank you very much, Madam Chair. Thank you, Togo. Mauritania, you have the floor, followed by Mauritius. Thank you, Madam Chair. Mauritania congratulates the Secretariat for the quality of the document. It strengthened health security. Mauritania has made significant progress. For example, in detection and surveillance, Mauritania has crossed very important stages in the surveillance of disease. The third edition of the integrated disease and response is being deployed with training that's provided in all the 15 regions in the country. School continuous training has continued with frontline workers that has strengthened national expertise. In the community level, the workers have been trained as well, but their actions are still fragmentary. As regards laboratory, the strengthening of laboratory based on the COVID-19 has helped to improve the capacity in preventing and controlling infections with regular 10 countries benefit from the early warning system with an ambition for national coverage. As concerns preparedness and resilience, the coordination of health emergencies is based on the National Center of Health Emergency, and the teams benefit from training thanks to the support of WHO and Africa CDC. The last session on the emergency and funding, there's been significant progress and resources have been mobilized. Mauritania has clearly the ambition of leadership and intends to strengthen collaboration and to raise additional resources. Thank you, Mauritania. Mauritius.
Thank you, Chair. With the support of WHO, Mauritius has put in place an integrated disease surveillance and response IDSR framework, supported by capacity building of health staff and the development of SOPs. Mauritius has also initiated event-based surveillance through specific hotline and media scanning. We are also implementing an epidemic intelligence from open sources EIOS platform to detect and verify health threats from publicly available information. Mauritius has also set up a Public Health Emergency Operations Center, FIOC, with the support of WHO. The FIOC will be operationalized soon once the infrastructure and amenities are put in place. The FIOC will coordinate any outbreak detection, risk assessment, and response. We have also a strong multicultural collaboration under One Health approach with the Ministry of Environment, Ministry of Agriculture, and the Ministry of Local Government in respect of zoonotic disease surveillance, such as dengue, leptospirosis, and mpox. We have also engaged in early warning, alert, and response EWAR initiatives incorporating climate change-related health risk monitoring to anticipate and mitigate outbreak risks linked to extreme weather events. Ongoing engagement with regional and international partners such as WHO, AFRO, SADC, IOC, IHR mechanism for information sharing, training, and joint response planning is underway. Lastly, we have approached the WHO for financing the review of the Public Health Act, which dates as far back as 1925. Thank you, Chair.
Thank you very much, Mauritius. Before we proceed and give the floor to the Secretary for announcements, I'm going to read the countries that are on the list. And the Central African Republic, Seychelles, Benin, Senegal, Angola, Zambia, Kenya, Mozambique, the Democratic Republic of Congo, Tanzania, South Sudan, Burkina Faso, and Comoros. We have left out any country. There is Algeria. Nigeria is present, so I think that I'm going to give the floor to the Secretariat for announcements. Thank you.
Thank you very much, Chair. We would like to remind that a link and QR code for departure details and pickup is available and will be displayed on the screens at one point. For VIP, the departure process is handled at the same area as upon arrival. For all other delegates, buses will leave from the hotels 3 hours before the departure time shown on your ticket. You will then proceed through the normal departure process at the airport. Should you need any assistance, please contact the travel desk located in the back of the plenary room, next to the interpreter's booth. A lost and found desk is installed just next as well. Several items have been handled in already. If you have misplaced anything, please check. As for lunch, lunch will be served for VIPs with red tags on the first floor and in each end of the main hall for participants as during the past days. Extra finger food is offered for Pen Plus side event participants at the end of the session in front of this meeting room.
Donc, Merci au secrétariat.
Thank you, Secretariat. Just to mention that we are going to start a break and we'll resume at 2 p.m. on the dot. Thank you very much and enjoy your meal.
The side event on 10 Plus will be starting in this room now. Thank you very much.
Yuka. The ministers first. Yeah, I thought. Yes, perfect. You just put one.
Hello, indeed. Hello, delegates and friends. Please kindly take your seats. Don't worry about lunch because we will have a special portable lunch for you when this session is finished. So this session is going to start imminently. We're scheduled to start at 12:15. We're slightly over that now. And we'll finish by 1:45. And then you will have a portable lunch just outside. So don't worry about missing lunch. You will have it as soon as we finish this session. So please kindly remain in your seats, or if you're standing, take your seats, because this very, very important session on the PEN Plus approach for severe NCDs and advancing women's health is about to begin. So please take your seats. It's going to be a very dynamic session. Lots of engaging presenters working on the front line of health and NCDs, integrating breast and cervical cancer. And we look forward to your full attention. Thank you very much. We'll start very shortly. Thank you. Nobody told me. Yeah. Oh, I've heard about this video. Someone told me that in the transition there'll be a video. Okay, that's fine. Yeah, we are now aware of it. Okay, thank you. Thank you very much. Thank you. There you go. Hi, you okay? Yes. Thank you. I'm going to. Thank you very much, delegates. Kindly take your seats. We want to begin imminently. And could I ask the presenters from the first panel to come up on stage? Could we have the RD up on stage, Professor Janabi? Could we have Dr. Paul Chilwesa from Roche, Dr. Parag Bamare from Jipaigo, Dr. Anna Mokumbi on behalf of Professor Bookman, so again, Professor Janabi, Dr. Chilwesa, Dr. Bamare, and Dr. Mokumbi. Thank you very much. Prof, good morning. How are you? Good to see you again. Great to see you. Somehow. Thank you very much. Kindly take your seats. It's going to be a really engaging and very important session. NCDs are occupying more and more concerns at the highest level of government across Africa and beyond, indeed, harming more people than the diseases we traditionally associate with early mortality. But there are things we can do about it. We know what the theory is, but what about the practice? What are the strategies? Thank you very much. People over on the left-hand side, would you kindly take your seats? Thank you very much. All those of you standing up talking, would you kindly take your seats? Thank you very much. Or if you don't intend to stay, would you kindly leave the room? Thank you very much. This is a very, very important session on the PEN Plus approach for severe NCDs in Africa and advancing women's health. very, very important. Increasingly, and as we make advances in life expectancy, so this disease burden is going to increase. So please, all those of you to my left, stage left, would you kindly take your seats or please leave the room? Thank you very much. Kindly take your seats. It's an important session. We want your full attention. Thank you very much. Thank you. We can start in a moment or two as soon as we have quiet in the room and people have sat down. Thank you very much. So good afternoon, delegates, ladies and gentlemen, friends, all protocols observed. Welcome to the RC75 side event on Pen Plus Women's Integrated Cancer Services Beat Breast Cancer Project. So WICS BBC. I'm your MC, Henry Bonso. I'm looking forward to steering you through the next 90 or so minutes of key conversations, after which you'll be treated to a portable lunch outside the room. So don't worry, you're not going to miss what out on the food. Healthy, nutritious food, we hope. Now, when we talk of NCDs, we tend to refer to cardiovascular disease, cancer, diabetes, and chronic respiratory disease, those that mainly affect midlife to older adults. That's what we associate them with. But the breast cancer figures, yes, they're particularly alarming. Breast and cervical cancers account for more than half the cancer burden among women in sub-Saharan Africa, with about 60 to 70% being diagnosed with cervical cancer at an advanced stage, and only 1 in 2 women diagnosed with breast cancer survive beyond 5 years. That's a very, very low, very poor statistic. But every year, severe NCDs like sickle cell disease, rheumatic heart disease, and type 1 diabetes kill more than 500,000 children, adolescents, and young adults living in some of the poorest areas of Africa. So we need action and fast, not just at a later stage in life, but also earlier stage. And to provide the much needed momentum, raise awareness, and explore opportunities for greater investments for scale up for Pen Plus, breast and cervical cancers, the NCD's team within the Health Promotion and Disease Prevention and Control Cluster at the WHO Africa region is co-hosting this side event with JPIGO. For those who don't know what JPIGO stands for, used to stand for, it's Johns Hopkins Program for International Education in Gynecology and Obstetrics. It's a hybrid meeting with presentations, panel discussions, and if we have time, some Q&A, but we may not because it's been difficult to manage time because people have a lot to say. Distinguished ladies and gentlemen, let me recognize some of our special guests. We have Professor Mohamed Janabi, Regional Director for Africa, WHO, Dr. Abdurrahman Diallo, Acting Director of Program Management, Dr. Benito Impuma, Acting Director, Health Promotion, Disease Prevention and Control Cluster at AFRO, and Dr. Tirone Desta Alamarewu, WHO Zimbabwe Country Representative. We also have Dr. Paul Chilwesa, who's on the panel here, Head of Policy, Population Health and Health Systems Strengthening at Roche, Dr. Parag Bamare from JPIGO, Technical Lead for Women's Cancers, and the NCDI Poverty Network. The co-chair is here, Dr. Anna Mokumbi. So let me thank all panelists and participants from various ministries of health from the respective countries. So let's start off with a context. How is the land lying at the moment? Let me invite the WHO Regional Director for Africa, Professor Mohamed Janabi, to provide some brief opening remarks. Professor.
Thank you, MC. Excellencies, honorable ministers of health, head of delegations, distinguished delegates, our valued partners, colleagues and friends. Good afternoon. Well, thank you for joining us in such amid a busy schedule. It's really heartening to see this strong show of support and for today's side event, mainly focus on 2 urgent priorities: expanding care for severe non-communicable diseases to the Pen Plus approach, and advancing women's health through integrated breast and cervical cancer services. Let me begin by expressing my deep appreciation to our partners, the Leon and Harry Hamsley Charitable Trust, Roche and Jepaigo. Your steadfast commitment is helping us confront a devastating reality. Each year, severe NCDs claim 500,000 young lives across the African region. Each year. Now, you don't have to answer me. We all know how many people died in the Second World War, how many people died in the First World War. Now, you can get a picture when we talk 500,000 people are dying. Many of these conditions, including diabetes, sickle cell diseases, and rheumatic heart diseases, are preventable or treatable elsewhere in the world. The same is true for the breast cancer and cervical cancer. Together, these account for more than half of all the cancers in women in our region. Yet, far too often, these diseases are diagnosed far too late, or even those who are diagnosed, they are inadequately treated. I'm a clinician, I've seen it. So delayed diagnosis, limited access to essential medicines, and lack of specialized care, especially in the first level referral facilities, continue to cost lives. So what can we do? There's only one answer. This must change. No one should left suffer or die from the diseases that is both preventable and treatable. That is our shared responsibility and our urgent call to action. There has been progress, and there is hope. And as I always say, hope is a good thing, and good things never die. In 2022, member states adopted a PEN Plus regional strategy to expand integrated care for severe NCDs at the first level referral facilities. Today, 20 countries are implementing PEN Plus, and momentum is growing. Just last month, the second international conference on PEN Plus and chronic care in Africa was held in Abuja, Nigeria. This reaffirmed the strong regional commitment to scaling this approach as a pathway to universal health coverage and achieving the SDG 3.4. On women's health, the Women Integrated Cancer Services WICS project is making a strong progress in Cote d'Ivoire, Kenya, and Zimbabwe. Meanwhile, Jepaigo, Beat Breast Cancer in Africa initiatives in Ghana and Tanzania is advancing the Global Breast Cancer Initiative 60-60-80 target. These efforts are already reducing diagnostic delays and expanding access to life-saving care, especially in under-deserved areas. These are not pilot projects, dear colleagues. They represent the future of equitable and effective care. To sustain this momentum, I urge member states to prioritize integration of PEN Plus and women's cancer services into the National Health Benefit Package and primary healthcare strategy. Recognition of early breast cancer diagnosis and timely treatment as proven cost-effective NCDs best buys. As endorsed at the 76th World Health Assembly, financing and policy reforms that embed PEN Plus and WICS into broader health system strengthening. Cross-border sharing of models, tools, and evidence to scale innovation. WHO Regional Office for Africa remains fully committed to leading the regional NCD response. We will continue to provide technical support, build your capacity, and advocate for greater investment in sustainable integrated programs. PEN Plus, WICS, and Beat Breast Cancer initiatives are models for a new standard of care, rooted in equity, access, and health justice. This is how we ensure timely, quality, and compassionate care for all. The young girl with a sickle cell disease in a rural clinic, the woman with a breast lump in a district hospital, and a teenager with type 1 diabetes. Let this event be a catalyst to accelerate implementation, amplify local solutions, and align our efforts around the shared vision of people-centered, integrated care. This is the only way forward. I thank you. Back to you, Auditor.
Thank you very much indeed, RD. So people-centered, integrated care, that is the watchword. Well, let's turn now to our partners from industry and research. First, we have Dr. Paul Chilwesa, Head Policy, Population, Health and Health Systems Strengthening at Roche. Dr. Chilwesa.
Thank you very much, Chair. I think I should firstly open by stating that I'm here to represent the head of Roche Pharma, Dr. Machurin Chumi, who has been here the last 2 days. Unfortunately, he's had to travel out this morning. Your Excellencies, the Honorable Ministers of Health, the Regional Director of WHO Afro, Professor Janabi, I would like to thank you for the organizing committee for inviting Roche to R75 and the honor of giving a statement on this very critical topic. I think I would like to start off by saying, why is this topic important to industry? Why isn't this important to Roche? And I'll start off with a statistic that I think is a well-known WHO statistic and the latest breast cancer report, the Global Breast Cancer Report. We know the incidence is increasing. But what's very, very important to all of us, for every 100 women with breast cancer in the Western world, only 17 of those will be under the age of 50. If we bring that statistic back home, the report states that 47 of those 100 women are under the age of 50. What does that translate to? Every 100 deaths of breast cancer in Africa leads to 270 orphans in our communities. So this is a socio-economic imperative that even industry is really keen to participate. As we've heard, PEN Plus is an African-born, African-owned vision endorsed by WHO to ensure that people living with severe NCD receive quality, decentralized care close to home. It takes what works in primary health care and extends it to the district level, bringing specialized services to the people who need it the most. As we advanced women's health as a collective, we have an opportunity and a responsibility to bring breast and cervical cancer into this integrated model. These are not rare diseases. Breast cancer is now the most commonly diagnosed cancer worldwide, and cervical cancer remains a leading killer of women in Africa, despite being largely preventable. The logic for integration is very clear to us. The same health systems priorities and principles that underpin PEN Plus decentralization, task shifting, robust supply chains, and use of digital tools can be applied to early detection and treatment of breast and cervical cancers. Leveraging district hospitals as hubs for both NCD and cancer care means women don't have to travel hundreds of kilometers for screening, diagnosis, or follow-up. This integration is very clear, reduces costs, improves adherence, and builds trust in the health system. We have seen this as an example where we've been involved as Roche in Kenya through the Empower program, which began as a primary care initiative, evolved into a digital oncology initiative, and is now fully integrated into the National Cancer Institute system. By digitalizing patient records, enabling remote specialist consultation, and building a local capacity for cancer diagnosis and treatment, Empower has shown that even in the rural and unserved settings, hundreds or thousands of women can have access timely, quality care without leaving their communities. For this to happen, we think three things need to be essential. They need to be policy alignment and financing in accordance with the Lusaka agenda. Cancer services must be explicitly included in the PEN Plus implementation plans, backed by sustainable domestic and partner funding. Secondly, we think capacity building is of utmost importance. District level providers need training in clinical, breast examination, VIA for cervical cancer, basic oncology, and referral protocols. Technology and data is what we think is the third most important, where we think digital pathology, tele-oncology, and interoperable health records can extend specialist expertise to rural settings and track outcomes.
Dr. Chilwell, can I ask you to land very quickly?
Absolutely. I think PEN Plus has shown us the power of integration. Let's extend that power to breast and cervical cancers and make women's health a central measure of our progress on severe NCDs in Africa. And Roche stands behind WHO to achieve this. Thank you.
Thank you very much indeed, Dr. Chilwell, on behalf of Roche. It's good to see you, that you're promoting the district hospitals as hubs. And I like the idea of cost reduction, adherence, and trust. Okay, let's go to JPIGO for their perspective. We have Dr. Parag Bamare, Technical Lead for Women's Cancers. Dr. Bamare.
Thank you so much. Excellencies and distinguished delegates, very good afternoon. Allow me to begin by acknowledging the esteemed presence of Professor Janabi and my fellow co-host whose efforts have brought us together. Under the leadership of Ministries of Health of Ghana and Tanzania, and with the unwavering support of the Pfizer Foundation, it is a great honor to represent Beat Breast Cancer team here. Team that's working towards translating the Global Breast Cancer Initiative framework into action in the region. Thanks to WHO Afro for providing us this unique opportunity to learn and share insights from initiatives such as PEN Plus, VIX, and Beat Breast Cancer. Yesterday, from this very platform, His Excellency Honorable President of the Republic of Zambia urged us to learn from peers and avoid reinventing the wheel. This side event reflects that spirit, highlighting lessons from diverse initiatives and systems, but united by a shared goal of advancing health of women and their families. As a representative of JPIGO, I want to express our commitment to work with governments, partners, and communities to make access to quality assured care a reality for every woman everywhere. Thank you so much for the opportunity.
Thank you very much indeed. I'm stunned. Just over 1 minute and 10 seconds. Tremendous. Let's follow that lead. So we've heard from Roche, we've heard from JPIGO. Let's move to the NCDI Poverty Network, Civil Society. We have a specialist doctor. It's Dr. Anna Mokumbi is going to speak on behalf of her chair, Professor Jean Bookman. Dr. Mokumbi.
Thank you. Honorable Regional Director of WHO Afro, Your Excellencies, Ministries of Health, all protocol observed, dear colleagues and friends. It is hard to believe that only 3 years ago, here at RC, WHO Afro took the bold decision to endorse the PEN Plus strategy. 3 years seems such a short time, but we have come a long way in implementing this strategy. We are already improving the lives of children, adolescents, and young adults living with severe chronic diseases. The NCDI Poverty Network is proud to partner with WHO Afro and member states to implement the PEN Plus strategy. Specifically, NCDI Poverty is currently supporting government partners in implementing the strategy through training centers and clinical services in the Afro region with technical and financial support. These sites have already enrolled around 9,000 patients with type 1 diabetes, sickle cell disease, and congenital and rheumatic heart disease alone. The network is also supporting central level analysis and planning for PEN Plus expansion in additional 10 countries in the Afro region, particularly through national PEN Plus operational plans that are led by NCD poverty commissions in these countries. In addition, resources such as libraries, training, and mentorship materials have been also developed and delivered. Finally, we support with these countries' national operational planning for PEN Plus to provide the countries with an endorsed roadmap for PEN Plus scale up and to mobilize and align resources for PEN Plus. Zambia is an example of an incredible success with 3 centers already established. Last month, the Ministry of Health launched a national operational plan to scale up a new PEN Plus in new districts in Zambia.
Just last week also, the team here hosted an integrated camp where youngsters living with different severe non-communicable diseases came together for a full week to learn from each other and build an integrated peer network to support themselves. Let's give a big round of applause to our colleagues in Tanzania. Mozambique, besides being PEN Plus implementing country, hosts the network co-secretariat, which acts as a regional hub to Southern Africa. In 2 weeks, teams from Angola, Eswatini, Lesotho, and Zimbabwe will visit Mozambique to learn and share experiences. At NCDI Poverty, we have the goals to support WHO Afro PEN Plus strategy through our PEN Plus Partnership Strategic Plan. Our goal by 2030 is to ensure that over 50 million people in low-income countries have access to PEN Plus services, ensure that 100% of services for PEN Plus achieve quality standards, and mobilize a target of at least 40 million USD annually for PEN Plus. We are committed to working hand in hand with WHO Afro to achieve the regional milestones set for 2028 and 2030. Together, we must work to bring in more partners to support this journey, but I am certain that we will continue fighting to achieve these targets to make sure that all children, adolescents, and young adults on our continent who live with these conditions have access to services they need to live lives that are healthy and productive. I thank you very much for your attention.
Dr. Makumbi, thank you very much indeed. I was just about to ask you to land and you have done so. You preempted me. So thank you very much. That concludes our opening remarks. So put your hands together for Professor Janabi, Dr. Chilweza, Dr. Bamare. Dr. Bamare, you're going to stay, and Dr. Makumbi. Thank you very much indeed. So we're going to change panels. Dr. Bamare, you're going to stay. We're going to change panels. We're going to bring up a different set of speakers now, because we're going to move to another section. We want a progress update on implementing the PEN Plus project, but this time we're going to look at country profiles. We're going to look at country profiles for PEN Plus, and then we will have presentations on WICS, so Women's Integrated Cancer Services. So let me invite up to the stage Dr. Kofi Mensah-Nyako, Team Lead NCDs, the WHO Afro, Mr. Hastings Chwima from the Ministry of Health, Malawi, Dr. Yvette Kisaka from the Ministry of Health, Kenya, Dr. Ange Stanislas Anyero Nomel, and also Dr. Joan Paula Bo Malinya. So that will be our next panel. So we'll get country profiles from Cote d'Ivoire and Kenya on WICS, and Malawi and Kenya on PEN Plus. Thank you very much. I think you all brought up your place names, I think, haven't you?
Determined whether a person lives. Amara is a 12-year-old girl living in a remote village in Uganda. Since being diagnosed with type 1 diabetes, Amara must travel long distances to the nearest city hospital to get the insulin she needs to survive. Each journey adds financial strain to her family and keeps Amara away from school. In a nearby village, a baby boy, Zaki, is born with sickle cell disease. Without access to proper care, Zaki is likely to die before his 5th birthday. Every year in the African region, non-communicable diseases cause the premature deaths of hundreds of thousands of people who are younger than 70 years old. While most of the medications to manage severe non-communicable diseases, NCDs, such as type 1 diabetes, sickle cell disease, and rheumatic and congenital heart disease, are easily accessible in high-income countries, many people in sub-Saharan Africa still lack access. They must either face devastating costs to get to referral hospitals for treatment or go without care altogether, risking disability, ongoing sickness, or death. But there is hope. The World Health Organization is supporting countries to adopt the PEN Plus strategy to decentralize NCD services in the African region and bring care closer to home for people with severe NCDs. PEN Plus is a community-focused, person-centered solution that builds on the WHO's Package of Essential NCD Interventions, or WHO PEN. While WHO PEN provides care for common NCDs at primary healthcare centers, PEN Plus facilitates specialized care and integrated case management for more severe and complex NCDs at first-level referral facilities. The PEN Plus strategy includes training and mentorship of health providers, such as nurses and clinical officers, to provide diagnosis, treatment, support, and referral for severe NCDs. PEN Plus strengthens primary healthcare systems delivering WHO PEN services through ongoing training and supportive supervision. It also improves the quality of care through patient education, training, community engagement, and psychosocial support for patients and families. The PEN Plus model has not only proven successful, it has exceeded expectations. Health systems implementing PEN Plus have seen a tenfold increase in the number of patients receiving care for severe chronic diseases. The 47 member states in the WHO African region have adopted PEN Plus as their official strategy to manage severe NCDs like type 1 diabetes, sickle cell disease, and rheumatic and congenital heart disease. By bringing care closer to home, the PEN Plus model is expected to save millions of lives, especially among children, adolescents, and young adults over the next decade in Africa, ensuring that children like Amara and Zaki have a chance at a healthier future. To achieve universal health coverage, we must expand access to treatment for severe NCDs among hard-to-reach populations and communities in Africa. Together, we have the power to ensure that no one is left behind. Join us in creating a world where everyone, no matter where they live, has access to the life-saving care they need when they need it.
Tremendous. So that's PEN Plus on video and the theory, but what about on the ground, the implementation? Well, let's find out now, because we have Dr. Kofi Mensah-Nyarko, who is team lead for NCDs at WHO Afro. Please, Dr. Nyarko, please provide a brief overview of the progress that we're seeing at PEN Plus and give us some updates on the implementation in those 20 focus countries we heard about. Dr. Nyarko.
Thank you very much. The Honorable Regional Director, WRs, Honorable Ministers of Health present, all protocols observed. I'm presenting briefly on the progress of the implementation of PEN Plus in Africa. Next slide, please. The PEN Plus regional strategy was endorsed by member states in 2022 with clear objectives to look at governance, access to medicines, making sure that it's implemented, capacity building, and lastly, to ensure sustainability. And luckily, we had funding from the Hemsley Charitable Trust, and we started with 20 countries, and also in collaboration of NCDI Poverty Network, as you have heard this morning. So next slide, to look at where we are. The implementation, as we are all aware, before you can implement, you need to engage stakeholders, do an assessment, you move on to service delivery. After that, you implement, you scale up, then go to national coverage. Of the 20 countries, we have only one country that is at stage 2. All countries at 3 and 4, with Rwanda having national coverage. All the country, we are having PEN Plus implementation. So I think we should clap for Rwanda. And Malawi too has reached stage 4, moving on to national coverage. What have we done as a region? We have supported these 20 countries with documents, normative products, as NCR indicated, Zimbabwe, Zambia, we have national operational plans. We have developed guidance documents as by WHO, our value addition to guide countries, build capacity, and we have also supported visibility so that countries will get to know what PEN Plus is. And most importantly, as you are aware, for SDGs, we want to reduce premature mortality by 1/3, and PEN Plus deals with severe NCDs. And without PEN Plus, we will not be able to achieve the SDGs. And we see that with a few countries that are on track. For example, Rwanda, they are doing very well. So we encourage all countries to adopt PEN Plus and implement PEN Plus. So all 47 member countries, we encourage you to initiate, and those doing it to scale up institutional capacity building, improve access to medicines to ensure that severe NCDs is dealt with in the 47 member states, because that's the only way we can deal with premature mortality, and with premature mortality reduction, we'll be able to achieve our SDG goal 3.4. Thank you very much for your attention.
Thank you very much indeed. So yes, deserve an applause, Dr. Kofi Mensah Nyako. So that's the picture, the broad picture. What about the country level? Well, we are delighted to have, he's on my right, Mr. Hastings Chwima, from the Ministry of Health in Malawi, Republic of Malawi. So please tell us what is happening. What is the PEN Plus implementation on the ground? What progress are we seeing? What can you tell us? Good. Okay.
All protocols observed. Thanks so much, moderator. Indeed, I'm Hastings Jumia, Head of NCDs and Mental Health Division in Malawi. I'm here to highlight pertaining to the national country scale up in relation to PEN Plus in Malawi. I'm going to start with the on issue to do with the NCD burden in Malawi. NCDs account for 32% of mortality in our country. Suffice to highlight that NCDs also contribute to thanks. Basically, that's the NCD burden in Malawi. Basically, that slide is actually highlighting the scale up, how the scale up process in the country has actually progressed. Suffice to inform the House that we have actually scaled up to 13 district councils in my country. Pertaining to coverage, it's at 46%. That's in relation to PEN Plus. Now, in relation to PEN clinics, we have actually scaled it up to 240 districts out of the targeted 480, and that comes to 49%. This is with the support from WHO. WHO, Scottish Government, World Diabetic Fund, UNICEF, as well as partners in health. This has actually necessitated in relation to the PEN Plus operational plan 2018, which is basically in 3 phases. And as of now, we are in the final phases, which regards stepwise national scale up. Basically, in relation to the scale up, another milestone has actually been integrating non-communicable diseases into other chronic care conditions, such as the HIV, tuberculosis, and sexual and reproductive health services conditions. Now, pertaining to the key challenges we are actually facing as a country regards the limited or erratic availability of drugs and supplies. I feel this is not a secret. Another major challenge regards the lack of space, as well as the infrastructure. Probably pertaining to the next steps as a country, we are planning to mobilize as much resources as possible so that we can actually scale up PEN Plus in almost the 28 district councils. In Malawi, we have actually 28 district councils. As I already alluded to, we have actually done the national scale up to 13 district councils.
It's good to hear about the scale up and the plans, Mr. Chwima. I now have to ask you to land because your time is up and we have received a very interesting but mixed picture from the Republic of Malawi. So thank you very much indeed, Mr. Hastings Chwima from the Ministry of Health Malawi. You're in charge of the lead on NCDs. Thank you very much for giving us a picture from Malawi, because we're now going to move to the picture from Kenya.
Thanks so much.
Thank you so much. Yes, indeed. Thank you very much. Excellent. Thank you. We're now going to move to the perspective from Kenya. Dr. Yvette Kisaka is from the Ministry of Health in the Republic of Kenya. She's going to give us a PEN Plus update on implementation, coverage, and hopefully progress. So over to you.
Thank you. Good afternoon. As a background, Kenya, like many African countries, faces a challenge in providing quality care for severe NCDs, hence the adoption of PEN Plus in 2023. So we have done this since 2023 with support from NCDI Poverty Network, implemented PEN Plus in 2 counties, which has 2 districts, very different. Isiolo County being an arid, semi-arid region, mostly nomadic population, and Vihiga County being a rural, more agricultural setting with high prevalence of sickle cell disease, but also suffering most of the population living below the poverty line. Our focus has been on sickle cell disease, chronic respiratory diseases, and cardiovascular diseases, as well as type 1 diabetes. So challenges notwithstanding, we have made progress when we look at the 2025 goals. One of the things we did is the adoption of protocol-based management for severe NCDs. So far, we have 1,300 patients in care. We have developed and ready to launch a costed national operational plan to support scale-up, but also as a resource mobilization tool. We have built capacity of healthcare workers using a protocol-based training curriculum and strengthened diagnostic capacity through provision of point-of-care devices. One of the things we did to support our supply chain, we did revise the essential medical list to include commodities for PEN Plus to enable provision of the same at lower level facilities. We did develop data collection tools specific for PEN Plus, and there are processes ongoing to integrate this into the national health information systems and also digitizing the same. We have focused on sustainability, guided by the National Operational Plan. We plan to scale up to a bare minimum 20 counties by 2030, and this will be guided by the disease burden, but also looking at ensuring we have geographical distribution. So far, we have done a baseline assessment supported by WHO. There's a strong focus on sustainability. This is a government-led initiative. We have ensured to align with existing policies supporting UHC and primary healthcare. We have ensured that PEN Plus is not operating in a silo. It's actually integrated into existing systems. And one of the things we have done is actually linking the PEN Plus components into the government financing systems to support learning and improvement mechanisms. Kenya needs approximately 13 million USD to scale up to a bare minimum of 20 counties. Kenya has 47 counties. Therefore, we are calling for continuous collaboration, technical and financial support to not only go to the 20 counties that we do target, but to expand this to a national scale up. So thank you for listening. I will have saved you some seconds.
Dr. Kisaka, that was thank you very much indeed. You see, I'm smiling at you. 2 minutes and 50 seconds. And you gave us a lot of information in that time. And it is great to see that you're focusing on sickle cell and cardiovascular disease, and you're further enhancing the capacity of healthcare workers at the county level, which has drawn admiration from around the world. So it's great to hear from you, from Mr. Chwima, from the Malawian perspective, Dr. Nyako from the broader PEMPLOS picture update. Okay, we're going to move to women's integrated cancer services in a moment, looking at implementation and outcomes at the country level. Before we do, we're going to see a short video which will explain what WICS is all about. Please run the video. Well, I don't know who put together that video and chose the music, but it makes me feel like I can climb a mountain now. Very positive indeed, and gave us a snapshot of what's happening in Zimbabwe, Kenya, and Cote d'Ivoire, the countries where the pilots have been taking place. So let's move now to discuss the Women's Integrated Cancer Services implementations and outcomes at a country level. We have Dr. Ange Stanislas Agnero Nomel from Côte d'Ivoire, who's going to present the country experience. Il va parler en français, so if you're not comfortable in French, then use your headphones, your casquette. Alors, Monsieur le Docteur, c'est à vous.
Mr. Doctor, you have the floor, please. Thank you, ladies and gentlemen. All protocols reserved. I have the honor to present to you the implementation of the WICS project in Cote d'Ivoire. This project is based on integrated services in primary healthcare and is based on the fact that 75% of the cancer diagnostics of breast cancer and cervical cancer are also gaps. The WICS project provides the opportunity of integrated services and on women by bridging gaps and avoiding deaths, cancer preventable deaths. Concerning our intervention and results, it should be noted that an assessment of the need of health institution identified gaps in service provision and resources in the two priority districts, Abbeville and San Pedro.
Ok. Voilà. Oui. Voilà, c'est bon. Voilà. 3. 2, 3. 3. Voilà. Ok. Voilà. Non. Revenons. Voilà. Ça passe pas là. Ah, c'est pas pour moi.
Do give us a second or two. We'll pause the time.
We get to our slides. Côte d'Ivoire. Voilà, c'est ça. C'est votre pays, je crois.
Oui, c'est ça. Your country. You sure that you've got the right one now? As I'm saying,
concernant notre intervention et les résultats, il faut
the intervention and results needs assessment using the harmonized health facility assessment, identified critical service and resource gaps in the selected priority districts, namely Agboville and San Pedro. The key focus areas in this project was to equip the health establishments, build human resources capacities, improve data management system, conduct community mobilization, launch a navigation system to support patients and laboratories. Two national awareness campaigns, mass awareness and screening campaigns were conducted with messages in local languages. The services were integrated for screening and assessment of health problems, hypertension and diabetes. More than 1,700 women have been enrolled in this screening in 2 districts of the WICS project. At the national level, more than 3 million girls aged between 9 and 18 years have been benefited thanks to the HPV vaccination drive. There has been a deployment of DHS2 tracker for real-time surveillance. As regards the next steps, it is imperative to provide testing kits, HP testing kits, thermoablation devices, and ultrasound machines to address identified gaps, to support rapid finalization and rollout of the patient navigation and reference system, to fully deploy the DHS2 with real-time monitoring of automated reporting across weeks, and invest in sustainable awareness raising campaigns tailored to local culture in order to adapt the use of routine services between national campaigns and improve the request of services, and finally accelerate training efforts to reach 10,000 women by May 2026. It's on this note that I'd like to thank you for your attention.
Merci beaucoup, Dr. Agnero Nomel.
Thank you very much, Doctor. Doctor, the most important, tailored to local culture. That's very important.
Thank you very much.
Thank you.
Indeed, for giving us a picture from the Côte d'Ivoire. Let's go back to Kenya now. That's one of the 3 countries that were piloted under this particular project. And Dr. John Paula Bo Malenya will tell us how the Women's Integrated Cancer Services Program is working in that country. Thank you very much. Dr. Bo Malenya, please, over to you.
Thank you very much. Distinguished colleagues and partners, all protocols observed, good afternoon. I'm here to share our story from Kenya about the implementation and outcomes of the Women Integrated Cancers Project, which, as you saw in the video earlier, Kenya is one of the countries that is implementing. So in Kenya, breast and cervical cancer are the top 2 cancers actually overall. So they pose a significant public health challenge. Almost 30% the mortality and the incidence of these 2 cancers combined. And they affect women in the prime of their lives, ages 35 to 49 years. And the challenges that we have are that we have limited access to comprehensive cancer care and low uptake of screening services. And this results in late-stage diagnosis. The opportunity then that we saw with this Women Integrated Cancers Project is that it aligns with our National Cancer Control Strategy 2023 to 2027, which seeks to strengthen early detection, diagnosis, and treatment access. So I'll give you an overview of this project. We began with a joint needs assessment, which we did with WHO. We mapped the services, and this led to selection of 2 counties, Bungoma and Nyandarua, You may not be able to see them very well on that map, but we selected 4 facilities from each of these counties for this project as the pilot facilities. And we identified the work streams on guidelines similar to our colleagues in Cote d'Ivoire and in Zimbabwe as well. So we have guidelines, we have training, we have advocacy, we have data management, patient navigation, and laboratory and diagnostic support as our key priority areas. That photograph there is when we launched the initiative in Kenya in October last year. And what have we been able to do since the launch? We've been able to revise our national cancer screening guidelines and to bring together experts, multidisciplinary experts, really to develop training materials for this integrated approach. We have screened women over 1,000 in the counties, and we have also deployed the equipment. And one of those pictures there is showing Nyandarua County receiving the equipment from WHO. We have also built a capacity of 300 different, segments. We have media, we have healthcare workers, we have community health workers, and we have community champions as well trained. And what are our next steps? We are looking to strengthen patient navigation, sample tracking, also real-time cancer reporting, and all this to accelerate reporting our screening to 10,000 women. So my call to action for us is that let's build on this investment and strengthen technical exchange and cross-country learning so that we can ensure that every woman everywhere can access the care she needs to beat breast cancer and cervical cancer. Thank you very much.
Thank you very much indeed, Dr. Bomalenya. Thank you very much indeed for that. Giving us the BBC picture from Kenya. So let me thank our presenters just now and invite them to leave the table as we change a panel. So Dr. Bomalenya, thank you very much. Dr. Anyaro Nomel, thank you to you. Mr. Chuma, thank you. And Dr. Nyako, thank you very much. I'm now going to call up some other presenters because we're going to talk in more detail about the Beat Breast Cancer Project. Let me bring up Dr. Ernest Konadu Asiedu, who is from the Medical and Dental, well, he's the head of the Medical and Dental Unit, Technical Coordination Division, Ministry of Health, Ghana. Can we have Dr. Safina Yuma, who is a public health specialist at the Ministry of Health, Dodoma in Tanzania. Dr. Gertrude Mashashi, oncologist specialist, the Bugando Cancer Center, Tanzania, Mwanza. And we'll bring back Dr. Paul Chilwesa, Head Policy, Population Health and Health System Strengthening at Roche. Thank you very much indeed. I think that's probably the last time we're playing musical chairs now, but we still follow the program. So let's look at the BBC, the Beat Breast Cancer implementation in 2 particular countries. But before we do, let's get the overall picture from Dr. Parag Bamari from JPIGO, who will present a brief overview of the Beat Breast Cancer Project.
Thank you so much, Henry. Excellencies and distinguished delegates, very good afternoon, everyone, once again. I want to start with a request to each one of you to reflect upon a situation. A woman diagnosed with breast cancer in the United States has a 9 in 10 chance of survival. Travel across continents to many parts of Africa, and the story is heartbreakingly different. Fewer than 6, sometimes even less than 4 out of 10 women survive. For too many, it's not the disease, but it's long symptomatic periods, delayed diagnosis, limited access to treatment that turn hope into tragedy. These numbers are not just statistics. They represent lives which could have been saved with timely action. Beat Breast Cancer is our response to this urgent need. This initiative is built on 3 pillars: stage shifting, early diagnostics, and timely treatment, aiming to detect cancer earlier, accelerate access to care, and change survival outcomes for women across the continent. Today, I invite you to explore how Beat Breast Cancer is transforming the narrative, turning these stark numbers into stories of hope and survival. Beat Breast Cancer is anchored in the Global Breast Cancer Initiatives Framework, with the ultimate goal of reducing symptomatic period for breast cancer from current average of 12 months to less than 3 months. To achieve this, the initiative employs a comprehensive set of strategies that includes institutionalization of breast health awareness, saturating primary healthcare. Saturating primary healthcare capacities for early detection using clinical breast examination, decentralizing diagnostics, and then facilitating access to multimodality treatment. At the core, Beat Breast Cancer also drives impact through 3 key levers. That includes innovation, women-centered programming, and patient navigation pathways. The Ministries of Health in Ghana and Tanzania are leading the way in deploying Beat Breast Cancer interventions across multiple regions, demonstrating how these strategies can be effectively implemented on the ground. The efforts are also paving the way for national scale-up in near future. Importantly, this initiative is contextualizing the GBCI framework to each country's unique health system and community's needs, generating valuable lessons and learnings that can guide other countries and regions facing similar challenges. The initiative is structured around 3 major arms. The first focus on health system strengthening, spanning breast health awareness, early detection, timely diagnosis, and comprehensive management, while also enhancing patient navigation and recording and reporting system. The second arm incorporates implementation research, generating evidence and insights on what works best in real-world settings to inform continuous improvement. The third arm is dedicated to knowledge sharing and dissemination, and this very event is an example of that. Finally, since client is truly at the center of this entire work, Beat Breast Cancer focuses on strengthening systems to make this care journey smoother, more accessible, and closer to the women's homes. Every strategy is designed to reduce barriers, enhance convenience, and ensure timely support so that women receive care they need without unnecessary delays and hardship. Now, I'd like to invite our ministry colleagues from Ghana and Tanzania to share how they are leading implementation of Beat Breast Cancer, providing insights into its execution, challenges, and successes on the ground. Dr. Ernest from Ministry of Health, Ghana. Thank you, sir.
Thank you. Thank you very much, Parag. So the Beat Breast Cancer implementation in Ghana is anchored within the policies and strategies of Ghana. And so the National Health Policy in Ghana has a vision of healthy population for national development and ultimately follows with the universal health coverage that focuses on promotion, prevention, curative care, rehabilitation, and palliation, not leaving emergency and mental health. And out of that, we developed the non-communicable disease strategy in 2022, among others, focusing on cancers and breast cancer, together with cervical cancer as women's health is one of the prioritized areas. And so this work initially was supported by Rush when one district was taken in Bekwai to actually focus on a pilot stage of the work that would improve the access to cancer care, typically breast cancer. So as you can see on the screen, you clearly see that as far as Ghana is concerned, the work that currently going on, supported by Pfizer Foundation and being implemented by JPIGO, is a 3-year program that is also looking closely at selecting 3 different regions in the country. The first one in the southern part is Greater Accra, the middle belt is Ashanti region, and also the northern region is also focused a little bit more on the north. The period of this work is 3 years. And this initiative is basically aimed at early detection and treatment of cancers. For the purpose of this presentation, I'm going to look at 3 different strategies. The first one is basically looking at early detection at the community level, and that is also looking at integration of cancer care at the primary care level. And this is done through improving awareness among communities by co-designing social and behavioral change communication as far as materials that are culturally acceptable and context sensitive as far as media messaging is concerned. And the second one is also looking at improving access to quality clinical breast examination using the most efficient and clinical tool, which is the hand. And this is also looking at building capacity of the primary healthcare workforce at the community level, including the community health nurses, the midwives, physician assistants, and doctors. The second strategy, which is focused on timely identification and focusing on reducing diagnostics delay by decentralizing diagnosis, again, by improving access to diagnostics at the district level with the one-stop approach, where you're looking at a single visit that provides opportunity for imaging, biopsy on the first day, and reducing dropouts and loss to follow-ups. And this facilitates timely diagnosis by leveraging on technology. Currently, some tools, SOPs, and training materials have been diagnosed or currently underway for mentorship for the clinical staff. The third strategy, which is looking at access to multi-modality treatment, where the focus is on facilitating availability and uninterrupted access to treatment by addressing infrastructure, equipment, supplies, and human resources, and then also financing. And this will be done through partnerships, collaboration, and the ecosystem approaches. This gives the treatment options such as surgery, hormonal therapy, chemotherapy, radiotherapy, and targeted therapy. And all these innovative strategic approaches require financing, where in Ghana, we are using the National Health Insurance Scheme, which comprehensively takes care of women's health, including comprehensive breast cancer and cervical cancer. And then also the Ghana National Trust Fund, which is the Mahama Cares, that is also focused on chronic conditions. There's also dialogues and policy reviews and strategic partnerships. So there's a call to action that looks at partners collaborating to support financing breast cancer across the country. Thank you.
Thank you very much, Dr. Esiedu.
So I will call my colleague from Tanzania to also share the Tanzanian experience.
Good afternoon, everyone. All protocol observed. I want to share experience from Tanzania about this breast cancer project, which implemented in 5 regions in Tanzania, in 45 districts. However, this approach, in single visit approach, we are integrated in all facilities, hospital to do diagnostic services. Sorry, not my slide. It's not my first slides.
Let's see what we can do here.
Okay, sorry, I think they changed my slide, so I'll just explain to save the time. Okay, yeah. The project is implemented in the 5 region in 45 district hospital and the 126 facility. However, this project is focused in 26 facility, but we have integrated cervical cancer and breast cancer in more than 300 facility, but for purpose of this project, only for the 120 facility. After launching of the project, we managed to review our service delivery guidelines, which include 68 pillar for WHO. Then we review our monitoring tools to capture more indicator, because before it was not captured. Then we capacitate national trainers and healthcare workers so they can deliver integrated model of single visit approach where the women can do cervical cancer, breast, as well other intervention like blood pressure. Also, we strengthen our disease hub, 50 disease hospital, so they can be able to do diagnostic in timely. Also, with procurement of diagnostic machines, ultrasound, and corneal biopsy, so they can have access for early diagnosis. So number, I think the number is not here. After implementation, after launch, we managed to mobilize more than 6,500 plus women. Those of them, 7,500 plus, were do clinical breast examination. After that, 60% of them were just observed with abnormal results. After abnormal results, so they can go to do the diagnostic. So 62% of them, we managed to do timely diagnosis. We align with the WHO pillar, so within 60 days of the diagnosis. Among them, 58, we just diagnosed with the breast cancer disease, and then they started treatment on time. what's our lesson learned? Lesson learned after implementing this project, we see decentralization of this service, diagnostic services, can be really helpful to minimize the late diagnosis for the women, because we're using single orbit approach. When the women come, we do all this clinical basic examination and also the diagnostic. And then after identify them, we refer them for the treatment. We are lucky with 4 treatment centers in country, so at least we are struggling with that. But after 6 months of implementation, we think we can achieve this. Lesson learned, there are many, but I'm going to mention a few. Challenging the accountability, but as a ministry, we just sit in a driving seat, so we coordinate our partner so we can have a smooth implementation of the project, as well as another challenge is just patient navigation. Still, most of the clients, they don't have afford the diagnostic for the early detection. So we want to advocate for inclusion of the diagnostic in the health insurance, so they can be able to access this safety, because most of the women with low incomes, they can't afford this. What's our way forward? We are going to continue what we're doing, because we're in 5 regions and the 48 districts. So we want to scale up if resources available in the rest of the region. Thank you very much. Thank you.
Thank you very much. Indeed, thank you very much indeed, Dr. Yuma. Yep. So, Dr. Parag Bamara, thank you very much from Japago for leading that particular explanation of BBC implementation. And thank you very much to our other presenters, Dr. Isiedu and Dr. Yuma. So Dr. Isiedu and Dr. Yuma are staying with us. And we also have Dr. Gertrude Mashashi with us and Dr. Paul Chilweza from Roche as well, because this is now our sort of mini panel discussion, really, because we want to talk a little bit further and build on what we've just learned on WICS and BBC. I'm going to start off with Dr. Isiedu from Ghana. Just thinking about what you said there, what are the biggest hurdles, the biggest challenges in implementing effective HPV vaccination programs in Ghana and more broadly in African countries? And when you have succeeded, what have you done? What has helped you succeed?
Thank you very much. So basically, I would say that some of the biggest barriers are looking at inadequate information, misinformation, inadequate awareness creation, and some social cultural barriers. And for this, I would say that continuous public health education campaigns and then also community engagement are very critical for successes. Then it gives also an opportunity for survivors to tell their own story and how bad it was in the past and how good it is for those who have been exposed to these vaccines. Now, the second one is also about the high cost of vaccines and also its unavailability. So here, it's also important that partners will come together. There should be cost reduction and some subsidies, as well as regular availability of these vaccines integrated into the national EPI programs that are existing in African countries. The third one is also looking at challenges with the health system itself, where logistics, infrastructure, human resource, and also equipment as far as the cold chain is concerned. For Ghana, these will easily be implemented when it is integrated into the EPI program, and how to reach areas are also accessed in the same way that all the other vaccines, especially the childhood vaccines, are being implemented in the country. So generally, if this can be done, then one, school-based vaccination is very important because a lot of the countries, and typically in Ghana, all children at that age between 9 years and 14 years are in school. So it means that collaboration with Ministry of Education is a very important thing that we need to do. This particular cohort to vaccinate. Then partnerships and collaboration is very important using the multi-sectoral approach. And like I mentioned, in Ghana, we are very religious, and a lot of, I think, most of the other African countries. So various religious institutions and their leadership will play a very critical role. Traditional leaders, because again, we live in communities where we are more coordinated by the community structures and the traditional leaders. So that also is very
Can I make a quick intervention? You heard the President of the Republic yesterday talking about people believing in strange things and being skeptical of scientific wisdom. And he said, look, I'm liberated. Sometimes with the traditional rulers, they're the ones who can be most skeptical, and the religious leaders too. How do you overcome that? Is that something that you've had to take on as well?
Thank you very much. So that is where the partnership is important, because the idea for a traditional religious person is also to bring healing to the people. Scientifically, the Orthodox system intends to also bring healing to the people. So there is a need that we come together, collaborate, and work towards what we can do. So when we work closely with these religious and traditional leaders, it is possible that we can make that. And then the Ministry of Gender, as far as the local government structures are concerned, so the Ministry of Health, Ministry of Education, Ministry of Gender would play a critical role in ensuring that we can achieve what we need to do. Thank you.
Tremendous. Thank you very much for the picture from Ghana there, Dr. Siedu. Dr. Safina, we've just heard from you talking about what's going on in Tanzania. Let's talk about gender equality and social stigma. How do they impact the early detection and treatment of breast and cervical cancer in Tanzania and more broadly across African communities? And as Dr. Siedu was hinting at, what measures are you taking to try and deal with these issues?
Okay, thanks very much for the question. Actually, the gender inequality and the stigma just play a greater role in public health concern about the early detection in cervical, this women cancer, cervical and the breast cancer. So start with the inequality, gender inequality. As you can see, most of the women, they don't have rights in the decision making in their own health. So women, most of the African communities, including Tanzania, especially in rural setting, the men, they have just on the whole house issues. So even they want to go to the hospital or to seek financial support from the husband, they need to ask for their husband, and sometimes the husband, they're not supported. Likewise, in the stigma, these two diseases are associated with stigmatized in the community, and sometimes they hide their symptoms because of the nature of the diseases associated with so many things, and they end up present with a late stage in the treatment. So what can we do in the particularly to address this issue? The issue, I think you can use the multi-level approach. So to start with the individual level, household level, to police level. In house level, you can just empower, because of the gender inequality, so we can empower women to have autonomy in their health-seeking behavior, and then to engage men so they can support their husband and family for health issues. As well, we can do like community level, we can develop communication education material according to culture appropriate. In Tanzania, we have in Swahili. So this material is developed in Swahili, so we can capacitate healthcare workers, so can go in the community to educate the community, as well traditional healer, because most of the time this end up with the traditional healers. So we can capacitate them. Also, they know importance of the early detection. Also, we can use survivors. Survivor can be as a promoter, as a champion to promote, because they are already got their story, they have the disease, so they can be the champion to address, to reduce the stigma to the women. And then we can use like professional association. We have the Women Association in Tanzania. So that's the can have a subject matter, because the expert can explain, can use the various channel media to deliver the right message in the correct. So in the police level, I think we can decentralize this service to more in the community, like we did in the district. We capacitate all the district hospitals so they can do timely diagnosis, they can access it, so it can be in the single visit approach. So even the women can access with the affordable price. And also we think we can promote inclusion of this diagnosis service. Most of the time there's a cost to inclusion in the National Health insurance, so they can reduce the out of pocket, because some of the women, they don't have a financial capacity. So I think you can do that.
Thank you very much indeed, Dr. Savina. Just a very quick supplementary. Imagine if I'm a difficult male. I'm in Dodoma, and I think that my wife should be controlled. I don't really care about my health. Why should I care about her health? How do you convince me that it's going to help the whole family? I'm a difficult male. I don't like talking about health.
Yeah, of course, male also they're difficult. So we try, like in these survival groups, not only for the women, also include men. So we just do health talk. So we just educate women, men. We have do many male involvement, so we can capacitate, educate, important for early detection. Because at the end, the one who can suffer, maybe if the women can die, they can become widow, and the children can suffer. So we try to engage male involvement to educate them on importance of early detection, and to support their family for the diagnosis and the treatment. Thank you.
Josephina, I'm a difficult male, but I've been convinced. Thank you very much indeed. Let's talk to Dr. Gertrude Mashashi, also from Tanzania, but I'm going to ask you to pull back from the country perspective and look more broadly at the continental perspective. You can't see me. Let me stand up and move over here. In fact, better here. But just thinking about this, Dr. Gertrude, from the continental perspective, how would you assess the current state of healthcare infrastructure across the continent vis-a-vis cancer care? What are the most critical improvements we need to enhance, to improve breast and cervical cancer treatment outcomes? Because at the moment, they're really poor and they need to be much better.
Thank you so much for that wonderful question. First of all, we have a rising incidence on both cervical cancer and breast cancer. Cervical cancer being the #1 cause of mortality, and the breast cancer, they present at stage 3 and 4 disease. We also have limited diagnostic capacity, including ultrasound and mammography. Again, in terms of infrastructure, we also have a limited number of pathologists which are required to make the diagnosis of cancer. Also, we have a weak cancer registry system. And we have fewer treatment cancer centers, mainly are located in urban areas. Also, we have poor access to radiotherapy, which is a critical component for treatment of both cervical and breast cancer. Again, we have lack of trained personnel and limited access to chemotherapy. So this is a problem in all Africa countries. So what are the area of urgent improvement? We need to expand HPV vaccination by using a single dose, like what the GAV project is done in Tanzania and Nigeria. We also have to integrate cervical and breast cancer screening. Also, we have to promote CBE and health education in areas where mammograph are not available. We also have to train the radiographer who have a basic knowledge of ultrasound to do a small part ultrasound, of which this one we have able to achieve through a BIT project. We have able to train the radiographers and healthcare workers on how to do CBE and how to do ultrasound in areas where mammography is not accessible. Also, we have to invest in diagnostic capacities. Through BIT projects, we are able to purchase a portable ultrasound so we can move and do a single visit approach in which women will be screened for cervical cancer and breast cancer, and they have diagnostic services at the single visit so as to reduce the dropout. Also, we have to train the healthcare professionals and health workers on delivering of cancer services. Again, we have to expand health financing by doing a universal health coverage so as to cover the cost of the cancer treatments. Also, we have to integrate or to intervene with artificial intelligence and telemedicine for specialist consultation and tumor body discussion so as to expand cancer care. So I'll urge to build a future where every woman, no matter where she lives, she could get good access to cancer care.
That's the ideal. Let's say a woman gets the first wave of treatment and she's responding well. She's been reached in a timely manner and not at stage 4. We hope she's on the path to recovery. What about rehabilitation? Because that's essential It's one thing to have the medicine, but also what about the rehabilitation to be nursed back to full health so you play your full role in society and with your family? Let's talk a bit more about that, the role of integrating rehabilitation in the proper comprehensive management of breast and cervical cancer care.
Okay, with increased early detection and improvement of cancer care, more women will be surviving with cancer. So these women, they suffer psychological, physical, and emotional stress. So integrating rehabilitation in these services should be a continuum of care, so as to help these women to cope with these cancer-related complications, including chemotherapy, radiotherapy, even surgery. So for example, for women with breast cancer, they suffer from lymphedema. So early physiotherapy should help these women to recover from the lymphedema. Also, we should integrate services. We should do more psychological issues like how do I live without my breast? Also fear of having a recurrence or being left out because my breast is gone. Yeah, so also in terms of sexual dysfunction, women with breast cancer, they suffered that problem. They have a vaginal dryness. So you have to integrate rehabilitation in all phases of continuum of care. So the Ministry of Health in Tanzania has managed to integrate rehabilitation services. And in the future, we hope it should be included in national NCD programs.
Thank you very much for that answer, Dr. Gertruda. Let's finish with Dr. Paul Chilweza from Roche. And I suppose because you're here, essentially representing a big pharma company, and I don't mean it in that way, you understand what I'm saying, but it's a term everybody recognizes. So you're a partner, and we want to know, let's focus on the role that international organizations and partnerships between both the public sector and the corporate sector, what role does it play? Could it play better in supporting breast and cervical cancer prevention and treatment in Africa?
Thank you very much. I think I want to start off by, bringing back the open remarks from the RD. And he said, we are building the same house. Let's not fight over the bricks. And when we talk about breast and cervical cancer in Africa, we need to name that house. And I saw on the video, I think it's the first time I saw it, the statement by the Minister of Health of Zimbabwe, and thanks for that. This is protecting the future generation. If we have to name the house of breast and cervical cancer in Africa, that's the name. And right now, I think we're all bringing in bricks and we're not talking to each other. I think that's the starting point. So I don't know if we're building the same house or we're all building houses that might not have a roof at the end of the day. So I think from the private, maybe I want to create private sector element is from international organizations, one thing we take cognizant of, and I think this is why we're here, WHO invited us, all of us here, and we're here, is that these international organizations have, one, the convening power. I think we all know why we are here. Second is credibility. When we read the WHO document, I think we can all sign to that of what it will do for the communities. And the third part is technical standards are set very well. So we know the outcomes from what my colleague has just mentioned. If we follow that, there's a chance of improving survival for that. I think when we take it a notch down to partnerships and collaborations, I think one of the examples is Weeks. The other example that we're talking about is Pen Plus and Beat Breast Cancer. But we do have, I think, a lot of examples that we could show that partnerships, collaborations is what to take us the next step. We've seen this in HIV. I was a very young physician, I should say I'm a physician by training. When HIV was one of those where we had a diagnosis and we gave counseling because there was nothing else. Collaborative approach, which created what we call Global Fund now, landed us where we are now. No one is so scared when they have HIV than it was 20 years ago. So I think we need to look at that more critically and be at the same table where we are sharing what bricks we bring to the table and be very clear of who owns that coordination. The last element I think I want to share to that question, I think very critical question, and following the deliberation that have happened at this RRC, is that all these things will only happen at the national level, regional level, if they're in the priorities of the national plans. It doesn't matter how good my proposal looks like that Roche or myself would bring to the country. If they're not a priority, we will not achieve that outcome. And I think we are able to achieve that outcome, but we need to talk to each other and be very collaborative. Thank you.
Great. Thank you very much indeed for that. And Paul, just one very quick, I suppose, supplementary. When Roche comes in, are people clear about what your role is, what your mandate is? Or do they think, Roche, big pharma, money to pay for our programs? What do they understand why you're there and what you want to partner on?
Thank you for that question. I think we haven't reached that level of maturity in our interactions with countries, to be very transparent. There's a transition period that the world is going through. And one of that is, if you look back in the 90s or when I started medicine in the early 2000s, pharmaceutical companies were seen as providers of healthcare commodities. Transitioning that to being seen as a healthcare partner who contributes beyond transaction, that is still going through a lot of maturity building, and every country is at different levels. And we've been proud to show some of these examples. And I'll quickly give an example in Nigeria where we saw the Cancer Health Fund to reduce catastrophic funding out of pocket. And that was a pure collaborative approach between civil society, government, and private sector. Have that achieved the outcome? Not yet, but they have created a pathway on what we can learn from.
Great example. Thank you very much indeed to our panel, Dr. Paul Chilweza, Dr. Gertrude Mashashi, Dr. Ernest Konadu Esiedu, and Dr. Safina Yuma. Thank you very much to our panel. That was a great discussion. Thank you very much. And only one person standing between you and your portable lunch, which will be served outside in a few minutes. It's a nice way to set you up. Dr. Tirone Desta Alamrewu, who is the WHO representative for the Republic of Zimbabwe. He's going to give the closing remarks. Dr. Tirone, please.
Thank you very much, moderator. My task is brief and simple. You have heard from the panelists, also from early presence, but we are talking more about NCDs in general. NCDs are actually growing a challenge in the African continent. And from the examples that were presented from countries, experiences, we have seen good progress, but it's not even. In some countries, there's very good progress. In some countries, they are still lagging behind. But there are many more countries that are not presented here that we don't know much about, and they still have to do a lot. So this is a session, as my regional director said, it's a session to catalyze the discussions and continue the discussions and do better on regarding NCDs. The African continent, unfortunately, where we are grappling with communicable diseases that have been there for many, many, many years, we are now carrying the burden of non-communicable diseases. And we are not getting enough resources. Recently, there's been promising trend, but now things have changed also over the past few months. Things have changed regarding general development assistance from the traditional partners. So the 10+ strategy has shown very good promising results in some countries. So we have to pursue this in more countries, not only those countries, but more countries to address the issue of NCDs. And we need to not forget also what we used to call PUPEN, which we have not mentioned in this session, which is supposed to be addressing issues at more peripheral health facilities, but regarding the same NCDs. These are complementary approaches that we should actually pursue. And our services should be people-centered. A mother who comes for services to access for a certain type of service should not go home without getting the services that she needs in other aspects of health that she may need. So integrated people centers services are very, very important. The good thing is we have the knowledge and the tools for most of the problems that we are facing in NCDs. But the challenge we have is to bring the services to the periphery where the communities are. And for that, we need extraordinary effort. We have to double our effort. In the face of declining overseas development assistance, we have to come up with a sustainable solution to address this big challenge, public health challenge. So therefore, while I'm concluding my remark, I would like to appeal to all members presented here in the African region and also partners present here and who may not be present here to double their efforts. NCDs are a reality. We are facing a challenge, but we are, as my regional director said, we should not allow anybody to die while we have a solution for the problem. That's what it is. So we have to double our efforts to address issues of NCDs. I thank you very much for your kind attention.
Thank you very much indeed for that, Dr. Emero. Thank you very much indeed. And there's only one more thing to do before we go and have our lunch, is to get all the panelists and presenters to come to the front and then take a picture with the regional director, Dr. Janabi, so that the paparazzi can have their moment. So could you please all come to the front here and take the picture? Thank you very much. Thank you very much. So that's all the presenters from the beginning. So the last four panelists, Dr. Parag earlier as well, Dr. Anyiro Nomel, Dr. Bo Malenya, Dr. Kisaka, Mr. Chumia, Dr. Nyako, Dr. Nyako, there, Dr. Mr. Chuma, Dr. Kisaka, Dr. Anyiro Nomel, Dr. Bo Malenya, all the presenters from earlier. The RD, of course. All the speakers. Here we go. Good session. Your equipment is better than being too long. That's why they gave me the supplementary, because it builds on what the president was saying. It builds on my own family experience and possibly yours as well, because it's been one of the biggest impediments to get for healthcare for our family, but not just in the massive area, but also the people who are supposed to be more sophisticated in our craft.
Surtout le moment de la saison de pluie, il y a la présence de certaines mouches et le fourreau. Hein, mais ça nous dérange. Auparavant, on avait des problèmes de la vue. Nombreux, la population se sentait plus bien, ne voyait plus bien. Et les gratter, les gens grattaient n'importe comment.
La stratégie mère reconnue aujourd'hui pour lutter contre l'onchocercose, c'est la distribution de masse de médicaments. Les médicaments sont donnés gratuitement au Congo. Nous recevons du médicament des partenaires par le truchement de l'OMS.
Mon travail consiste à éduquer, à communiquer avec la population, à leur inciter à prendre les médicaments qui sont nécessaires pour la vie. C'est une occasion qu'ils nous offrent, que l'OMS nous offre, pour que la population soit en son parfait état de santé.
Na melikisi oninganga bayi apesinga kisi na mili na melikisi yango oyo apesinga kisi na mili donc yango oyo malade nanga ekumi kosila donc aza sili koye kosila sikoyo nazo grate mais lokola apesinga kisi nazo grate lisusu te.
Eliminating onchocerciasis prevents the physical disability from blindness and just chronic illness, and enables communities to participate in economic activities that will improve their social well-being. Eliminating onchocerciasis is about improving social inequalities that exist in our communities.
Há 2 anos atrás, nós começamos uma atividade de busca ativa no terreno para descartar os casos de ancianias em São Tomé e Príncipe, para termos melhores dados e assim tentarmos concorrer para a eliminação.
Nós temos pacientes que são triados por enfermeiros. Estes pacientes têm manchas, que é uma das características um dos sinais, né, que podemos dizer, que nos orientam para que o paciente tenha ou não suspeita desta doença, que é a hanseníase. E aí nós começamos a examiná-los, fazendo questionário.
Good afternoon. This is the English channel being tested.
Em 2016, a criança era menor de 5 anos e foi diagnosticado com lepra. Esta criança ainda está até hoje sobre os nossos cuidados e vamos vendo, seguindo a criança para saber em que ponto de situação está. Hoje a criança já tem seus 12, 13 anos.
Ela internou, essa médica começou a seguir ela, fez ela tratamento, mandou para fora, mas por 2 vezes, como alta, e para casa.
Testing English booth testing 1, 2, 3.
Tivemos 2 consultorias internacionais neste âmbito onde nós podemos fazer algumas formações nos nossos técnicos das áreas de saúde e assim melhorar essa busca das pessoas com possivelmente a ciência.
You know, almost half of the world's population and nearly half of Africa's population is affected by oral diseases. Over the last 3 decades, the African region has battled a growing oral health crisis. Globally, the region has witnessed the highest increase in cases of toothache.
Bonsoir, chers tous. On va reprendre.
Good afternoon, distinguished delegates. We are going to resume our proceedings.
Donc, je ne sais pas si tout le monde est rentré. Et nous allons commencer par la République centrafricaine.
We'll begin with the Central African Republic, followed by Seychelles.
Le minuteur soit un peu changé. C'est 2 minutes que vous aurez.
You'll have 2 minutes to make your statements.
La République centrafricaine est là.
If the Central African Republic is there, kindly take the floor. You can begin. Thank you, Madam Chairperson. The Central African Republic congratulates the Secretariat for the quality of the document presented. Like is the case with many countries, we are faced with multiple health crises. We've had yellow fever, measles, mpox, epidemics, as well as natural disasters like floods and the massive displacement of populations. This, of course, makes our health systems more fragile, and our systems depend on external funding and have low human resources. This means that we need to build integrated and resilient health systems. In response, the Central African Republic has undertaken a number of actions, including the third generation document to the districts of the country, then the review of universal health coverage and the capacity building of health personnel using the One Health approach. However, a genomic surveillance and sustainable funding of health safety systems remain very weak. We request the WHO to increase technical support, and especially for genomic surveillance, and as well as reinforce cross-border activities. The Central African Republic commits itself to working with all the WHO member states so that they're better prepared for health emergencies. This CAR supports the strategy proposed by the WHO that aims to strengthen Africa's health security and invites other countries to also adopt the strategy. Thank you, Central African Republic. Seychelles has the floor, and Benin will get ready.
Honorable Chair, the government of Seychelles has reviewed and proudly endorses WHO Afro's strategic approach to achieving health security by 2030. This roadmap is not only visionary, but also innovative, integrating cutting-edge solutions with proven strategies to safeguard our region. Key to this success is partnership. Partnership between governments, regional bodies, and global health agencies, thus ensuring collective actions against health threats. Seychelles recognizes the power of collaboration in strengthening surveillance systems, particularly through the Integrated Disease Surveillance and Response Framework, which enhances our ability to detect and respond to outbreaks swiftly. The recent crises in the region, from pandemics to climate-related health risks, underscore the urgency of this mission. By investing in resilient health systems, workforce capacity, and cross-border cooperation, we can mitigate future threats before they escalate. Seychelles is committed to this journey. Together through innovation, partnership, and robust surveillance, we can secure a healthier and safer Africa by 2030. Thank you, Madam Chair.
Merci aux Seychelles.
Thank you, Seychelles. Benin has the floor. Senegal should also get ready. Thank you, Madam Chairperson. Congratulates the Secretariat on the proposed framework for implementing health security strategies in the WHO African region. In recent years, Benin has been involved in reforms and innovations to strengthen health systems. This includes the creation of a public health emergency operations center, which is progressively taking off, construction of 4 departmental epidemic treatment centers, and the ongoing construction of 2 more to cover every region of the country. We are trying to cover all infectious diseases. There are other interventions, such as the construction of the constitution, rather, of rapid response teams in all departments and health zones using a One Health approach. The procurement, so the training of epidemiologists at all epidemiologists, the procurement of 188 ambulances at once in 2024 for the transportation of patients and for response to emergencies. The implementation of community health with 13,000 community health workers, which is 1 worker per 200 households. And we are also ensuring daily surveillance of diseases with epidemic potential at family level and the provision of electronic reporting in case of detection of cases. Benin believes that our health systems can significantly reduce the impact of health emergency, and we call for the strengthened regional solidarity to establish resilient systems and foster partnerships. Senegal has the floor, followed by Angola. Thank you, Madam Chairperson. Ladies and gentlemen, we carefully reviewed the document AFR-RC 7510 on strengthening Africa's health security, enhancing event detection, building resilient systems, and fostering strategic partnerships. Our country I looked at the challenges and the actions proposed. We need to have all actors at the intermediary and local agents in IDSR. We need to look at event-based surveillance and the integral digitalization of the epidemiological surveillance using DHIS2. We have a laboratory network with a national reference laboratory that has a good genomic surveillance capacity, but we need to improve the capacities at intermediate level. We have a program to strengthen national public health laboratories and reference laboratories. Concerning funding and partnership and cross-border management, we are working closely with partners and neighboring countries to improve health security. Similarly, we are working towards strengthening human resources so that they are of quality, and especially for disadvantaged regions.
Mesdames, Messieurs les délégués, le Sénégal félicite à nouveau les acteurs et s'engage pour un renforcement de la sécurité sanitaire.
Would like to support health security.
Recording stopped.
Thank you, Senegal. Angola has the floor, and Zambia should get ready.
Thank you very much, Madam Chair. Angola would like to welcome this document, which has been presented this morning. And we think that it falls in line with one of the pillars that is very relevant, that is reinforcing health security in Africa. Angola is committed to strengthening vigilance and surveillance centers and different methods. And we have been putting this into action at a national and provincial level. We're committed to strengthening rapid response and multidisciplinary teams. We've also been expanding our network across the country, especially when it comes to communication capacities and transport. We've also been strengthening implementation of One Health. This is not an exclusive responsibility of health ministers, though. It requires coordination amongst all the different sectors. This requires effective. It also requires strategic thinking. So governments, partners, WHO, UNICEF, Africa CDC, regional institutions, technical partners and financial partners, all of them play a pivotal role at a time of crisis especially. So improving health security is vital when it comes to socioeconomic development. It also raises the confidence of citizens in health institutions. Angola is ready and willing to play its role and to coordinate its efforts with other member states. Thank you very much.
Thank you, Angola. Zambia has the floor and Kenya should get ready.
So, Chairperson, Zambia supports the agenda of strengthening health security in Africa through the following: enhanced events detection, resilient systems, and fostering partnerships. Why support the agenda? The changing epidemiological profile of disease, climate change effects, geopolitical dynamics, and lessons learned from the recent outbreaks. In enhanced events detection, in this area, Zambia has increased surveillance activities at health facility and community levels. Zambia is also implementing an event management system. In terms of resilient systems, Zambia has fully operationalized a National Public Health Institute, which is providing the brain power to manage emerging threats. The institute's capabilities are also replicated to sub-national levels. In terms of human resources, Zambia is expanding in terms of numbers and skills. In terms of laboratories, Zambia is expanding laboratories with capability of multiplexing capabilities. Zambia is also increasing biobanking in various places of the country. Zambia is also investing in electronic information systems across many areas using the concept of interoperability. Fostering partnerships, Zambia argues for partnerships in the following areas: research and development, surveillance systems, technology transfer, information exchange, medical countermeasures, and in artificial intelligence. And we are asking for these partnerships between both bilateral and multilateral partners. Let us leverage each other's capabilities. Thank you.
Merci beaucoup, la Zambie. Thank you very much, Zambia. Kenya has the floor, followed by Mozambique.
Thank you very much, Chair. In 2024, we heard that Africa faced 150 public health events, which were mostly driven by outbreaks, climate shocks, and complex humanitarian crises. As such, Africa and the world at large is managing more than just diseases, but we are managing compounded risk. We therefore fully support the call to enhance event detection, build resilient health systems, and foster strategic partnerships around the region. However, we remain concerned that response to Africa health emergencies are still being primarily coordinated from outside Africa. And surveillance is now to be coordinated from the WHO hub in Berlin. We therefore call for Africa-based hubs to be prioritized and allocated the necessary resources to deliver their mandate. Albeit all this, Kenya continues to strengthen its IDSR systems and is progressively implementing the third edition of the IDSR technical guidelines with a scaled up electronic IDSR in counties as we continue to respond. Kenya is also prioritizing evidence-based surveillance, electronic community health information systems. In addition, Kenya is also conducting community evidence-based surveillance and hospital-based surveillance in 19 out of our 47 counties.
We're also proud to state that Kenya has a One Health platform, which captures threats across the human, animal, and environmental sectors. And we also have the genomic sequencing surveillance through our national public health laboratories and our research institutions, which will be extremely critical in the pathogen access and benefit sharing instrument being developed under the pandemic agreement. Chair, Kenya views universal health care as a foundation of resilience, and therefore we call for continued support of enhanced partnership and financing by broadening diverse strategic partners for an active engagement with relevant stakeholders. Thank you.
Merci au Kenya.
Thank you, Kenya. Mozambique has the floor, and the Democratic Republic of Congo will be taking the floor next.
Thank you very much, Madam Chair. All protocol observed. We welcome the document as Mozambique. In our country, we invest a lot in surveillance, human capital, and with the support of the WHO, we are busy operationalizing a network for public health events. We are building the capacity of healthcare workers so that they can use open source data, with the emphasis being placed on disaster management. We think that event detection can be done effectively using technology, such as digital systems. Mozambique has made progress in integrating digitalization into its processes. This includes being applied to event detection. We also believe in strengthening laboratory capacity. We've expanded these services to each part of the country. We also have been ensuring that services are faster and more reliable for pathogen detection. Healthcare workers and emergency responders are fully integrated into this process. We also focus on early warning systems. In this way, we aim to overcome the challenges despite limited financial resources. We also want to ensure that we have financial sustainability. It's also important for us to continue expanding the network to the most far-flung regions. We welcome the document. We look forward to going forward on this work. Thank you very much.
Merci, Mozambique.
Thank you, Mozambique. The DRC, followed by Tanzania. Thank you, Madam Chairperson. The DRC approves the Secretariat's report of the item under review. In the last decade, we have gone through various epidemics, including Ebola virus, yellow fever, and measles, including others. We are now going through an mpox and cholera epidemic. We note that there is a persistent insecurity in the eastern part of the DRC for over 3 decades, and this has led to millions of IDPs and a continued humanitarian crisis. To combat all these events, the government of the DRC has put in place sustainable structures to respond to various emergencies, particularly the National Public Health Institutions creation that houses the PHEOC, the surge initiative with technical support from the WHO has also been put in place. The training of RRTs and the training of public health officers in emergency operations, and as well as IDSR Edition 3. We have a platform to visualize data while respecting the One Health approach. The timelines for investigations has been shortened, and we've managed to increase UHC. However, despite the efforts deployed, the DRC continues facing several challenges, particularly with regard to environmental surveillance, the establishment of a laboratory network, and the strengthening of digitalization. The DRC would like to express its gratitude to various stakeholders, including the WHO, for the support in terms of technical and financial assistance to improve health security. Thank you. Thank you, DRC. Tanzania has the floor, and then South Sudan will follow.
Thank you, Madam Chairperson. The United Republic of Tanzania reaffirmed its commitment to strengthening the early detection of health threats, building resilient public health systems, and fostering strategic partnerships for action. We have enhanced disease surveillance across all levels with trained health community health workers reporting through mobile-based platforms supported by citizen input via a dedicated hotline. The nationwide rollout of the third edition of IDSR guidelines improved real-time event detection and response to public health events. Chairperson, Tanzania has also advanced its laboratory capacity by installing two genomic sequence analyzers and training of personnel. These efforts enabled the timely confirmation of the Marburg outbreaks with genomic data, which was shared transparently and submitted for publication. Given our strategic location with many borders, Tanzania is emphasizing on regional collaboration. We are installing digital infrastructure at the key points of entry and aligning with international health regulations to enhance cross-border surveillance and emergency preparedness. We are progressing towards interoperable data systems supported by multi-sector collaboration and exploring artificial intelligence-driven tools to improve early warning and One Health surveillance. Recognize the importance of human resources. Tanzania has launched the Integrated Community Health Workers Program and continues to invest in epidemiology and laboratory sciences through the Field Epidemiology and Laboratory Training Program. Tanzania thanks WHO and partners for their support and aligns with the technical papers recommendations. We look forward to continued collaboration with global and regional partners.
Merci à la Tanzanie.
Thank you, Tanzania. Thank you, Tanzania. South Sudan, you have the floor. Burkina Faso will be next.
Thank you so much, Chair. South Sudan supports the document presented on strengthening Africa's health security, event detection, resilient system, and strategic partnerships. South Sudan has made a number of strides in terms of surveillance. We have rolled out IDSR third edition to all 100% states and 100% counties. We have also established electronic disease reporting, the EWAS and the IDSR, and is in the process of rolling out community-based surveillance training in 40 of the 80 counties. Cross-border surveillance is well established with 5 of the 7 neighboring countries. Laboratory diagnostics capacity is growing. In terms of preparedness and resilience, we have national risk profile and multi-hazard preparedness and response plans developed. We also have preparedness and response plans for all hazards listed on the national risk profile. We have also launched the One Health strategic plan and One Health multi-sectoral coordination platforms at national level and 7 of the 10 sub-national states. With regards to workforce development, there is the field epidemiology training established in country, completing 7 cohorts on basic course, and are now currently running the first cohort of the intermediate FETP training. South Sudan has made significant progress in surveillance, RRT deployment, preparedness planning, and One Health integration. Sustained investment in resilient health systems, equitable workforce distribution, and emergency readiness is essential to protect South Sudan's population from future health emergencies and advance universal health coverage. Therefore, I would like to bring to your attention, Chair, that South Sudan aligns with the proposed actions of strengthening Africa's health security in event detection, resilient systems, and strategic partnerships. Thank you.
Merci au Soudan du Sud.
Thank you, South Sudan. Burkina Faso has the floor, followed by Comoros. Thank you, Madam Chairperson. The delegation of Burkina Faso congratulates the Secretariat for the quality of its report, which highlights the challenges the region faces. Burkina Faso is stepping up strategic actions to strengthen health security, specifically its capacity for early detection of public health events, as well as integrated being implemented in all districts supported since 2021 by a technical guide aligned with the WHO's guidance and the introduction of event-based surveillance. In the same vein, the Health Emergency Operations Center that has been operational since 2018 manages crises, while the One Health platform created in 2020 promotes intersectoral collaboration to improve multi-sectoral coordination. As part of the international health regulation, Burkina Faso established a national focal point in 2024, completed a second IHR joint external evaluation in 2024, and developed a national action plan for health security for 2025 to 2029. My delegation would like to urge the WHO to strengthen basic IHR capacities through training, technical assistance, and institutional development, as well as diagnostics and genomic capacities. In conclusion, the delegation of Burkina Faso takes note of the measures proposed in the document. Thank you. Thank you, Burkina Faso. Comoros has the floor, followed by Algeria.
Madam Chair, we are an SID. As Comoros, we are exposed to cross-border transmission, as well as natural disasters, climate change, human mobility-related problems. And in last year, our country was faced with an imported cholera epidemic, and this goes to show how vulnerable we are. This took place in a situation marked by multiple risks, such as emerging illnesses and diseases, as well as climate change-related pressure. And this shows that we need to improve early detection capacities. We also need to strengthen the healthcare system. We don't have a national laboratory. The One Health approach is important. So we intend to work together in order to see the regional strategy of the WHO be fully implemented, because it's an opportunity for Comoros to improve its capacities when it comes to responding to events. In this line, we have implemented various different actions. For example, we have SMR focal points now in every region of our country. We've also been strengthening surveillance capacities. We have made sure that SMR guides are available digitally and in paper format. We have been evaluating our capacities, and during the cholera epidemic, we looked into how we could use community-based reporting formats and technologies. We have also strengthened the capacity of laboratory personnel when it comes to genomics sequencing. I thank the Comoros. Algeria.
Bonjour. Merci, Madame la Présidente.
Thank you, Madam Chair. Good afternoon. I would like to thank the Secretariat for the report. I would like to share examples of a few measures that my government has taken to strengthen health security. When it comes to the resurgence of certain pandemics, including COVID-19, Algeria has opened an autonomous independent agency. It forms part of the healthcare system and is focused on early detection. It also takes into account the effects of climate change on health. The National Health Security Strategy was established by the government for 2025-2030. It is based on promoting a proactive approach of healthcare resilience, and it is also based on an integrated approach. It aims to bring a balance, animal and human health. Last July, we concluded an agreement with the Ministry of Research and Technology in order to strengthen research into health security. And finally, the agency has started publishing a weekly information bulletin. Thank you very much. I thank Algeria. Thank you to all distinguished delegates. We have no more requests for the floor. If that is the case, where do you see this flag? Madagascar. Madagascar, you have the floor. Thank you, Madam Chair. Madagascar welcomes the work done by the Secretariat. In 2021, we reached an important milestone as we adopted the third edition of the guide, and we have updated our work on this. We have been investing in our ability to detect events on an early warning basis. We have an early warning and emergency response center in place now. We have consolidated our approach. It is multi-sectoral. We now have qualified human resources, such as epidemiologists, who are part of the surge teams. Madagascar is also committed to digitalizing its health surveillance teams, and we now collect data on all key sectors of the One Health. We also undertake simulation exercises to ascertain our levels of readiness. We submitted our GE report on the progress made. However, we do face major challenges. Strengthening health security and improving the quality of our laboratories is necessary to respond timelessly to public health events. Despite these challenges, we remain committed to strengthening health security. We are willing to create a resilient system which is capable of detecting the emergence of health threats. Thank you. Thank you, Madagascar. I now invite member states of other regions, UN agencies and other IGOs to raise their nameplates if they wish to take the floor. Let me remind you that you have 1 minute. I see IAEA for now. You have the floor.
Thank you, Madam Chair. Since the launch of the Race of Hope in 2022, 41 African member states have joined Race of Hope initiative for regional capacity building. Currently, 3 anchor centers have been recognized in Africa, Algeria, Morocco, and South Africa, while Egypt is expecting to sign shortly. The contribution made by the donors and partners for the first wave participating countries have enabled both short and long-term training for radiation medicine professionals in Africa, including in Benin, Chad, Kenya, Malawi, Niger, and Senegal. In addition to medical equipment have been procured, including 2 linear accelerators in Kenya, 1 in Niger and 1 in Malawi and shielded cyclotrons in Benin and Senegal. But none of this can happen without the effective partnership and investment. That is why the IAEA is engaging with member states, international organizations, and international financial institutions such as African Development Bank, OPEC Fund, and the private sector to unlock resources and scale up impact. Thank you.
Merci.
Thank you. Thank you very much for your contributions. I understand that several non-state actors have requested to deliver statements on this agenda item, and I now invite them to take the floor. We are going to start with International Society of Physical and Rehabilitation Medicine, ESPRM. You have the floor, 1 minute.
Thank you, Chairperson. Distinguished delegate, ISPR, a member of the World Rehabilitation Alliance, the WHO State Network, notes the priorities in strengthening Africa's health security technical document. Rehabilitation and assistive technology must be part of preparedness and recovery planning to enable people to regain functions, return to daily life, and contribute economically after emergencies. We therefore call on member states to integrate rehabilitation and assistive technologies into health security strategies as core element of resilience and develop strategic partnership with key rehabilitation actors at local and global level to achieve this goal. Thank you for your attention.
Merci.
Thank you very much. Now, Public Services International, you have the floor.
This agenda item raises existential questions and reinforces the linkages between emergency preparedness and climate change. It further underscores the dangers of chronic government underfunding and donor dependence. PSI urges member states to support proposals by the regional secretariat, such as robust interoperable One Health data and information systems, and adequate investment in workforce development. We, however, call for caution on partnerships for financing which prioritize the private sector. These don't close financial gaps. They promote the profit motive, undermining a people-centered approach to health security. Member states should rather promote public-public partnerships and close their financing gaps by making corporations pay their fair share of taxes and stop Africa's annual bleeding of $90 billion from illicit financial flows, for example. The need of health security requires that we put the people and profit before profit.
Thank you.
Merci beaucoup. Merci.
Thank you very much. Now, IFMSA, International Federation.
Honorable Chair, esteemed delegates, strengthening Africa's health security is not a choice, but a duty. To every child lost to preventable disease, every under-equipped health worker, and every unheard community in crisis, true resilience is built not only with infrastructure, but with trust, equity, and sustained local capacity. We call for cross-border data sharing and lab networks for rapid outbreak detection, investment in training and retaining community-level health workers, stronger youth and civil society engagement in preparedness, sustainable financing beyond emergency cycles. As IFMSA, we reaffirm our commitment to co-create solutions, raise awareness, and be present, not just in future dreams, but in today's decisions. We urge this committee to see young people not as beneficiaries, but as bold, capable allies in building a healthier, safer, and more just Africa. Thank you.
Merci beaucoup.
Thank you very much. Now, United Nations Foundation.
Thank you, Chair. Honorable Chair, distinguished delegates. An integrated and multi-purpose surveillance system is foundational to sound public health decision-making and is essential to managing health threats before they escalate. The UN Foundation believes that disease surveillance should be treated as a critical component of resilient, self-reliant health systems. As such, we endorse the approaches outlined in the technical paper prepared for this meeting. Recognizing WHO's role in supporting country-led action, we remain committed to working with member states and other partners in the Africa region to make progress on these goals. Looking ahead to the negotiations on the pathogen access and benefit sharing mechanism and the 2026 high-level meeting on pandemics, we urge member states to maintain focus on key enablers of our shared health agenda and maximize opportunities to elevate African leadership on the issue of disease surveillance. Thank you.
Merci beaucoup.
Thank you very much. Now, FAMSA.
Thank you, Madam Chair. Resistance to current medicines for malaria has become an urgent health security threat, especially in Africa. Medicines for Malaria Venture urges member states to devote resources to the creation of national and regional bodies involving public and private sector bodies dedicated to the surveillance and detection of anti-malarial resistance. Medicines for Malaria Venture also calls on member states to adopt WHO's strategy on the use of multiple first-line therapies to reduce the stress and dependence on a single or limited range of medicines for the treatment and prevention of malaria. Finally, we call on member states to lead in the development of human and research capacity for the development of new medicines that can overcome the current anti-malaria resistance threats emerging on the continent. Thank you.
Merci beaucoup.
Thank you very much.
Fédération des associations des étudiants en médecine d'Afrique, FAMSA.
FAMSA.
Madame la Présidente et déléguée distinguée, je prends la parole
Madam Chair, I'm taking the floor today on behalf of FAMSA and all medicine students in Africa. We are called for further commitment towards the youth, especially when it comes to primary health care. The voice that is heard needs to be the most inclusive as possible. We also need to ensure that youth are prepared for future events. Member states, as well as WHO and stakeholders, have made efforts which unfortunately are unequal. And as FAMSA, we are calling for member states, WHO and stakeholders to involve young people more in work done at a regional, national and international level. This must be done in all levels. We can't afford to wait for the next pandemic until we take action. The moment I take action is now. Thank you very much. WHF.
Honorable Chair, distinguished delegates, the World Heart Federation would like to commend WHO for the comprehensive and timely actions proposed in this document. We would like to highlight that people living with chronic non-communicable diseases, particularly cardiovascular disease, face significant challenges in emergency settings due to overburdened health systems and disrupted services. The World Heart Federation urges member states to prioritize the needs of people living with NCDs in health emergencies and elevate NCDs within the regional health security agenda. Integrate essential NCD services into emergency preparedness, response, and recovery plans. Strengthen primary health care and universal health coverage to build resilient systems that ensure continuous and equitable NCD care and improve collection analysis of interoperable data. Thank you.
Merci.
Thank you very much. Does the Secretariat have any comments to make?
Yes, Madam President. I would like to express my sincere appreciation for the active engagement of all countries and feedback on the AFR RC 7513. Your leadership is vital in strengthening health security across the region, both at the national and subnational level. It is noted that all countries are making progress in developing their emergency and health security frameworks, establishing capacity for rapid response, and enhancing coordination mechanism. Strengthening health security requires a collaborative approach with regional coordination playing a pivotal role in ensuring that efforts are unified and effective. WHO remains committed to supporting all countries in this endeavor and facilitating this collaboration with partners. In light of the recent reduction in resource and shift in official development assistance, it is important that we openly discuss the strategic direction WHO Emergency Preparedness and Response Program should go. To this end, I invite you to a site event later today at 6:45 p.m. in the same room where we will serve dinner and engage in a dialogue about how WHO can better support strengthening of country health security. Thank you.
Merci beaucoup.
Thank you very much.
Merci pour votre attention. Le secrétariat a pris note des observations formulées. Le comité régional est-il disposé à prendre note du document et adopter les mesures proposées dans le document AFR RC 7510 intitulé « Renforcer la sécurité sanitaire en Afrique, améliorer la détection des événements, mettre en place des systèmes résilients et favoriser les partenariats stratégiques ». Je ne vois pas d'objection en salle, donc il en est ainsi décidé. On vous demande quelques minutes de patience.
We'd like to request a few minutes of your patience. We'll get back to you right away.
Donc, on attend juste quelques secondes, le temps que mon président s'installe.
I'm just waiting for the next chairperson to arrive and then we'll restart.
Thank you. Thank you. Good afternoon once more. The next item on our program of work today is agenda item 15, draft provisional agenda. Place and dates of the 76th session of the Regional Committee, which is under document AFR stroke RC 75 stroke 1212. Firstly, we will consider the draft provisional agenda of the 76th session of the Regional Committee. If there are any comments from distinguished guests, delegates, we should allow for that. Any comments from the distinguished delegates? Ethiopia.
Thank you, Your Excellency. Ethiopia appreciates and aligns with the agenda. One small agenda item we want to put for the next 76 is in the provisional agenda that we feel that if the committee approves 76 session of Regional Committee of Africa, deliberate on the importance of having a strong, resilient health systems in Africa, and the need to build surge capacities, which I think WHO has, but as South African region, we don't have that strategy. So the WHO Global AMT strategy, which is published in 2023, so it will be imperative that to have regional AMT strategy that we feel that Africa needs in our different arenas, as we learned from the last 3 days of deliberation on our own emergency. So this is a proposal that if the regional committee approves, we want to be this included as an agenda. Thank you.
Another comment? Another comment? I see none. I now go for any comments from distinguished delegates on the dates of the 76th session. The dates of the 76th session. On the dates, any comment? I see none. We shall proceed now to determine the place of the 76th session. Allow me to remind you that the criteria for selections of a member state desirous of hosting a session of the regional committee will apply to determine the place of the 77th session of the Regional Committee during next year's Regional Committee. As indicated in the document, A4 stroke RC 75 stroke 12, the Minister of Health of the Federal Democratic Republic of Ethiopia has submitted a written request to the Regional Director to host the 76th session of the Regional Committee. Are there any comments from the distinguished delegates on this written request by Ethiopia? I see none. Is the Regional Committee ready to approve the draft provisional agreement agenda of the 76th session of the Regional Committee as proposed in the document AFR/RC 75/12 of the 76th session of the Republic of the Regional Committee from just putting a date, don't worry. From 24th to 28th of August 2025, 24th to 28th August 2025. 26, I'm sorry. 26. I see no objection. It is decided. Distinguished delegates and guests, we have now come to the section on information documents under agenda item 16. Given that there are 17 information documents to be considered under 4 different pillars, I would like to propose that we take these documents in 4 batches accordingly to their pillars. Kindly indicate clearly which documents you are commenting on. May I remind you to please be brief with your comments. You are now invited to present your comments on the following under Pillar 1. 1 billion more people benefiting from universal health coverage. Agenda item 16.1 to 16.9. Comments? I wish to invite member. Yes. I now invite member states wishing to provide comments to do so by raising their nameplates. The floor is now open. Cote d'Ivoire, followed by Seychelles. Cote d'Ivoire, you have got the floor. The rest you can put just name tags, then we can record them here.
Monsieur le Président,
Mr. Chair, Côte d'Ivoire welcomes the adding of these points to the agenda of the 76th session. Various topics here which are very important with 2030 in mind. We further welcome and congratulate rather the work done by the Secretariat on this topic. We need a national system for coverage. And in our country, we have adopted this in 2014. And it's thanks to our president's commitment. When it comes to increasing the supply of healthcare services, we think that we need to improve the quality of healthcare as well when it comes to prevention as well as treatment across the scale of the healthcare system throughout the country. We need to ensure that the approach is holistic, that we take into account the needs of the population. We also need to reduce the numbers of lacks and shortages. We also therefore need to improve human resources. We need to ensure that blood products are in supply and in sufficient supply. In 2024, more than 7,000 healthcare workers were recruited. The average was around 3,500 per year previously. We've also invested in surgical teams. So we're continuing to pursue our strategies when it comes to supporting pregnant women especially, and children. We've also been focusing on the health of women, children, and adolescents. Similar to this, what else has been important is mental health. This has been a priority for our country too. Mr. Chair, Côte d'Ivoire would like to reaffirm its commitment to UHC.
Avec un renforcement des ressources humaines endogènes,
and when it comes to the strengthening of healthcare,
la disponibilité. Merci.
Thank you, Chair. I'll be talking about document 16.1. Mr. Chairman, AMI is a silent but deadly pandemic, and Seychelles has not been spared. Our laboratory surveillance is collecting AMI data already, and Seychelles continues to report to GLAS, whilst also participating in the track survey. An MOU was signed between the different ministries, Ministry of Health and Agriculture, to strengthen the One Health approach to address health risk at human, animal, and environmental interface. We also have established functional AMR governance mechanism and conduct yearly awareness campaigns integrating AMR within the IPC training packages. However, we call for greater emphasis on public education, stricter regulation of private pharmacies to prevent inappropriate over-the-counter antimicrobial sales, and inclusivity of private health providers in national AMR action plans. Technical reinforcements are also needed to operationalize antimicrobial stewardship and embed AMR as an official program within the healthcare services for enhanced monitoring. It is imperative that we enhance our focus also on IPC, as it is the cornerstone of reducing infections, limiting antimicrobial use, and crucially promoting patient safety and quality of care. By prioritizing IPC, we strengthen our ability to protect communities and ensure more resilient health systems for the future. Seychelles remains dedicated to advancing this strategy of implementation, regulation, and stewardship. I thank you, Mr. Chair.
Thank you. Burkina Faso, followed by Angola.
Merci, Monsieur le Président.
Thank you, Chairperson. I'd like to talk about 1613. The government of Burkina Faso thanks the Secretariat for the relevance of the report that talks about empowerment of communities for PHC, UHC, SDGs, and health security. As we implement the regional strategy for community engagement 2023-2030 for the WHO African region, Burkina Faso has adopted a strategy 2024 to 2028 to strengthen governance, professionalize community care, scale up digitalization, improve M&E, and resource mobilization. In this regard, several strides have been made. We have recruited 32,000 health workers, including in peri-urban areas, as well as insecure areas. We have the e-health platform and the integration of community data in the health information systems. We have regular performance reviews, as well as the adoption of a national resource mobilization strategy for a budget of billions of CFA francs over 3 years. We want to have secure and sustainable funding through transparency and support from partners. To conclude, we take note of this report and reiterate Burkina Faso's commitment to implement the strategy effectively. Thank you.
Angola, followed by Central African Republic.
Thank you very much, Mr. Chair. 16.7. Let me start by saying that Angola's healthcare system is universal. It aims to respond to the needs of the population. It aims to put people at the heart of our actions. And we have expanded infrastructure for healthcare, and it's modern now. We've done so at various different levels. We've gone from 2,000 units to 13,000 units. That is data which is relevant to this year. We've also focused on a One Health approach, and we have increased our workforce as well, if you compare it to previous years. We have also implemented programs to train tens of thousands of health workers, and not just clinical workers, but persons involved in various structures of the healthcare system. This is part of achieving UHC. We are attempting to continue digitalizing our services. When it comes to finances and policy, we've also made important progress when it comes to reducing MMR, especially for children under the age of 5. Our efforts will lead to the reduction in newborn mortality by around 24 per 1,000 live births, to a number which is quite inferior to that. And we expect that we will achieve this. We remain committed to UHC. We want to ensure that everyone is protected and no one is left behind. Thank you.
Followed by Senegal.
Monsieur le Président, notre intervention.
Chairperson, our intervention is on agenda item 16.1. Chairperson, the Central African Republic congratulates the Secretariat of the WHO Regional Committee on the quality of the report presented and commends the progress made in implementing national action plans to combat antimicrobial resistance in the African region. At the national level, the CAR has made progress, particularly by developing a budgeted national action plan to combat antimicrobial resistance, integrating the country into the global antimicrobial resistance surveillance system, and organizing a national consensus workshop on the governance of antimicrobial resistance. The WHO is requested to strengthen its technical support with a view to accelerating the effective implementation of its action plan. The Central African Republic reaffirms its support for the proposed measures and encourages all member states to adopt them so that together we can work towards a future where antimicrobials continue to save lives. Thank you.
Senegal, followed by Kenya.
Thank you, Chairperson. Senegal would like to make a comments on item 16.7. Senegal congratulates the Secretariat for presenting the progress report on the framework for health systems development towards universal health coverage. Senegal wishes to reach UHC, like is the case with other countries. We developed a national health financing plan to cover UHC, to cover the period 2017 to 2022. We were able to increase financing from 19% to 2017 to a higher percentage in 2021. We have essential services that increased to 49% in 2019. In line with the vision of the head of state for resilient Senegal, we have a new development strategy that was developed, and it has the following guidelines: ensuring integrated quality services that are equitable, promotion of an inclusive system to protect the population against financial risks linked to diseases, and then sector interventions to manage health, and then strengthening of governance. Senegal invites the regional committee to take note of the report and encourages the WHO to support countries to effectively implement their interventions identified therein. Thank you so much for your attention.
Yeah, followed by Togo.
Thank you very much, Chair. Kenya is going to be presenting on this agenda item of 16.7 on universal health coverage progress. Kenya is honored to present its UHC progress aligned with the WHO's vision of equitable health care access. As a core pillar in the government's bottom-up economic transformative agenda 2022-27, alongside agriculture, MSC, housing and transformation, and digital economy, UHC drives Kenya's health reforms. In 2023, Kenya was able to establish 4 new laws which established our social health authority. Fully operationalized by last year, November, our health authority now has enrolled over 23.9 million members with 7.8 million dependents, and 5.4 million households are fully paid. In June 2025, we also established what is called Lipa Pole Pole. That means pay slowly, an initiative that we launched offering interest-free funds for informal sector households to pay for their annual social health insurance premiums upfront with flexible repayment periods. Kenya takes pride in the social health authority funds and ensures that comprehensive care supported by digital innovations like electronic health records and biometric enrollment is established. Kenya is strengthening domestic financing to navigate donor transition, exemplified by the USAID withdrawal, which with reforms which will be driven by reducing out-of-pocket expenditure and notable gains in maternal and child health outcomes, bringing Kenya closer to accessing sustainable healthcare. Kenya commits to achieving full social health insurance coverage by 2023 and fostering resilient health systems. Thank you, Chair.
Togo, by Nigeria.
We would like to make a comment on item 16.5. Thank you, Chairperson. Togo congratulates the Secretariat, Secretariat for this progress report. The health information system on mental health and the use of psychoactive substances is commendable. It is a concerning phenomenon, and we've noted that we have a high prevalence of people consuming these substances. And the prevalence of mental health within the population has shown that you have many people using psychoactive substance, says, and those who are also facing mood changes. Togo would like to subscribe to the vision of the WHO, and we have been screening people and ensuring that they have access to quality and affordable care. We take note of the report, and thank you, Chairperson.
Thank you. This of Nigeria, and followed by Ghana.
Thank you, Chairman. The Chairperson. Nigeria is delivering statement on Agenda 16.2. Nigeria commends the Regional Office for Africa for its continued leadership in advancing the regional strategic on innovation and medical products regulation. The report from the last meeting outlines ambitious targets for 2025, including the establishment of national patent system that fully utilize TRIPS flexibility, the strengthening of regulatory mechanism to accelerate the maturity of innovations and sustainable pathway for scaling up health innovations. In this regard, Nigeria has taken deliberate steps to align with these regional priorities. First, as part of our commitment to a coordinated government-led innovative drive, the federal government inaugurated the Interministerial Committee on Research and Innovation on 17th April 2025, chaired by the Vice President of the Federal Republic of Nigeria, with representation from over 12 ministries and key sectors. Second, to sustain health tech innovation amidst global shifts, Nigeria is implementing a national health tech roadmap aligned with emerging global and regional priorities. Thirdly, Nigeria has prioritized the healthcare value chain through the establishment of the Presidential Initiative on the Health Value Chain, PVAC. Fourthly, Nigeria recognizes the critical role of the TRIPS agreement and shaping innovative and access to health technology. Nigeria remains committed to the regional vision of achieving WHO Maturity Level 3 regulatory system. We call on WHO Afro partners and member states to continue supporting African countries by accelerating alignment of national laws and treaties with TRIPS flexibility, strengthening regulatory system to fast-track innovations. Innovations and regulations are powerful level for African health security and development. Nigeria stands ready to work with regional partners to ensure that by 2030, Africa is not only a consumer, but also a global producer of health innovations. Thank you.
Ghana, followed by the DRC.
Thank you, Mr. Chair. Ghana, thank you for the opportunity to contribute to discussion on Agenda 16.1. We add our voice to commend the Secretariat for the technical report and note with appreciation the progress made in the region. Mr. Chair, Ghana has made progress in implementing interventions. We are implementing a formally endorsed, fully costed national action plan aligned to the Global Action Plan on Antimicrobial Resistance. 17 sentinel sites with 3 reference laboratories with capacities to perform susceptibility testing on critically important bacteria have been established. We actively participate in the annual Tracking AMR Country Self-Assessment Survey, demonstrating a commitment to systemic monitoring of AMI implementation progress. To strengthen governance and leadership on AMR activities, a functional One Health AMR governance structure with defined roles and responsibilities across human health, animal health, food, environment, and related sectors that enable effective cross-sectorial collaboration and accountability has been established. To maintain and strengthen the momentum on tracking AMR, Ghana proposes the following. 1, improving laboratory infrastructure, diagnostic resources, and human resource capacity. 2, promoting and institutionalizing antimicrobial stewardship programs into the primary healthcare systems. 3, leveraging on and integrating One Health digital technologies with existing integrated disease surveillance and response framework to enhance efficiency and sustainability. 4, mobilize resources and mainstream and prioritize AMR interventions into national budgets for sustained action on AMR. We note the proposed actions and the recommendations therein. Thank you.
DRC, followed by Gambia.
Merci, Monsieur le Président.
Thank you, Chairperson. DRC thanks the Secretariat for the quality of the reports on the situation of to reduce in Africa 2019-2025. Malnutrition is a major concern in DRC. Despite the efforts made by the government, our demographic and health survey shows that children under 5 are faced with stunting and low weight. So DRC is keen on ensuring that everyone has good nutrition and ensure that they will contribute to the human capital and the economic development by 2030. Since 2023, the DRC has been involved in innovation to support the plan, domestic resource mobilization to cover nutritional cases, as we are now adding nutrition to SIAs, and we also have a law on health security, as well as the opening of school canteens. In the margins of the UN Assembly in 2022, President Felix Tshisekedi talked about the impact of malnutrition, and he has been leading a dialogue on malnutrition in collaboration with 6 other heads of state in Africa and the AFDB. The head of state said that he would reduce chronic malnutrition by 2030 using a tailored multi-sectoral approach. Thanks to the DRC would like to come to an end of the double burden of malnutrition. Thank you. We thank the Secretariat for its report.
We want to comment on agenda number 16.3. The Gambia delegation wishes to thank the WHO Secretariat for preparing this report on the midterm review of the WHO PEN Plus in the Africa region. As highlighted in this report, we have also noted with concern the increasing burden of and the inadequate capacity in our countries to effectively manage severe NCDs at referral level of care. This said, we have also noted the progress made in the region regarding the adaptation and use of standardized protocol-based management approaches for severe NCDs and training of mid-level healthcare workers on the management of chronic and severe NCDs. We also concur with the challenges in this report hindering the implementation of the PEN Plus, notably the insufficient human and financial resources, as well as the weak and overstretched health system in our countries. Notwithstanding, the Gambia has instituted measures to strengthen capacity for the management of severe NCDs at the referral centers, hospitals by developing and implementing standard treatment protocols. Meanwhile, the Ministry of Health is also working closely with the Gambia Sickle Cell Association to increase public awareness in sickle cell diseases across the country. With the support from Defeat NCD Partnership, we have also developed a costed NCD action plan. However, in view of our varying challenges and context, we would urge the WHO to continue supporting member states in strengthening our health system to better manage severe NCDs. With focus to be given on 3 areas: integrated service for PEN Plus conditions at all levels of healthcare, community empowerment, and primary healthcare revitalization, improve access to essential medicines and diagnosis for these conditions. In conclusion, the Gambia has noted this report and we support its adoption. Thank you.
Mozambique.
Thank you very much for giving me the floor. We would like to start on 16.8. On 16.8, Mozambique has its own regional strategy. 2005, and Mozambique has enacted a specific law on this aspect, and we are busy revising various options, such as creating an entity to take a closer look into healthcare products and medicines for human use in Mozambique. We have been doing this because it feeds into our efforts to regulate the medicine market and the market for healthcare products. This also goes for clinical trials. Via its regulatory authority, Mozambique has been regularly examining where there may be loopholes in our national regulation system. Mozambique takes part in the collaborative process, CRP, with the WHO, the goal being to strengthen harmonization and regulatory convergence. We also are part of a SADC-level harmonization effort. All of this aims to ensure that our healthcare system is strengthened when it comes to the regulation of medication. This is why we support this report, and we thank the Secretariat for their work on it. Thank you.
Liberia, followed by Madagascar.
Thank you, Honorable Chair. Liberia would like to speak on Agenda 16.1. Honorable Chairperson, Liberia aligns with this strategy and its effort to make notable strides in implementing the Global Action Plan on antimicrobial resistance. Liberia developed its National Action Plan on AMR 2018-2022 and established a One Health AMR Technical Working Group with clear terms of reference and focal points to coordinate and monitor implementation. 6 centennial surveillance sites were set up, including a National Reference Laboratory and a Veteran Laboratory. Liberia enrolled in a global antimicrobial resistant and new surveillance system in 2021 and has since been submitting AMR data annually. An antimicrobial stewardship program was launched with regular ward rounds in selected facilities to monitor microbial use. Since 2021, Liberia has participated in tracking AMR, country self-assessment survey, using it to identify sectorial gaps. Despite these progresses recorded, there are still needs to increase AMR awareness through the nationwide quarterly campaigns, expand the centennial surveillance by strengthening laboratory capacity across One Health sector, enhance AMR practices by developing an AMR curriculum for training and professional institutions. Liberia is well on track and achieving this goal, and we look forward to reaching this goal. Thank you, Honorable Chairperson.
Madagascar, followed by Burundi.
Thank you, Chairperson. We'd like to make comments on agenda item 16.1. We approve the report developed by the Secretariat. Antimicrobial resistance has not spared Madagascar. We have a national plan that is aligned with the WHO plan. We use the One Health platform that constitutes a formal framework for coordination between the human health, environmental health, and environment interfaces. We have been standardizing our techniques and ensuring that regular data is uploaded on the GLASS platform, as well as controlling infections. And The One Health platform has also been used as an experience sharing platform. However, the challenges are huge. We do not have technical and maintenance support. We do not have adequate data collection systems, and AMR data is incomplete. We want to strengthen the capacities of our laboratories so that they have modern techniques, including sequencing, PCR, and bioinformatics. Madagascar fully commits itself to fighting antimicrobial resistance, and a multi-sectoral approach would be the best to contain this threat and ensure the health of our populations. Thank you.
Burundi, followed by Eswatini.
Merci, Monsieur le Président. Thank you, Mr. Chair.
Monsieur le Président, le Burundi salue.
Mr. Chair, Burundi. Apologies, I'm focusing on 16.3 on the regional strategy to address severe non-communicable diseases. Burundi welcomes the agenda, thanking the Secretariat for the quality of the reports presented. Clearly, we are facing severe challenges when it comes to severe NCDs, which are the #1 cause of morbidity in our country. In other countries, it is also the same, that NCDs are not receiving enough attention. We have seen in our country a worrying increase in the incidence of NCDs, and they hinder us from achieving our 2040 emerging Burundi agenda. So Burundi reaffirms its commitment to achieving the PEN targets. We also intend to continue focusing on the priority actions when it comes to serology, as well as in addition to the production of vaccines and building capacity of healthcare workers. We continue to do so via the provision of online training, as well as the mobilization of financial resources. Mr. Chair, Burundi reiterates its firm intention to work with partner countries in the region and the WHO in order to build a more resilient healthcare system, which is capable of providing for our people integrated services of high quality when it comes to treatment of NCDs. Thank you.
Eswatini, followed by Ethiopia, and Ethiopia should be the last now.
Agenda item 16.1 AMR. Eswatini is one of the countries that have strengthened the prevention of AMR through a One Health approach and working in collaboration with the Ministry of Agriculture, Natural Resources and Energy, and Tourism and Environmental Affairs. A national antimicrobial resistance containment strategic plan was developed in 2017, and AMR stewardship committees are in place to monitor the implementation of the strategy. In addition, the country has continued to report consistently to the GLASS mechanism and is implementing AMR antibiograms in sentinel sites to monitor antimicrobial use and prevent AMR. Eswatini is in a position to become a regional leader in cross-sector AMR coordination and surveillance. However, more effort needs to be put into strengthening nationwide awareness campaigns, expand stewardship coverage, and enhance data use for policy. We appreciate the report and would like to further recommend scaling up of public awareness and education programs on AMR, strengthening of laboratory and surveillance capacity for priority pathogens, and integration of AMR stewardship training into health and veterinary pre-service curricula. I thank you.
Thank you. Ethiopia.
Thank you. Thank you, Chair. We wish to take the floor on agenda item 61.12. Ethiopia welcomes the progress report on the regional multi-sectoral strategy to promote health and well-being. We commend the Secretariat for highlighting both achievements, gaps, and addressing the determinants of health. Ethiopia has established national coordination platforms and adopted One Health approach and developed One Health strategy plan that reinforces preparedness against zoonotic disease, climate-related health risks, and antimicrobial resistance as one of a flagship program as we participate in the global network of ministers as a champion country in antimicrobial resistance. Through the National Food and Nutrition Strategy and the WASH intervention, we also making promising progress in improving child health and malnutrition. Ethiopia also implements major initiatives led by His Excellency, the Prime Minister, Dr. Abiy Ahmed, the Great Legacy campaign, that which you heard. Ethiopia planted 14 billion trees in the last 5 years only. SADU, or Clean Ethiopia initiative, is also a big campaign for safe, healthy environment and the sanitation. And also we introduced car-free days for human movements. Urban corridors development includes the bike lines, walking lines, and we do every month a campaign for NCD preventions. Ethiopia continues to face challenges, including limited financing, weak multi-sectoral coordination, and particularly at subnational levels. So to accelerate that, we need a progress and a partner to the WHO and other partners as we go. One last word before I close, Your Excellency, if you allow me, I want to thank the regional committee and the U chair, the whole podium for selecting Ethiopia for next RC meeting, and we welcome you in Ethiopia and motherlands of all humankind and your home of Africa. Thank you so much.
Ethiopia, congratulations. Congratulations, Ethiopia. Thank you. I will now pass the floor to the observers, starting with the member states from the region, then the UN and other IGOs to make their comments or statements on these 5 progress reports. Kindly indicate which agenda item you are referring to. The floor is yours.
Thank you, Mr. Chair. Under the auspices of WHO IAA Joint Program in Cancer Control, the IAA supports national efforts to integrate these services into evidence-based cancer control planning. In 2020-2024-2025, the IAA, working together with WHO and IAR, provided advisory support to Eswatini, the Gambia, Madagascar, Mozambique, Nigeria, Rwanda, and the United Republic of Tanzania to comprehensively assess cancer control capacities and needs. The IAA further supports the African cancer community by sponsoring a cancer control professional to attend the global fora and share the good practices. In addition, that IAA helps to build capacities of member states in Africa to use stable and stop techniques to improve micronutrition status among children and develop 2-year regionally harmonized master's degree program in human nutrition and nuclear technique.
Thank you. Thank you. Yes. I understand that several non-state actors have requested to deliver statements on this agenda item, and they are now invited to do so. I have Federation International, IFMSA,
Honorable Chair and distinguished delegates, health innovation is not only a driver of health equity, it's a cornerstone of economic growth and societal resilience. We're proud to partner with institutions like the H3D Foundation, which is building world-class drug discovery capacity on the continent. Enabling this innovation requires talent development, stable markets, and a robust and predictable policy environment that incentivizes R&D, including strong IP frameworks. Crucial to delivering this is the TRIPS agreement, which we encourage countries to fully implement. A strong regulatory ecosystem is equally essential. We support the operationalization of the AMA and the broader regulatory harmonization agenda. As the burden of NCDs rises, innovation must be at the heart of the response. Addressing NCDs is a litmus test for how effectively we can integrate innovation into health systems to deliver on UHC. We stand ready to work with WHO Afro, member states, and all partners. Thank you.
Uniting to combat NTDs. You have the floor.
Uniting welcomes the framework and the progress report and commend the efforts of member states and WHO to strengthen health financing and service delivery. However, the persistent gaps in reaching the underdeserved populations and the rise of out-of-pocket expenditures threaten to reverse gains made in NTD control and elimination. We urge member states to increase their UHC service coverage index, particularly for NTDs, for improved population coverage and equitable access to care, thus leaving no one behind. Integrating NTDs as part of the essential service package is critical to achieving UHC and primary and health equity in the African region. Addressing and investing in NTDs is a moral and economic imperative, one that aligns directly with the UHC and SDGs. Thank you.
International Society of Physical and Rehabilitation Medicines, ISPRI.
Thank you, Chairperson. Distinguished delegate, the International Society of Physical and Rehabilitation Medicine, member of the World Rehabilitation Alliance, the WHO network, hosted network, commends the review of PEN Plus strategy implementation in African region. We urge the integration of rehabilitation into PEN Plus service packages delivered in dedicated clinics. The basic package of intervention for rehabilitation is a key resource to provide appropriate early rehabilitation services to patients in order to improve their quality of life, prevent complication, support the ability to work, and participate in community life to their full potential. Thank you.
Drugs for Neglected Diseases Initiative, the NDI.
Thank you, Chairperson. On agenda item 16.1, Drugs for Neglected Disease Initiative welcomes member states' continued commitment to addressing the growing threat of antimicrobial resistance. We commend the adoption of the regional strategy and progress on implementing national action plans to combat antimicrobial resistance. AMR remains a critical challenge, with sub-Saharan Africa bearing the highest burden on global mortality. We call for increased investment in research and development, targeting drug-resistant infections, particularly in those affecting vulnerable populations, including children and people living or affected by neglected tropical diseases. Thank you, Chairman.
NCD Alliance.
On agenda 16.9, NCDs pose a considerable challenge to the African region. The age-standardized NCD mortality rate remains consistently higher than the global average, and the proportion of premature deaths from NCDs is highest in Africa when compared to all other WHO regions. Out-of-pocket spending for NCDs threatens households, economies, and development gains. 2025 is a pivotal year for NCDs, and would like to draw your attention to the UN high-level meeting on NCDs in September. We regret that the political declaration that has been weakened, largely failing to deliver a concise, action-oriented declaration that builds on previous commitments. We therefore call on member states to mobilize high-level political leadership to increase allocations on national budgets, to operationalize multi-sectoral responses, strengthen NCD services at primary healthcare, mobilize sustainable financing, prioritize additional cost-effective NCD prevention policies, and operationalize meaningful participation.
International Federation of Medicine Students Association.
This is a statement on agenda 16.5. Honorable Chair, distinguished delegates, the IFMSA emphasizes the urgent need to strengthen the comprehensive Mental Health Action Plan 2013 to 2030. Mental health is a critical issue in Africa, where stigma and underinvestment hinder well-being.
We assert that universal health coverage must include mental health for true progress, and we urge member states and WHO to scale up investments in community-based mental health services that are culturally grounded, accessible, and integrated into primary healthcare, equip health workers, including medical students, with the skills and empathy to break cycles of stigma and silence, prioritize school-based and youth-centered programs that safeguard the mental health well-being of our future generations, and establish cross-sectional collaborations that address the social determinants of mental health, poverty, displacement, violence, and inequality. Africa's resilience should lead to responsive systems that transform pain into policy, making mental health a cornerstone of universal health coverage. Thank you.
African Tobacco Control Alliance.
Thank you, Chair. The African Tobacco Control Alliance views with concerns a lack of resources for the health sector in Africa. And yet, we have repeatedly heard during this meeting about the domestic resource mobilization. We therefore call upon member states to impose higher taxes on harmful products like tobacco, alcohol, and sugary beverages to generate more revenue, but also earmark part of the tax revenue for the health sector. This strategy is lacking in Africa, Mr. Chair. Taxes on harmful products are very often not adequate, and earmarking tax revenue for health is almost inexistent. The Philippines is a perfect example of how the health sector can undergo a profound transformation through proper taxation and earmarking. Africa can do the same for the benefit of its population. Thank you, Chair.
Thank you, Chair. We welcome the progress in advancing mental health in the region. However, we are concerned that the alcohol, mental health, and NCD burden remains unaddressed in this report. The African region has the second highest rate of alcohol attributable deaths globally, 52.2 per 100,000 people, despite low average consumption. Alarmingly, from 2010 to 2019, alcohol use disorders increased by 8.8% in our region. Alcohol fuels a mental health crisis in Africa. The burden falls heavily on our youth, undermining human capital, mental well-being, and developmental potential. This crisis requires urgent investment in alcohol policy solutions. Rising alcohol taxation, banning alcohol advertising, and limiting alcohol availability, while expanding access to treatment services, while expanding access to
Obesity Federation.
Health system strengthening and youth protection. Thank you.
On Agenda 16.9, the World Obesity Federation welcomes this report and urges member states to integrate obesity prevention and management into primary healthcare as recommended by WHO. Obesity is rising rapidly across Africa, with adult rates exceeding 30% in several countries. It is a disease that requires multi-sectoral response. Prevention policies alone will not be enough. Because obesity drives other major NCDs such as diabetes, heart diseases, cancer, addressing it in primary healthcare offers the double dividend, improving health outcomes while reducing long-term economic costs. Encouragingly, some countries in the region are beginning to integrate obesity into primary healthcare. For these efforts to succeed, it is vital to involve people with lived experience of obesity, ensuring services are patient-centered and non-stigmatizing and trusted. We call on all member states to recognize obesity services as essential and to embed them in primary healthcare now before the epidemic overwhelms Africa's health system.
World Health Federation.
Honorable Chair, distinguished delegates, on agenda item 16.9, the World Heart Federation applauds member states for the strides made in the implementation of the regional framework for integrating essential NCD services in primary healthcare. However, we note with concern that none of the 2025 milestones have been achieved. Cardiovascular disease remains the leading cause of NCD-related morbidity and mortality in Africa, with hypertension being the most important risk factor. The World Heart Federation calls on member states to support the expansion of hypertension treatment to 500 more million people globally by 2030, aiming for 50% hypertension control through strengthened primary healthcare, and to establish sustainable financing for NCDs through mobilization of domestic resources to strengthen primary healthcare level. Thank you.
Thank you. Help International. Help.
Thank you, Chair. Distinguished delegates, on behalf of the HelpAge International Global Network, we welcome PEN+ Progress, decentralized, nurse-led, district-level service saves lives. Yet, the midterm review is clear. Without urgent investment, millions, especially older people, will be left behind. NCD already caused 37% of death in Africa and will surpass infectious diseases by 2030. Older people bear the greatest burden, yet remain invisible in policies, financing, and data systems, with premature mortality excluding those over 70. We urge member states to embed age-inclusive NCD care into UHC, expand resilient community models, strengthen the workforce, and remove age caps in data. Thank you.
Thank you. I see no more requests from the floor. We will now continue with agenda item 16 on information documents. Kindly indicate clearly which documents you are commenting on. May I remind you to please be brief with your comments. You are invited to present your comments on the following under Pillar 2, 1 billion more people better protected from health emergencies. Agenda item 1116.10 to 16.11. It's 11. It's 13. I now invite member states wishing to provide comments to do so by raising their nameplates. The floor is now open. Nigeria, followed by Central African Republic.
Thank you, Chairman. Agenda item 16.10, progress report on the framework document for the African Public Health Emergency Fund. Nigeria welcomes the opportunity to provide its national perspective on the implementation of the African Public Health Emergency Fund. In an increasingly interconnected world, the frequency and complexity of public health emergencies are growing. For Nigeria, recurrent outbreaks and simultaneous threats highlight the urgency of resilient preparedness and response systems. The government has adopted a coordinated, multi-sectoral, and evidence-based approach using tools such as the multi-hazard risk assessment, the WHO STAR tool, and the readiness intelligence tool to strengthen risk profiling and planning. Key progress includes adoption of the second national multi-hazard preparedness and response plan, establishment of emergency preparedness and response committees, deployment of enhanced situational awareness, and the Nigerian preparedness response and alert system, development of a medical countermeasure logistic plan, strengthening of the public health emergency operations centers, and integration of the African Public Health Emergency Fund utilization tracking for accountability. Nigeria call to action. Nigeria calls for stronger domestic investment in preparedness systems, system expansion, and institutionalization of monitoring tools as stated, and strengthen multi-sectoral collaboration. We also urge WHO to sustain technical and financial support to member states. Thank you.
Merci, Monsieur le Président.
Thank you, Mr. Chair. Excellencies, ladies and gentlemen, dear delegates, the CAR would like to thank the DG, rather the RD, for having included this question on the agenda. I'm focusing on 1611. We welcome this item on the agenda. It shows that the continental efforts are underway in line with the global strategy for cholera prevention and control. Our country is facing a cholera epidemic. The current status is characterized by our neighboring countries' situations, which find themselves in active epidemics. We experience high migration flows and trade across borders. In our country, the last epidemic took place in 2016. At that time, we saw a high level of mortality, higher than 7%. This means, what I can say is that the situation is still bad. We are basing ourselves on a multi-sectoral approach, and this involves WASH and local communities and actors' engagement. Several actions have been put in place, such as laboratories and cholera response plans based on our experience from the past. Use of communication tools, training of healthcare workers when it comes to surveillance, risk analysis, treatment, and control. The provision of PCR tests in healthcare units, simulation exercises. We depend on our partners. Thank you.
Muito obrigada,
Thank you very much, Mr. Chair. The African Fund, the African Public Health Emergency Fund, is in 1610. It has been an indispensable instrument to help us coordinate our immediate emergency approaches to health events in our region, given that they are taking place at an alarming rate. We welcome this encouraging document. We think it is significant. It is a mechanism for us to increase technical capacity and increase the amount of financial resources available. Allow me to highlight the fact that Angola has been a direct beneficiary of this collective effort. It was rapidly mobilized in response to the cholera epidemic, which has been affecting us since January this year. This support has allowed us to increase epidemiological surveillance efforts. It's helped us to intensify community engagement mechanisms. This includes identifying outbreaks and protecting the most vulnerable populations. It shows how important it is to have a fully functional fund, which is sufficiently funded and flexible. Our experience shows that African solidarity and cooperation on a technical level can save lives and strengthen resilience of individual countries' healthcare systems. In this context, I'd like to recommit Angola to the guiding principles of the fund, including its sustainability on the long term. We encourage all member states here to strengthen their commitment to this essential mechanism. I'd like to thank the WHO, AFRO, for their support and their team for their dedication and professionalism. I'd also like to thank multilateral institutions for their commitment to public health in Africa. Thank you.
Togo, followed by Malawi.
Merci, Monsieur le Président.
Thank you, Mr. Chair. Togo will refer to 1610, Progress Report on the Framework Document for the African Public Health Emergency Fund. Togo would like to congratulate the Secretariat for this report. It is a progress report, and it looks into the measures which have been taken so far and looks at the future actions to be taken. Member States' contributions have helped us in our own situation. And when it comes to the wider situation, we see that the fund has been receiving financial resources. In our country, we are facing cholera, Ebola, and malaria, as well as climate-related events. This is why we need persistent funding. This is why we think that the fund will be incredibly helpful in order to respond to emergency situations. If there is a lack of monitoring, however, the fund will not be able to respond to fulfill the requirements. We welcome the establishment of this fund, and we await further steps to strengthen it. Togo takes note of the report. Thank you, Mr. Chair.
Malawi, DRC.
Thank you, Chairperson. Sub-item of interest for Malawi 16.10, Public Health Emergency Fund. Malawi reaffirms its strong support for the fund as it serves as a vital regional financing mechanism for timely and coordinated public health emergencies response in Africa. Malawi so far has received about $1.6 million from the fund, and this has enabled us to respond to the emergencies that we've experienced as a country. We also commend the Technical Review Group for achieving timely review of funding requests, ensuring that we have rapid disbursement of funds when needed most. Chairperson, persistent funding shortfalls continue to undermine the fund, and we've noted that Malawi has a cumulative arrears of approximately 103 million, but so far we have contributed roughly $138 million. In conclusion, therefore, Chair, Malawi remains fully committed to settling its arrears, recognizing the critical role that the fund has in safeguarding national and regional health security. Thank you.
Merci, Monsieur le Président.
Thank you, Chairperson. The Democratic Republic of Congo approved the regional framework for the implementation of the global strategy for cholera control in the WHO African region. And thanks the Secretariat for this. Cholera is a major public health challenge in the DRC and is manifesting in several epidemics. We had over 48,000 cases reported this year, with 1,400 representing a CFR of 3%, which is above the OMS threshold of less than 1%. The authorities of my country are concerned by this outbreak. An effective cholera intervention requires a multi-sectoral approach, and therefore we have developed a multi-sectoral plan for the elimination of cholera from 2023 to 2027. To deal with this public health challenge, we have put in place a strategy for cholera and diarrheal diseases that takes into account curative measures and the improvement of access to water, sanitation, awareness raising, risk communication, and vaccination. For the current outbreak in the DRC, we have a preparedness and response plan that is being implemented. It was developed under the PHEOC with a focus on rivers without cholera. It involves a commitment from the government and partners using a multi-sectoral approach. The DRC would like to sincerely thank various partners, including the WHO, for the technical and financial support in cholera control. Thank you.
Ghana, followed by Gambia.
Yeah, Mr. Chair, the Gambia wants to comment on the agenda 16.11. We sincerely thank the regional director for the comprehensive report on the implementation of the framework of the implementation of the global strategy for cholera prevention and control 2018-2030. We acknowledge and commend the significant progress achieved thus far, which reflect our collective commitment to advancing this important agenda. At the same time, we acknowledge the challenges outlined in the report and support the proposed action to accelerate implementation of the framework. While this progress is very positive, it is important to highlight that Target 3 under this report, which aims to ensure regular monitoring, evaluation, and adaptation of the regional framework, has only 39% of the milestone achieved. This challenge reiterates the urgency of implementing the proposed actions in the report. In the Gambia, we have initiated steps aligned with this recommendation already. For example, we have constructed 329 climate resilient latrines and 1,601 ventilated improved fit latrine in household previously practicing open defecations in both riverine and non-riverine communities. This is aimed at reducing open defecation from 1% to 0%. In May this year, we have conducted a waste bottleneck analysis as part of our preparation for a joint waste sector review scheduled for later this year. This review will culminate in a presidential compact which will serve as a high-level commitment to improving waste as an advocacy to mobilize support. Recognizing the increased risk of outbreak during this rainy season. Thank you.
Thank you very much, Mr. Chair. We are going to be talking about 1610, the African Public Health Emergency Fund. Mozambique has received around $15 million, and this has contributed significantly to us strengthening our capacity to respond to public health emergencies. This fund has helped us to contract and rather hire professionals such as epidemiologists, laboratory officials, and this has helped us to strengthen our technical response capacity. This funding has been fundamental when it comes to procurement of medication, PCR, and personal protection equipment, PPE. It means that hospitals are better able to respond to outbreaks. We have saved many lives as a result. This is why the African Public Health Emergency Fund is a stimulus for ongoing improvements in individual countries' healthcare structures. So we note the report and we look forward to future steps to be taken. We are grateful for the continuous support of the WHO in Mozambique, and so we warmly support the adoption of it. Thank you.
We see no further number. Yeah, one. Sure that. We didn't do. Huh? I see no card. There is there. Kenya, you have the floor.
Thank you, Chair. I would like to make a statement on agenda item 16.11. Kenya continues to align herself with the aspirations of both the Global Strategy for Cholera 2018-2030 and the Africa Regional Framework for the implementation of the strategy. Kenya has a designated national cholera focal point and the National Cholera Elimination Plan in line with the Global Task Force for Cholera Control Guidelines. The country has enhanced its outbreak detection, preparedness, response, and recovery capacities by investing in emergency operation centers and in emergency operation centers and incident management teams that are well trained, implementation of the integrated disease surveillance and response guidelines, training of frontline health workers and rapid response teams, and strengthening our emergency supply chain capacities. And we are also empowering our communities to participate in cholera prevention and control. While significant progress has been made, we need to note that we receive events on our continent, including insecurity and extreme weather events leading to large outbreaks in many member states, threatening to reverse all these gains. This calls for a rededication of member states to the global strategy through mobilizing political and technical support to highlight the human and developmental costs of cholera. With the changing global health financing landscape, member states, WHO, and partners need to come together with more innovative resource mobilization strategies for cholera prevention. Climate resilience, WASH, and disaster risk reductions are key in averting the impact of cholera outbreaks while ensuring communities are empowered and knowledgeable. Global solidarity is also needed to enhance the timely access to medical countermeasures. So Kenya notes the progress made in this report and endorses the recommendations of the Secretariat. Thank you.
Thank you, Kenya being the last. I will now pass the floor to the observers, starting with the member states from other regions, UN and other IGOs, to make their statements on these 5 progress reports. Kindly indicate with which agenda item you are referring to. See no indication? Thank you. You are now invited to present your comments on the following. Under Pillar 3, 1 billion more people enjoying better health and well-being. Agenda items 16.12 to 16.14. I now invite member states wishing to provide comments to do so by raising their name plates. The floor is now open. Nigeria, you have the floor.
Agenda item, thank you, Chair.
Togo.
Agenda item 16.14, progress report on the implementation of the strategic plan to reduce double burden of malnutrition in the African region. We acknowledge with deep concern the findings presented in the report on the double burden of malnutrition across our continent. The coexistence of undernutrition and rising rates of overweight and obesity presents a complex public health challenge that demands urgent, coordinated, and sustained action. We commend the region for the strategic plan 2019 to 2025, which has provided a valuable framework for member states. However, as the report rightly highlights, progress has been uneven. Only 4 of the 9 regional nutrition targets have been achieved, underscoring the need for renewed commitment and strategic recalibration. In Nigeria, we are taking deliberate steps to address these challenges. The launch of the National Multi-Sectoral Plan of Action for Food and Nutrition 2021-2025 has strengthened our coordination across health, agriculture, education, and social protection sectors. We are also implementing projects like the Accelerating Nutrition Results in Nigerian project, which delivers cost-effective nutrition services to vulnerable populations, particularly women and children. Despite these efforts, we recognize that challenges persist, particularly in data integration, enforcement of food policies, and climate-related disruptions. We therefore welcome the recommendation to extend the strategic plan to 2030 and call for enhanced technical assistance, capacity building, and investment in resilient food system. Nigeria remains committed to working collaboratively with regional partners, WHO, and other stakeholders to ensure that every African child, woman, and man has access to safe, nutritious, and affordable food. Thank you.
Togo, front back arm.
Merci, Monsieur le Président.
You, Chairperson, the statement from Togo regarding agenda item 16.14. We would like to support the reduction of the double burden of malnutrition in the Africa region. We have had overweight cases, underweight and stunting. We are concerned because obesity seems to be rising, and we note that there is been a study on NetCode to advocate for a legal framework to improve the situation of malnutrition. We want to put in place specific actions and to combat NCDs. This initiative will also help us address these diseases. We need to look at maternal milk and other related items. We need to strengthen nutrition in the health system, both in the developmental context as well as emergency situations. The Plus-SPEN initiative against NCDs should be scaled up. Thank you.
Followed by Senegal.
Chairperson, the Central African Republic would like to make a statement on agenda item 16.14. We congratulate the Secretariat of the Regional Committee for the quality of the report on the situation of the implementation of the strategic plan to reduce the double burden of malnutrition in the African region 2019-2025, and is happy with the progress made so far. We have made efforts in nutrition, particularly the creation of a multi-sectoral committee, food security and nutrition under the Prime Minister, who's the head of government. We have put in place a Codex Alimentarius and nutritional indicators in DHIS2. And the marketing of milk substitutes is being looked at by the Parliament. We have challenges, including lack of qualified personnel in nutrition, and we have to have difficulties conducting the SMART survey, and we need support of the WHO. We support the adoption of this report as well as the measures proposed and encourage the other member states to adopt it as well. Thank you.
Senegal, followed by Kenya.
Thank you, Chairperson. Senegal would like to make a comment on agenda item 16.12. We congratulate the Secretariat for preparing the progress report on the regional multi-sectoral strategy to promote health and well-being in the WHO African region. Senegal, as it tries implementing the national multi-sectoral strategy, developed a training manual to facilitate the adoption of health and well-being. An agreement was signed with the territorial authorities, civil society organizations, private health facilities, community work actors, and international partners, so that we have an inclusive and participatory mechanism. We want to ensure that the devolving of public health is effective. The new strategy for UHC will provide for a steering committee on accountability. Under the Prime Minister, each sector needs to have terms of reference to contribute to UHC and report on this. To conclude, Senegal would like to invite the Regional Committee to take note of the situational report. Thank you for your attention.
Thank you. Kenya, followed by Angola.
Thank you, Chair. I'll be making a statement on 16.14. So Kenya commends the WHO Regional Officer for Africa for the comprehensive final report and the strategic plan to reduce the double burden of malnutrition in our region. So Kenya fully aligns with the planned objectives and has made notable progress. Through the Kenya Nutrition Action Plan, we have institutionalized priority interventions across the sector. We have strengthened enforcement of the Breast Milk Substitutes Act, and developed Kenya's nutritional profile model, and initiated reforms on front of package nutrition labeling and market restrictions targeting unhealthy foods. We're encouraged by our improvements in our child nutrition outcomes. Stunting is down, wasting is at below 5%, and exclusive breastfeeding has surpassed the regional target, reaching 60%. We have integrated nutrition indicators in our national DHSI systems and scaled up early detection and management of malnutrition along the continuum of care, including at the community level. Kenya strongly supports and endorses the extension of the strategic plan to 2030 to align with the global nutrition targets and allow member states to continue implementing gaps. We endorse the call to strengthen leadership and data systems, multi-sectoral coordination, and emergency preparedness, especially in the face of climate shocks that continue to threaten the nutritional gains in our arid and semi-arid areas and regions. We urge the WHO and partners to provide increased technical and financial support, even in these difficult financial times, to member states to scale up high-impact, context-specific interventions and accelerate regulatory and legislative reforms that promote healthier food environments. Kenya remains committed to this work and to work with all stakeholders and other countries. We thank you.
Angola, followed by Campos.
Thank you very much, Mr. Chair. Angola would like to thank the Secretariat for preparing the report. I'm particularly referring to the priority interventions on the long term when it comes to reducing the double burden of malnutrition in the African region 2019-2025. Our country continues to face this double burden. It is characterized by a 40% rate of chronic malnutrition for young children. On the other hand, the consumption of highly processed foods and unhealthy food leads to obesity. Angola is committed to improving the quality of food consumed in line with global nutrition targets. We aim to incentivize people to eat healthily throughout their lives. And in line with this, we have a nutrition strategy on a national level. We also have a policy for school meals. We have a marketing code for breast milk, and we also have an integrated program focusing on prevention. So besides the fact that we've made much progress, certain challenges remain, such as the need to develop our nutritional pharmacovigilance system, we continue to benefit from the support of the WHO and other partners to strengthen leadership and strategies which tackle all forms of malnutrition. Thank you.
Comoros, followed by Zambia.
The Union of Comoros would like to make a statement on item 16.14. In the Union of Comoros, malnutrition has become a public health problem. We have been trying to reform the nutrition system by developing a national nutrition and feeding program. We are also conducting surveys on attitudes and practices. In the country, several steps have been made to combat malnutrition, and infant malnutrition is very critical. In 2012, we had high cases of chronic malnutrition, and the rate went up. In addition, the newborns have low weight at birth, and this, of course, increases their vulnerability to diseases and compromises their growth. We want exclusive maternal rights, as well as ensuring that children have adequate nutrition. We've been organizing annual campaigns to screen for malnutrition, conducting deworming and vitamin A campaigns. Despite all this, the challenges persist. We have poor households, we have poor feeding habits, and the low education of mothers, as well as cultural beliefs. We need to ensure that
the floor is
Thank you very much, Mr. Chair. On behalf of the government of the Gambia, I wish to commend the WHO Regional Office for Africa for the timely and detailed report on the implementation of the strategic plan for the reduction of the double burden of malnutrition in the region. We welcome the notable progress, particularly the adoption of the legislation aligned with the International Code of Marketing of Breast Milk Substitutes by 34 member states. The Gambia is proud to report an exclusive breastfeeding rate of 53.6%, exceeding the regional target of 50%. To combat the double burden of malnutrition, the Gambia continues to collaborate with the local and international partners and has implemented interventions, including the development of the National Food-Based Dietary Guidelines, contextualized to promote healthy eating habits across the life course, community-level cooking demonstrations, which promote the use of nutritious, locally available foods to improve household practices, scale up positive deviance interventions on exclusive breastfeeding, empowering communities to adopt behaviors already working for well-nourished children of similar context, integration of nutrition education in primary healthcare and schools, and continued capacity building of frontline health workers, ongoing nutritional surveillance through the MWAC, that's the mid-upper arm circumference screening. The mother-led MWAC interventions have significantly improved early detection, reporting, and treatment of acute malnutrition. We've also invested in public engagement, working with religious and community leaders to promote breastfeeding and improve on child feeding practices. Thank you very much for your kind attention. Thank you.
Madagascar, followed by Mozambique.
Thank you, Chairperson. Madagascar approves the report presented by the Secretariat. We are proud to be part of the Scaling Up Nutrition program, and we have been signed the Global Pact on Malnutrition. A multi-sectoral approach has been adopted, and we integrate nutrition in PHC, agricultural, social protection sites. We have agricultural programs sensitive to nutrition, and we also educate mothers on exclusive breastfeeding, as well as the provision of micronutrients. We have been working with Child Nutrition Fund and the World Bank. We are aware of the challenges, and we have a national budget deficit that is limited, and that, of course, is combined with our vulnerability to climate change. We want to consolidate the local food systems, build resilience, improve our data for better monitoring and accountability. We support the key priorities on the promotion of the sharing of good practices in African countries for sustainable funding mechanisms for nutrition with actors to combat malnutrition and obesity. Once again, we reiterate our strong commitment and the multi-sectoral approach for the sustainable progress of the region. Thank you.
Mozambique.
Thank you very much, Mr. Chair, for giving me the floor. I would like to comment on 1613. And I do this because Mozambique has committed at the highest level to this, that is community engagement. And the President, His Excellency Daniel Chapo, has punted this. We have mapped out community needs and implemented mechanisms which promote the involvement of communities in preparation for emergencies. Mozambique is involved in finding concrete steps to fund mechanisms which increase surveillance within communities, and they are fully integrated into our response plans, and they are a part of our cross-border regional strategies. We call on the member states of the WHO, as well as our partners, to provide technical and financial support in the normative framework when it comes to community engagement. We need to ensure that we increase the resilience of communities. The health of our communities depends on our ability to listen, learn, and act together. Mozambique reaffirms its commitment to transforming the healthcare system, making community engagement a fundamental pillar of it, because this would improve justice and equality and equal access. I'd like to take this opportunity to thank you for the technical support, which has been invaluable. We support this report. Thank you very much.
I see no more cards. Thank you. I will now pass the floor to the observers, starting with the member states from other regions, UN, and other IGOs, to make their statements on these 5 progress reports. Kindly indicate which agenda item you are referring to. See none? I understand that several non-state actors have requested to deliver statements of this agenda item, and they are now invited to do so. International society You have the floor. IAEA.
Thank you, Mr. Chair. As it must address increasing demands of cancer services, Africa is also facing a double burden of malnutrition, stunting and obesity. Treatment outcomes and survival in cancer patients depends on the nutritional status. The IAEA helps to build the capacities of member states in Africa to improve micronutrient status among children and develop 2-year regionally harmonized master's degree in program in human nutrition and nuclear technique. The program is hosted by Morocco, International, and South Africa, Ghana, and Zambia. Further, it is at advanced stage approval in Senegal. We look forward to continuing our fruitful collaboration with WHO to reduce inequity in access to health care in Africa, tackling the cancer burden through multi-sectoral, multidisciplinary, and evidence-based approach founded on universal health coverage. Thank you.
Now revert to where was International Society of Physical and Rehabilitation Medicine.
Thank you, Chairperson. This statement is on Agenda 16.12. Distinguished Delegate, the International Society of Physical and Rehabilitation Medicine welcomes the progress report on the regional multi-sectoral strategy to promote health and well-being in the WHO African region. Considering the burden of communicable and non-communicable diseases, impacts of climate change, armed conflicts, and humanitarian crisis in the region, rehabilitation is a key strategy to improve health and well-being of population. In this regard, we call on member states to integrate rehabilitation and assistive technology in multi-sectoral actions and policies implemented to improve health and well-being of outcomes in African region. Thank you.
African Media and Malaria Research Network.
Thank you, Chairman. On 16.12, African Media and Malaria Research Network calls for intensified efforts towards the elimination of the otherwise preventable diseases. Partnerships must be strengthened between health institutions, government, civil society, and the media, and to invest in behavioral change communication to drive uptake of proven interventions such as use of bed nets and vaccines. As a network of journalists, health advocates across Africa, AMREN recognizes the critical role of effective communication in achieving the vision of health for all. Communities must understand and trust health interventions and actively participate in them. AMREN pledges to work with partners to bridge the gap between scientific research policy and the public on health interventions through accurate, timely, culturally relevant health information. We therefore call on WHO and partners to strengthen media capacity. Thank you so much. Obrigado.
Thank you, the Chair. The NCD Alliance and Africa NCD Network applaud WHO and member states for committing and institutionalizing social participation and community engagement and welcome progress on the regional strategy. We people living with NCDs have the right to participate in decisions affecting our health. Lived experience is crucial for identifying barriers and solutions. Policies, programs that are co-developed with lived experience people are more likely to be effective and sustainable. Social participation can build trust, unlock ownership, increase accountability, and promote people-centered health systems. We members of Lived Experience Network report that engagement remains too often reactive rather than embedded in healthy programs. Therefore, Mr. Chairman, through
International,
team reserve
of the floor.
Thank you, Chair. Item 16.13. We commend the WHO Region Office for Africa for advancing the community engagement strategy. Community empowerment is fundamental to achieving health equity, sustainable development, and the resilient health systems. One area where WHO, Afro, and countries of our region can unlock significant progress through community engagement is alcohol prevention, policy, and treatment services. The members of Movend International across our region show how effective community engagement can help advance alcohol policy development. It can provide addiction services when governments don't, or can, and help empower people, families, and communities to overcome alcohol use disorders and addiction. And it can help raise awareness of alcohol harm and support both people and politicians to resist alcohol industry interference and co-create solutions that improve health and development. We urge member states and WHO Afro to ensure that alcohol policy is integrated into future community engagement strategies. Thank you.
Thank you. I see no more requests from the floor. You are now invited to present your comments on the following under Pillar 4, more effective and efficient World Health Organization, providing better support to countries, agenda items 16.15 to 16.17. I now invite member states wishing to provide comments to do so by raising their nameplates. The floor is now open. Congo, followed by Senegal.
Je vous remercie, Monsieur
Thank you,
le Président.
Mr. Chair.
Le Congo aimerait intervenir au
The
point
Republic of Congo would like to
16,
focus on 1615.
La délégation de la République du Congo
Our
félicite
delegation
le
congratulates the Secretariat
présentation du
for the presentation of the progress report on the framework for integrating country and regional health data in the African region.
et exprime sa reconnaissance
We
pour les
are
efforts
grateful for the
déployés
efforts that have been made
d'améliorer la
to
collecte,
improve
l'intégration
the collection,
l'utilisation
integration, and use
des données de santé
of
dans notre
health data in our
Nous
region.
saluons la mise en place
We
de la version
welcome the
alpha du Centre
implementation
régional de
of the Regional Data Hub
hébergé sur une
2024-2030,
plateforme
and we
sécurisée
also
qui
look forward
constitue une avancée
to
majeure
the use of secure data. This is a step forward towards the interoperability and access to reliable data in order to guide decision-making based on evidence. On a national level, we are facing several challenges. For example, in limited interoperability of our existing systems. This requires manual transfer of data. We also have a need to strengthen the technical and human capacities when it comes to integrating data. We also need a robust national framework in order to guarantee confidentiality, security, and usefulness of the data. The Republic of Congo supports the next steps which have been proposed, and we reaffirm our commitment to collaborate closely with the WHO, other member states as well, so that we can make the Regional Data Hub a definitive strategic instrument. It will help make interventions in public health more effective and will contribute to better results. Thank you.
Je vous remercie, Monsieur le Président.
Thank you very much, Mr. Chair. Senegal would like to speak under item 1615. We welcome the significant progress made in implementing the framework for integrating regional and national health data within the African country region through the Regional Health Data Center. In line with the National Agenda for Transformation, Senegal 2050, our government reaffirms its commitment to accelerating the harmonization of its health data platforms by promoting interoperability and strengthening national capacities when it comes to data governance. Therefore, with a view towards digital sovereignty and full digitalization of the health system, Senegal has already begun deploying the electronic patient record, is also considering the creation of a National Center for Health Intelligence and Data. To this end, we also commit to strengthening our national health data governance body to ensure compliance with international standards and to actively contribute to the regional technical working group established to lead this process. Thank you very much.
Yeah, followed by Nigeria.
Thank you, Chair. Kenya will be commenting on item 16.15. Kenya announced the progress on regional health data hub 2024-2030 framework, which promotes seamless data integration for improved analytics and evidence-based health decisions. The country is advancing digital transformation, recognizing digital health as a vital to achieving national goals. To address fragmentation and interoperability issues, Kenya is implementing a digital superhighway to harmonize data, enhance service coordination, and support disease surveillance. This strengthens digital health interventions and cross-border collaborations. The country has enacted the Kenya e-health policy 2016-2030, which focuses on integrating digital technologies to improve health access, efficiency, and quality to achieve UHC. The policy is underpinned by the Digital Health Act 2023. This framework aims to establish a comprehensive health infrastructure, enhance data governance, and promote innovation and healthcare delivery. Kenya endorses the proposed next steps and urges continued WHO support to help member states fully realize their strategy's objective. Asante sana. Thank you.
Nigeria.
Thank you, Chair. Agenda item 16.15. Progress report on the framework for integrating country and regional health data in the African region, regional data hub. We commend the Secretariat for the comprehensive progress report on the regional health data hub and the development of the regional data governance framework. We recognize that timely, reliable, and interoperable data are essential for strengthening evidence-based decision-making and for advancing health outcomes across the African region. At the national level, Nigeria has made deliberate efforts to strengthen health information systems, including scaling up the use of district health information software, DHIS2, implementing electronic surveillance through the integrated disease surveillance and response system, and expanding digital health platforms at the primary healthcare level. These investments reflect our commitment to improve data quality, availability, and use. We note, however, the challenges outlined in the report, particularly the issue of data fragmentation and consideration, the sovereignty of every nation. We are committed to promoting interoperability and strengthening our national data governance structures to ensure compliance with privacy, security, and standardization requirements. Nigeria and Ethiopia currently shares the Health Tech Hub Africa initiative, which brings together health tech innovations from African startups to enrich our health data management. We therefore encourage WHO and partners to continue aligning the regional health data hub with global initiatives while supporting member countries in capacity building, infrastructure investments.
Ghana, you have the floor.
Thank you, Mr. Chair. Ghana, thank you for the opportunity to take the floor to comment on agenda item 16.17. Regional matters arising from WHO internal and external audit reports. Ghana acknowledges the comprehensive effort of WHO Afro in strengthening accountability, risk management, and operational transparency across the region. We commend the Secretariat's progress in implementing 93% of internal audit recommendations and all external audit recommendations, reflecting a maturing control environment. The Ghana Audit Review noted an overall good control environment. The overall justification rate was 85%, implying that 85% of expenditures were adequately supported with the right documents. Ghana is proud to have closed all 11 audit recommendations from its 2023 review and to have reimbursed $54,000 on justified direct financial cooperation expenditures from 3 defaulting implementing partners, demonstrating our commitment to financial integrity. We also celebrate our participation in the Digital Payment Initiative, which has enhanced transparency and health worker satisfaction. Additionally, implementing partners who trained on WHO standard operating procedures to minimize the incident of anomalies found during the audit. We support the call for member states to collaborate closely with WHO country offices to ensure timely DFC reporting and to embed risk mitigation strategies in program delivery. Ghana remains committed to upholding the principles of accountability, equity, and partnership as we work together to build resilient health systems. Ghana notes the report. Thank you.
Madagascar, followed by Gambia.
Merci, Monsieur le Président. Thank you, Mr. Chair. We would like to speak on 1615. Madagascar aligns itself with the initiatives led by the Secretariat. In terms of regional health data, we continue to follow regional and global directives which guide our collection of data. Madagascar has made significant progress when it comes to digitalizing its healthcare system. Currently, we have a national data hub, and this allows us to harmonize monthly reports at all levels on this platform. We also have a strategy to ensure effective interoperability across different communities. We also have a register of data centers, and this is being done at the moment. All of this goes to show that we are becoming more and more independent. However, we are sure that the challenges are not going to be easy to overcome. For example, the need to ensure quality data. There is also a cultural and logistical challenge. Given these issues, Madagascar continues its efforts and supports the regional data hub proposal. We note the progress that has been made as stated in the report. We would like to call for regional discussions where our experts will be able to dialogue. In conclusion, our commitment is clear. Better integration of data is fundamental so that we can be led by effective data. Madagascar will continue to work actively with its regional partners and global partners.
Gambia, you have the floor.
Thank you very much, Mr. Chair. We wish to express our sincere appreciation to the World Health Organization, Regional Office for Africa, for the insightful and comprehensive report on staffing in our region. We recognize that the WHO personnel are the backbone of our collective efforts to improve health outcomes across Africa. The data and analysis presented offer valuable clarity on the composition, distribution, and challenges facing the WHO workforce. However, we must also confront some persistent concerns. First, the issue of gender imbalance. While we acknowledge the progress made from 29.8% female representation in 2016 to 34.2% today, we are still far from achieving true gender equity. We urge the WHO to accelerate efforts to recruit, retain, and promote women, especially in leadership and technical roles. Gender equity is not outreach to underrepresented member states and the persons with disabilities is a step in the right direction. We encourage further action to ensure that the WHO workforce reflects the full diversity of our region and is responsive to local health needs. Finally, we are deeply concerned about the funding shortfalls resulting from reduced contribution by key health development partners. Staffing is not a luxury, it is a lifeline. We call on the Secretariat and member states of the WHO to explore innovative and sustainable financing mechanisms that protect staffing levels and ensure continuity of essential health services, especially in resource-constrained countries. Chairperson, the Gambia stands firmly behind WHO's staffing reforms. We are ready to collaborate in building a resilient, equitable, and representative workforce, one that can meet the health challenges of today and prepare for the uncertainties of tomorrow. Thank you very much.
Ethiopia.
Thank you, Chairperson. The government of Ethiopia commends the WHO Regional Office for Africa for the significant progress made on the Regional Health Data Hub initiative. We recognize the importance of this framework in addressing data fragmentation and promoting evidence-based decision-making to advance health outcomes across the region. We are fully committed to this vision of a harmonized, integrated, and secure health data ecosystem. As a member state, we have reviewed the progress report and noted the importance of a comprehensive, inclusive, and transparent process for developing and finalizing the data governance framework. We recommend that WHO Afro establish a formal mechanism for member states' participation in requirement elicitation and review of all foundational documents, including verifying previous engagement and implementing structured review cycles with sufficient time for national level consultation. The proposed data sharing agreement is subject to comprehensive review at the national level. It is recommended that member states receive the draft agreement before the signing phase and that the agreement allows for adjustments in accordance with the national legal and procedural requirements, including those necessary for sharing information internationally. We believe that the success of the hub is contingent upon the capacity of member states to provide high-quality data. Therefore, the governance framework must explicitly address the provision of technical and financial support for countries to strengthen their data systems, align with the standardized metadata requirements, integrate with program-specific digital health initiatives, and build robust national data warehouses as a more sustainable approach to integration. Finally, we urge that the hub initiative explicitly consider and articulate the tangible benefits for member states. Beyond the sharing of data with WHO Afro, countries must gain guaranteed access to their own aggregated and analyzed data, as well as platform for regional collaboration and comparison with anonymized data from neighboring countries. We believe the hub should be designed to support and strengthen national level analytics, providing a clear incentive for full participation. I thank you.
Thank you. I will now pass the floor to the observers, starting with the member states from other region, UN and the other IGOs, to make their statements on these 5 progress reports. As usual, kindly indicate which agenda item you are referring to. I see none. I see none. I understand that several non-state actors have requested to deliver statements on this agenda item, and they are now invited. I have one, the National Society of Physical and Rehabilitation Medicines.
Thank you, Chairperson. This statement is on agenda item 16.15. Distinguished delegate, the International Society of Physical and Rehabilitation Medicine welcomes the progress report on the framework for integrating country and regional health data in the African region. We urge that rehabilitation indicator as well as functioning be included in health data integration process of the regional data hub. This will strengthen evidence-based policymaking and investment, ensuring rehabilitation services are available, accessible, and of high quality in African region. Thank you.
Thank you. I see no more requests from the floor. Is the regional committee ready? No, the Secretariat has taken note of your comments. Is the regional committee ready to know the information, documents, and agenda item 18? I see no objection. The documents noted. This was for 2 minutes, but not going out in readiness for closure. Please, we should remain within our seats. Zambia wants to greet you in a way to remember you before we close. The reason for pauses, I need members outside having coffee, tea, to come in, please. Check. The member states, call them please to come and take their seats. Secretariat and announcements. Secretariat.
Thank you, Chair. Dear ladies and gentlemen, I would like to announce tomorrow's ministerial dialogue, which should be hosted here in this same venue. So the ministerial dialogue will take place in this same venue, in this plenary room, tomorrow, 28th August, from 9 to 12:40 p.m. And invited are all ministers, head of delegations, plus 2 delegates. Further, we would like to announce that you are requested to kindly fill in the departure form so we can program you for your shuttle. Please fill in the information for your departure so you can be scheduled for the shuttle bus. And you will find the QR code on the screen. Please scan it and fill in the form. This helps us to provide you the bus and the cars at the right time. Thank you very much.
Honorable Ministers, distinguished delegates, the Regional Director, Dr. Janabi, would like to say a few words and present something to the Honorable Minister of Zambia, who has been an excellent chair. Dr. Janabi, over to you to recognize our Honorable Minister and Chair. Thank you.
Okay. Thank you. Mr. Chairperson, on behalf of WHO Afro, would like to give you a small token of appreciation for everything you've done.
The snake. Wow. Reads Mr. Elijah Mchima, Minister of Health of Zambia, Chairperson, RC 75. Thank you very much for remembering me within the shortest possible time. It has been a tour for us in Zambia. We cherish every moment of being with you. All of you have been very, very kind, sweet, and we wish to continue for the next 2 weeks. Thank you very much. Thank you. Thank you very much. Thank you. Thank you, my vice. Okay. Thank you. And our able colleagues, thank you very much.
Mr. Chairperson and honorable ministers, head of delegation, before we move to our next program, let me just take this opportunity to, while we are waiting to finalize the gifts, to say thank you to Ms. Pamela. This is her last regional committee, a bigger part. And then,
yes. In retaliation, one time there was a president who said, "You have fed me, and I'll also go and revenge. You have recognized me on behalf of Zambian government. You can't also walk out of Zambia without a token of appreciation." I'm inviting my colleagues to go around our countries that are here with a piece of appreciation from the Zambian government, particularly from my president, our president, Hakainde Hichilema. Please accept the little token as the people will be going around. Please, we thank you and appreciate you on behalf of Zambian government. No, no. It is a pleasure at the hand of the Zambian government. Indeed, we are walking the talk, and as you can see, we have become one family. These are not my closing remarks. I just want to take also an appreciation to honor our regional director, WHO Afro, in recognition of his good work and championing the success of this meeting. Thank you. And to our dear lady, Pamela, a great teacher. Within a short time, I was taught regional director, my deputy and myself for the great work. I'm told she's going into retirement. We have tried to persuade her to be with us. She's saying, you know, enough is enough. I've seen many, I've taught many for so many years. I want to leave room to the young ones. Great.
Thank you. Very much. Thank you. Thank you. Thank you.
Thank you very much. Ladies and gentlemen, we have now reached the closure of the 75th session of the Regional Committee. Before we close, allow me to remind you that our last side event, recalibrating World Health Organization emergency preparedness and response, EPR work, and partnerships for public health emergency. Management in Africa, smarter, sustainable, and locally driven solutions would take place immediately after the closure of the regional committee. In accordance with Rule 20 of the Rules of the Procedures, Secretariat shall, in collaboration with the rapporteurs, prepare the final report of the committee, which shall be shared with the member states for adoption within 60 days. Member states shall have the opportunity to inform Secretariat of any corrections that they wish to make. Now, I would like to invite the Honorable Minister of Health for Senegal, Dr. Ibrahima SC, to deliver the vote of thanks.
Merci beaucoup, Monsieur le Président.
Speaker's microphone is off. Interpreters cannot follow the Honorable Minister. Kindly adjust the sound of the microphone of the Honorable Minister.
De la République de Zambie, en vue d'assurer le plein succès de la 60e
I'd like to thank the Republic of Zambia for ensuring the success of the 75th session of the WHO Regional Committee for Africa, which took place in Lusaka, Zambia from the 25th to the 27th of August. We received a particularly warm welcome, and we thank the government and the people of the Republic of Zambia. like to thank the President of the Republic of Zambia, His Excellency Hakainde Hichilema, for the logistics and arrangements availed to the delegations, as well as his inspiring and encouraging speech that he made during the opening ceremony of our RC session. I would like to express our gratitude to the government and the people of Zambia for their outstanding hospitality. Request the current regional director to convey our thanks to His Excellency, the President of the Republic of Zambia, Hakainde Hichilema. Thank you.
Thank you very much, Your Excellency. May I now request the regional director to address the regional committee.
Excellencies, Honorable Ministers of Health, heads of delegation, distinguished delegates, colleagues and friends. As we draw the curtain on the 75th session of WHO Regional Committee for Africa, I stand before you with immense gratitude and deep humility. This week has been more than a meeting. It has been a milestone. For me personally, it marks my first regional committee as a regional director of the WHO Afro. It has been a profound learning curve, but also a really pleasure. I had the opportunity to get to know many of you more closely, to hear your perspective, and to share in your unwavering commitment on the health of our continent. We have deliberated with purpose, debated with passion, and decided with unity. From health security and local production to non-communicable diseases and emergency preparedness. RC 75 has reaffirmed our shared vision that every African deserves access to quality, equitable, and resilient health systems. Allow me to take this moment to express my deepest appreciation to His Excellency, President Hakainde Hichilema, for his leadership and gracious hosting of this committee in the Republic of Zambia. To Honorable Minister of Health, Dr. Elijah Muchima, for his tireless efforts and a warm hospitality. To the people of Zambia, whose generosity and spirit have made us feel truly, truly at home. To the chairperson, vice chairperson, rapporteur, whose stewardship ensured our deliberations were focused and fruitful. Our media, thank you for keeping the globe updated. To the catering staff and the cleaning teams whose behind-the-scenes dedication kept us nourished and comfortable throughout these 3 days. To our drivers who made us reach our destination safely. Your contribution, visible and invisible, have made RC 75 success. As we leave Lusaka, let us carry forward the energy, the ideas, the solidarity we have built here. Let us turn resolutions into results and commitments into action. I and we at WHO Afro Brazzaville will never let you down. We are here to serve, to support, and stand with you. Every step of the way, Thank you for your trust. Thank you for your leadership. And thank you for believing in the future of a healthy Africa. I wish you safe travels, and I look forward to continue this journey with you, one in your respective countries. Thank you. Merci beaucoup. A bientôt. Muito obrigado. I look forward to seeing you in Addis, August 2026. Asante sana, and see you soon. Thank you.
Thank you, Dr. Janabi. We admire you for settling down so quickly. Now, allow me to offer my closing remarks. Honorable Ministers of Health, Regional Director, Professor Janabi, Your Excellencies, distinguished invited guests, ladies and gentlemen, let me thank you again for your availability and dedication to craft our common position on various issues affecting our continent. It is always tough to pave a common position, and what we have tried to do is to hear the various voices of representatives of our people on the continent. Honorable Ministers, Excellencies, allow me to thank you, my vice chairpersons, for the way they led various sessions in my absence when I was around in the background, just admiring the skills. Also, allow me to thank the World Health Organization, AFRO, Regional Director, for the way he has fitted in his new role and already for the excellent leadership skills he's exhibiting. My fellow ministers, Excellencies, ambassadors, including our technical staff, you have been superb. And as a chair, I'm proud of the work we have done in this meeting. I look forward to more fruitful engagements which will make our continent happier and safer. This is true Africa. Honorable Ministers, Excellencies, I'm glad to have noted that we all want equitable access to health products. We all want increased access to vaccines, diagnostics, and therapeutics. We all want to have technology transfer and local production capacities. We further want sharing information, ideas, resources, and expertise. Above all, we want to play a critical role in raising resources domestically to support our health systems and also to be part of the supporters for our WHO. As I conclude, fellow ministers of health, let me say that for us to be recognized as true champions of universal health coverage, let us endeavor to advocate for sustainable health financing with African countries contributing a fair share. Let us go back to each one of our governments to raise awareness on need to increase resource allocation to the health sector. This is not only for pandemics, but for general health service delivery in general. Honorable Ministers, distinguished delegates, I can say that the spirit of unity, love of humanity, and common purpose guided our deliberations. True to my heart, true to the heart of the Zambians, to the heart of our president, we feel part of you, part of Africa. This is a unifying committee meeting held here in Zambia, in Lusaka, and we congratulate Ethiopia for taking up the mantle without any resistance from everywhere. I thank you. I wish you a safe travel back to our second home, to us Zambians. I now declare 75th session of the Regional Committee for Africa closed.
Excuse me, ladies and gentlemen, colleagues, can we have all WHO staff, all WHO personnel coming in front here for a quick group photo so that we can transition into the next event, the last event for the day. So please come forward quickly, all WHO. Let's gather right here in front for a group photo. And the rest of the colleagues, can you maintain your seats and we'll start the next event shortly.
Okay. Okay, yeah. All right, thank you very much. We're now ready to have the panelists to come forward to the high table. Dr. Abdul Salam Gay, representing the RD, please come forward to the table. Dr. Deo Nshimirimana, please come forward. Dr. Chikwe Ikweazu. Dr. Landry Sage, please come forward. Dr. Hussein Isse. Dr. Ibrahima C. Dr. Daniel Kabayinze, please come forward. If we can also have on the stage, Ms. Uzomaka Gilpin, Dr. Irene Kiza, and Dr. Chris Elias, please come forward so we can begin the final events, the side events on emergency preparedness.
We're still waiting for a few members to join the panel. Dr. Chikwe Ikweazu, please join the panel. The Honorable Dr. Hussein Isse, please come forward. The Honorable Dr. Ibrahima C, please come forward. Dr. Daniel Kyabayinze, please come forward. Okay, perfect. Thank you, sir. Ms. Uzomaka Gilpin, Dr. Yes, excellent. Thank you so much. We'll be starting in just any moment now. Can you increase? Yeah. All right, we can go ahead and get started. This session is all about emergency preparedness and response in resource-constrained contexts. We're looking at paradigm shifts. And just to lay the context a bit for us all, we know that the landscape of emergency preparedness and response, EPR, in the WHO African region is at a pivotal junction. So this is what we want to discuss at this side event. And the objectives, I'd like to just lay out the objectives for you for this event. The objectives are to provide an update on the regional and global developments in EPR in the African region. We also hope to engage member states on resilience, management, and sustainability. These three words are so important. And finally, the objective for this side event is to enhance partnership and alignment with national priorities for EPR. So that's what we hope to achieve in the next 90 minutes or so. At this time, I would like to invite for the opening remarks and to set the tone a bit further for this conversation, Dr. Abdou Salam Gay. Thank you very much.
Bonsoir tout le monde. Il fait tard et dans ces périodes-là, je commence à avoir des maux de tête.
Good evening. I know it's late and we're beginning to get headaches and I prefer expressing myself in French.
Merci beaucoup.
Thank you very much.
C'est un honneur pour moi.
It is an honor for me to begin the discussion, to set the tone,
Essayer de mettre les choses un peu en place et en contexte.
try to contextualize our discussions.
Des signaux qui
There
arrivent
signals
quand vous avez l'honneur de gérer
that
quelque part
you
dans la
have
gestion.
when you're in management, and the management capacity depends on how you detect signals and how you respond to them.
Nous qui avons eu le privilège
We
et
have
l'honneur
had the
de
privilege
gérer
and
des
honor
emergencies en Afrique,
of
on a détecté
managing
récemment
emergencies in Africa, and I have identified three signals. The first
est que
is
lorsque
that
COVID-19
when COVID-19 hit us,
les pays s'attendaient à ce qu'il y ait une
countries
solidarité comme
were
d'habitude,
expecting the usual
aussi des
solidarity
supports
as well
techniques
as technical support,
et matériaux.
as well as
Au cours des
material assistance
Cela n'a
for
pas eu
response.
lieu.
However,
Les pays
this was not the
africains se sont
case.
débrouillés
African
et
countries
ont eu des réponses
were left to their own
vraiment
devices
efficaces.
and
Les
came up
millions de
with
morts qu'on
effective
espérait
responses.
ne se sont pas
The
passés
millions of deaths that we were
et l'économie
expecting
aussi
did not
a
occur,
pu survivre
and
malgré
our economies
quelques
survived despite
Et les pays sont
several
sortis
hitches.
avec un état
Countries
d'esprit en
came
matière
out
de réponse aux urgences
with an
divers.
emergency
Ils ont eu
response
beaucoup plus confiance
mindset.
en eux
They had
parce
more
qu'ils ont eu
confidence in
beaucoup plus de
themselves
capacités
because they had
qu'ils ont
more
appris
capacities
grâce
that
à cette
they
façon de faire,
learned
souvent sans aide.
hands-on
Le deuxième
without
signal
assistance. The
est
second
lié au
signal
fait que
is linked to the fact
il y a eu
that
récemment
recently,
pour certains donateurs
for
de
some
l'Organisation mondiale de la
donors
santé
of the
ont réduit
WHO,
leurs dons
there
à
have been
l'organisation parce
budget
qu'il y a un
cuts
changement de priorité.
because there is a
Mais
change
cela,
in
c'est pour l'ensemble de
priorities.
l'organisation,
And
pour
this
les
applies
États
to all organizations. For emergencies, it began earlier on because the funds that were set aside for COVID dried up progressively. That is the second signal. The third signal regarding WHO is the fact that for some time we have been pushing our limits in terms of moving staff to Dakar, Nairobi, and elsewhere. We have personnel that have increased extraordinarily. And the signal is that we did not have the usual response. We were closer to countries, but there are realities that we needed to take into account. So those are the three signals that we would note. Changes in countries linked to COVID, changes among donors because they change priorities, and changes linked with the fact that at the geographical level, we were no longer in Brazzaville, but we were in Dakar, Brazzaville, and Nairobi, and the intention to go to Pretoria. And these signals required some analysis. I did some analysis following some steps. For countries, we had a member state survey using an independent firm, and that firm sent us results and analysis. In addition, we conducted a strategic analysis using experts and our own expert teams as well, to talk about hubs. And then we followed the recommendations from HQ to see how to react in terms of budgetary cuts. And we have applied the recommendations and their results. So there are three packages of results linked to the three signals I mentioned. All these results were put together, and now is the time for me to introduce the Technical Advisory Group, TAG. The Technical Advisory Group is composed of 15 people who were appointed by the regional director to give advice on health emergencies and emergency preparedness and responses. We have experts and volunteers gave their CVs, and an independent group also contributed names. So we gave the results to the group to come up with recommendations. They met 2 weeks ago, and they've come up with general recommendations that will be presented to you, and in a clear terms, there's a document that will be circulated to you. And the discussions that were held last week were held for everyone to be able to listen and share. The TAG chair is seated here, and I'd like the TAG chair to talk to us about what they did with the results, but I'd also like to get the views from Dr. Chikwe, who's also seated here, and at the continental level from the representative of Africa CDC, and at country level for the honorable ministers who are seated here. The objective is to have a discussion and for you to tell us what you think we need to do based on the situation and the changes that we've noted given the three signals I highlighted. Thank you.
Thank you very much for those opening remarks, Dr. Gay. At this time, I would like to call upon the group chair of the EPR Technical Advisory Group to give us some expert insights, reflections, and recommendations from the EPR TAG. Please welcome forward to the table to speak Dr. Dio Nshimirimana. You can come forward to the podium.
Thank you very much. Honorable Ministers, Your Excellencies, ladies and gentlemen. Salam has already discussed and introduced the Emergency Preparedness Response Technical Advisory Group. I'm not coming to that. But let me start with this question. Is WHO Afro fit for purpose in emergency preparedness and response for its role with member states, other regional partners, and global partners? To answer this foundational question, WHO Afro commissioned a survey of member states. These are the findings that we want to reveal. Countries see WHO as a trusted partner in preparedness and response, and its normative guidance and technical advice is a core strength they value. Second, countries want WHO to strengthen its work in certain areas. First one being preparedness in the area of multi-sectoral and partner coordination. The second response, WHO Afro should advocate for the inclusion of local actors and civil society in emergency response. And third, fostering coordination of regional and continental partners to improve preparedness and response. Countries said that capacity building is of the highest priority for future improvement in preparedness and response, and therefore want WHO Afro to have deeper long-term investment with institutions, healthcare workforce, and long-term subnational capacity building strategies. Based on these findings, the TAG recommended WHO Afro encourage countries to develop a multi-sectoral inclusive approach and support the engagement of national and subnational levels, and to engage more intensively on cross-border and regional coordination for coherence. These observations are also echoed by the Ministers of Health in this regional committee. How should WHO Afro support countries in emergency preparedness and response? The TAG has made some recommendations. The first one, WHO Afro should be transformed to adapt to the current geopolitical changes which are likely to persist. WHO Afro regional hubs to address coordination with stakeholders, set expectation on support for member states. Support countries to harmonize surveillance systems at national level. This is especially needed during responses. Strengthening national workforce in emergency preparedness and response, and supporting with external emergency response when requested. African learning institutions must be engaged to create a sustainable pipeline of the needed workforce. And finally, WHO Afro should continue to reprioritize its work in preparedness, detection, and response. Regional coordination and alignment are non-negotiable. Without it, confusion, inefficiency, and wasted resources will occur, and that is not permissible. We have a call to action to Ministers of Health. Emergency preparedness and response begins and ends in the country. Therefore, there is a strong need to mobilize domestic financing and sustainable investments to be ready and to respond. For instance, other countries have created a fiscal space during parliamentary budget process, while others have created national emergency funds. Let me say that external support and funding should be secondary to this. Second, gain awareness of the new IHR amendments and pandemic agreement, and these will have an impact on your national preparedness and response goals, as well as legal and political implications. I encourage the honorable ministers to talk with your peers in the region, share information, and coordinate on your efforts in emergency preparedness and response. Lastly, use your voices in country first, including with other line ministries, example, Ministry of Agriculture, Finance, Animal and Livestock, and partners for a coordinated effort in line with One Health approach, and at regional and global forums to represent these interests on your countries and African region. In closing, WHO Afro and countries must prioritize human and financial resources for emergency preparedness and response. You can never take your foot off the pedal. Public health threats exist everywhere all the time, and response is much more expensive than prevention. I thank you.
Thank you very much. Thank you very much, Dr. Nshiri Mirimana. I'm sure that throughout the conversation, we will hear more about capacity building. Moving forward, we can receive the remaining remarks from the panelists here at the panel. No need to come to the podium. Thank you very much. At this time, I would like to call upon Dr. Chikwe Ikweazu to share his own reflections, specifically from a global response in regards to EPR.
You said we could stay here, right? You said we could stay where we are, right? No need to get to the panel. Thank you very much. And thank you, Dr. Nzirimana, for your excellent reflections on the work of the Technical Advisory Group for the WHO Afro Emergencies Program, part of WHO's Emergencies Program. Just to reflect a little bit on what you said in the last few minutes, you listed the first priority that countries want from WHO Afro moving forward is on building local capacity. And let me reflect on it in the context of a word that is emerging as the kind of most commonly asserted word in the last weeks in the work we do, is the word sovereignty. Sovereignty. Every country has been calling across Africa for more health sovereignty. But what does that actually mean? It means we want to do more for ourselves, which of course is a very emotionally appealing thing, and nobody globally would say that it is not a good thing. But how do we do more for ourselves? We have to develop the capacity to do that. And these capacities are complex. Many countries have started doing it many years ago, but like they say, the best time to build a tree is 100 years ago. The next best time is today. So over the last few months, years, we've had some incredible opportunities. There have been challenges, but there have been opportunities. Through the COVID response, we have built up our laboratory capacity in many countries in Africa to levels that would never have happened organically. We have built up surveillance infrastructure, digitalized our surveillance systems in many countries, built up EOCs. What is the next thing to do in order to be less dependent on organizations like WHO? Is how do we concentrate these capacities in institutions and organizations to do exactly in the EPR space what very often is left for WHO to do for you and Africa CDC to do for you. So many countries have started on this journey. Some have decided to set up national public health agencies. I heard Zimbabwe announce their own in this event this week. I was in Kenya a few weeks ago to support their launch of their new national public health agency. Why is this important? What a public health agency gives you is an ecosystem of juniors, middle level, seniors working together to develop themselves and their own capacities to grow. It's like a teaching hospital setting where you have house officers, you have registrars, you have consultants, you have a chief executive, and they replicate themselves over many years. Now, we cannot get to sovereignty if we do not develop this capacity. And we will not develop that capacity if we do not put our colleagues in institutions where they can grow. So as we think about the work and the recommendations of the TAG, we have to think, how do we translate the recommendation? Because nobody will tell you capacity building is bad or sovereignty is bad. The issue is, how do we get to where we are today to where we want to be? And it is by collecting these capacities in institutions that we can build up the capacity so that in the next few years, the challenges, whether it's on the HIV program that is being challenged by a lack of resources, or the TB programs across our countries that were mostly funded by USAID that don't exist anymore, or hopefully when we eradicate polio, I see Chris in the room, that we can say that all this infrastructure that we've built up, we are transferring it to a national institution that will manage it on behalf of our country. So I take your recommendation, Leo, and the TAG as a challenge for us. We need to, in the emergency space, remove ourselves from the front lines of the response. And so that where I would like to see WHO in the future is not in the front. I'd like to see every time WHO is going for a response with their blue jackets, I would like to see us behind the country teams, providing a little bit extra support where necessary, a little bit extra guidance, bringing together global actors. And I think that's very much in line with the advice that the TAG is giving us. And I hope that we can develop these capacities, support us as we grow, and WHO, Africa CDC, WAHO, whoever else is supporting countries really are at the margins of the response, and the countries are front center of everything that we do in the emergency preparedness and response space. Thank you.
Thank you very much, Dr. Ikweazu. Also for unpacking the word sovereignty, because it's definitely a word that needs to be considered before using. Thank you very much for that. I'd like to invite the Africa CDC to give us a continental perspective on this matter. And representing the DG, Dr. Jean Kasaya, we have Dr. Landry Sage.
Thank you so much. Thank you for having me. Excellencies, Dr. Chikwe Ikweazu, thank you so much for your great insights. Honorable ministers, distinguished partners, it's an honor to represent the Director General of Africa CDC's Excellency, Dr. Jean Kasaya, who sent both warm greetings and sincere apologies for not joining you today due to other urgent commitments. So let me share his remarks on this important topic. I warmly thank WHO Afro-Regional Director for inviting Africa CDC to share our perspectives during this crucial dialogue on the future of emergency preparedness and response on the continent. Africa CDC welcomes the recommendation from the Technical Advisory Panel on how WHO should adjust to the current context and changing realities. Our continent of 1.4 billion people continue to face over 100 health emergencies each year, with outbreaks as at the moment, cholera, mpox, few months ago, Ebola, Marburg. We are also facing a health financing crisis with significant reduction of ODA and persistent debt servicing, which reduces fiscal space. We cannot underestimate the effect of climate change and conflict, which continue to stretch our fragile health systems. So these realities demand that we rethink our framing of the issue and our framing of the response. And the recommendations of the TAP are very timely. They are calling for smarter, sustainable, and locally driven solutions rooted in country ownership, regional solidarity, unity, and continental leadership. At Africa CDC, as the public health agency of the African Union, entrusted by our head of state to lead on epidemic and pandemic prevention, preparedness, and response, local manufacturing for health products, including medical countermeasures, and recently entrusted to rethink health financing on the continent. We want to see this moment as an opportunity to work collaboratively with other AU agencies, AU Commission HHS, AU NEPAD, AMA, AFCTA, the regional economic communities, and our key partners, particularly WHO. Let me highlight an important innovation that Africa CDC jointly with WHO, AFRO, and WHO EMRO designed and launched 2 years ago, the Joint Emergency Action Plan. The acronym is JEAP. JEAP was launched at the World Health Assembly of 2023 as an innovative partnership grounded on harmonizing our efforts, reducing duplication, and leveraging respective comparative advantages of our institutions to the benefit of our member state and our population. The JEAP initiative has fostered workforce development, scaled up surveillance, and more importantly, over the past 2 years, the JEAP has supported our member state in the process of competing or mobilizing catalytic resources through the pandemic fund application process. So as we reflect on the recommendation from the TAP, let me emphasize a second important innovation. During the implementation of the JEAP, we all faced the Mpox continental outbreak, or the public health emergency of continental security, which was declared for the first time by Africa CDC. And together with WHO, in line with that continental leadership and coordination to reduce duplication, Africa CDC and WHO established the Continental IMST, Continental Incident Management System, to respond to the Mpox emergency. Today, that model is coordinating over 30 partners continent-wide around one plan, one budget, one reporting system, and even one financial management system. I think the recommendation from the TAP come the one in relation to the regional coordination emphasizes this model. So in the interest of time, let me move to how we see the way forward. We believe as the JEAP, a framework which was designed with an intent to strengthen preparedness, continue to grow with more partners joining. The IMST model also offers a framework for continental response in face of emergency, especially multi-country outbreaks. So we want to see, as we move forward, the lessons of the continental IMST for Mpox, which, as you know, yesterday was endorsed by our African Union champion on cholera, the president of Zambia, to serve again for the response on cholera. So we see it as an opportunity to reflect on how, moving forward, the architecture for emergency preparedness and response on the continent should be rethink, redesign, and strengthened in the interest of our member state, in the interest of our 1.4 billion people. So as I conclude, what we need now is true unity, is more solidarity, and it's a call for sovereignty. This unity is not symbolic. It is the difference between having a fragmented response or ensuring our collective security. So yesterday, the launch of the Continental Cholera Response Plan by His Excellency President Hichilema of Zambia represent a clear signal of the political leadership that we need as we think our architecture. If we are to protect our people, Africa must match the technical excellence that we have with the political will around public health emergency and domestic financing. We want solidarity with sustainable domestic investment. Our people demand it, our history commands it, and our future will forgive nothing less. I thank you.
Thank you very much, Dr. Sake, for that very comprehensive continental perspective. Now let's take the conversation to the national level. I'd like to begin with Mozambique, which is dealing with very unique challenges. Not only is Mozambique dealing with reoccurring public health crises, it's also trying to manage a very serious climate change disaster type of area. For example, floods and cyclones. So Mozambique is quite specific. However, it has shown incredible resilience. I'd like to ask the Honorable Minister of Health from Mozambique, can you share with us how your country has built and adapted its emergency response systems, specifically how it has learned to decentralize and to bring forward community-based approaches?
Muito obrigado.
Thank you very much. Thank you for giving me the floor.
Tenho a honra e humildade de cumprimentar Vossas Excelências.
Humbly and it is a privilege for me to have been invited to take part in this important event. Mozambique is a country which is very vulnerable to cyclones. In less than 3 months, we recorded 3 severe cyclones, which really destroyed our infrastructures. The diseases and the consequences that they bring for us means that we need to look for resources, particularly looking at prevention and promoting health. This is the biggest weapon we can have to deal with such situations. An important aspect that I would like to underscore is the political will at the highest level possible. And this we have through the President of the Republic of Mozambique. And he is allocating increasingly more resources to this area. And we have a specific institute which deals with dealing with cyclones and natural disasters. And it's the Ministry of Health which deals with dealing with these situations. An important aspect is that we need to look at the social determinants behind that and try to input this into other policies. What are the important determinant factors when we have emergency situations? We have to recognize about fine water, the issue of hygiene. These are extremely important factors in terms of diseases which could outbreak in such situations. And as you know, we have borders with countries which also face health challenges. And I think that really we can draw lessons from what is happening in neighboring countries too. We need to look, we have 3 main subsystems. We have the public sector, the private sector, and the community sector. And this is like a flag that we have. It is the flag that our president waves because it really helps us to give better access to better health services. It is very important for us. We have 2 plans that are being implemented, the one for eliminating cholera and also one for adapting to climate change. These are vital tools for us in helping our country. We have also invested in contingency plans at different levels at the national, provincial, subnational level. We have multi-sectoral approaches that we adopt, and we have several multidisciplinary teams at the national and the provincial level. We also have operational public health emergency committees, which help us to have an integrated and coordinated response in in line with other sectors. And we also work with public health laboratories so that we can carry out diagnosis and detection in the population. Here, we also look to strategic support from our donors, our key donors, because they have to go through us. We're the first point of contact for the population, but they are important technical and financial partners for us. And we have the Bill and Melinda Gates and other foundations. We have the support of the Global Fund. They have helped us a great deal in emergency situations. We also have the PPPs, and we work in line with the churches. They also help to strengthen our responses to public health emergencies and disasters. We have lessons learned, we have challenges learned in the public health sector, and we know that we need to take account of the financial constraints that are ongoing. What can we do to overcome this? Obviously, we need to try and work with the community in terms of preventing situations and promoting health. Also, we have the sector-wide aspects that can help us. We also have other challenges in our country, and this is rumors and disinformation campaigns. And this again it's crucial for us to have the community engagement. And we also have response, which comes from a special committee. We have multi-sectoral meetings, which deals with the analysis of the situation. And again, the community engagement is decisive. We have also looked at the issue of increasing the literacy of the community. And this has really helped us to manage rumors and disinformation, because they can really provide huge challenges to us, especially in terms of controlling cholera. We really need to work with the community. Otherwise, these are obstacles and barriers that we cannot overcome. And we also we look to faith organizations so that we also look at cultural aspects. This is the way we see the situation, but we're also very open to learn from other countries in Africa.
Thank you so much, Honorable. I'm very glad that you mentioned the issue of fake news, the dissemination of false information. Of course, that can exasperate any situation. I think that it's definitely worth more conversation to talk about how to combat fake news in the face of crisis and exploiting priorities. At this time, let's now hear from Senegal. Senegal plays quite a unique role in the West Africa region. So let's hear from the Minister of Health, the Honorable Dr. C. Can you talk more about the role that Senegal is playing in terms of trying to manage EPR regionally for the surrounding nations in West Africa? Thank you very much, Honorable.
Thank you very much for giving me the floor. I also like to thank the organizers for this very important panel, even if it's being done at the end. Would have loved that it be done at the beginning so that as many people as possible can take part, because what is being said here is very important. Now, before I return to the question, allow me to revisit some factors that are important. Because when we talk about emergency response, people need to have an idea of how the system is organized. When we talk about emergency response, we're talking about infrastructure or hubs. These are laboratory capacities that are well equipped, also vaccine production capacities. We'll talk about refer to skilled health works and surveillance systems that are apt. It's also about the development of prevention among the population in regard to health risk. It's also about national coordination capacities and cross-border
coordination. There's also the issue of capital that is quite important. Now, we find all these aspects in the organizations that we set up in Senegal to respond to emergency. We have the Emergency Response Center, that is the National Framework for Emergency Preparedness and Response. We have a national board for managing outbreaks. We have the regional hub for WHO emergency response in Zambia, and it's a framework to prepare for response at the national level that is equipped with several tools and the capacity building system of our structures. We were also lucky with the support of the WHO to have this certificate of medical emergency team, and that's the first in Africa, first of its kind in Africa. And we have another team that was certified by the WHO that's called SEARCH, but this concerns more professionals, health professionals who provide support in times of deployment need. We also have capacity building in epidemiological surveillance, especially in reference laboratories, the Institute Pasteur. We also have other laboratories as SIGAS that help to early detect a certain number of outbreaks, like the case we had with Mpox that was detected in less than 48 hours with the detection of the first case in Senegal under 48 hours. We're also lucky to have recently organized a collaborative surveillance workshop that was supported by the Gates Foundation that used the One Health approach. We mobilized all the stakeholders, the Ministry of Environment, Culture, and Health, as well as our technical and financial partners who are working in the area of surveillance. Among the important points, we can count the engagement of authorities at the highest level. We can't talk about emergency preparedness if we don't have the capacity, if we cannot locally produce vaccines, which explains why in Senegal we have the vaccinopole in Zambia with the Institute Pasteur that is developing a series of vaccines that can help out in case of needs during outbreaks. Senegal is also a member of a major organization that works in emergency response. Now, the question that I always ask, based on recent experience, we deployed a medical emergency team in the rural military hospital in an area that because that is a medical desert, as the population want access to some care, but they don't have this access. And the President of the Republic said, this team was set up, it is not, but it's not going to sleep, it has to get trained. The emergency committee has to evolve. If there are people who are in areas that need care and can have access to this care, then we have to develop strategies to ensure that this care is accessible. And it's this team that was trained by the WHO through the military field hospital, and it conducted about 11,000 acts with 7,000 consultations, which helped to save lives. These cesarean consultations that helped to save lives, because these people didn't know that they had this, they were facing this issue and they could die at any moment. Women who were pregnant and who benefited from cesarean section, and without this, during birth, they could have faced problems like they could have lost their lives. So we need to adapt and train these teams that could become operational in the event of emergency, especially with the change that we are facing now, climate and environmental changes. Before I conclude, I'd like to thank the WHO as well as the Bill Gates Foundation. I was lucky to visit the emergency hub of the WHO. It is very beautiful. It is obvious that a lot of work has been done. I'd like to thank the WHO in Geneva, as well as Afro, and all these teams around Dr. Chikwe, Dr. Gay, who are being very supportive of the country in terms of needs, training, and the preparation of health emergency. Thank you very much.
Indeed, Senegal plays such a crucial role in the EPR space for West Africa. And when we talk about EPR, there is a particular demographic that we cannot forget: refugees. And we know that Uganda hosts one of the largest, if not the largest, refugee population in Africa. So let's hear from the representative of Uganda's Ministry of Health, Dr. Daniel Kabayinze. Can you speak to us, sir, how Uganda has leveraged national capacities such as EMT and the Integrated Disease Surveillance Response System to manage public health emergencies such as Mpox and Ebola while trying to respond to a humanitarian crisis and hosting so many refugees?
Thank you very much. Thank you for making the correction. I was wondering when you say Minister for Health and she's watching. So I bring in greetings from my minister.
No problem. Thank you, sir.
Let me start by giving a quote from the WR, our new WR. Incidentally, she comes from this country. When she arrived in Uganda, we are experiencing an Ebola outbreak. So Dr. Kasonde Mwiga said, Uganda's leadership and resilience were critical in containing this outbreak. We had just gotten an Ebola outbreak. So from somebody coming from a technical agency, recognizing that leadership and resilience of the country are key to responding. So allow me to just highlight a few things in that area. As you said, Uganda was approximating 2 million refugees, and everybody is welcome to live in Uganda. So it's an open invitation. If you find it hard to live anywhere else, you're welcome to my country. Leadership comes with innovation. Innovation, let me just highlight the most recent outbreak of Ebola. We had outbreak in 3 cities. They are 600 kilometers apart. We've identified the first case in a major hospital, national referral, and the patient had been in an ICU setting. The board leadership decided to deploy a mobile laboratory for Ebola. That's the first time we are deploying a mobile testing facility to where the epicenter is. Everybody wanted the country not to do that because we have well-established infrastructure to test. But the leadership decided if we have to do it, then we better do it our way. But we are also hoping that it doesn't cause another outbreak. The second thing we did was to isolate all contacts. The popular word is quarantining. So the majority of the people we quarantined first were our own colleagues working in the ICU, working in the hospitals because their contact was in a hospital setting. That was not easy because for every contact, for every case, you can estimate about 30 contacts. So we had to quarantine at the end of the outbreak over 400 people. That was board leadership. The third one is that we deployed the vaccine, a trial vaccine, on day 5 of the outbreak. You need protocols, you need approvals, you need preparations. But we had all along worked with the academia and WHO to prepare that should there be an outbreak in future,
we will be able to deploy the vaccine because currently there is no approved Sudan Ebola virus vaccine. Instead of only saying we are responding, Uganda donated to the world new information through research, because that allowing ourselves to be exposed to a new vaccine at a time of response was also unique. And the results were well taken. The outbreak was contained in 66 days, and after only 87 days, the outbreak was declared over. Why does Uganda remain very vulnerable? All the people who live in Uganda as refugees still have ability to walk back to their home countries. So there is a lot of cross-border movement, and that calls for us to be collaborating with all our neighbors. What we hear happening in the next country, we should be alert. A case in time, we recently had an outbreak of cholera on the border district with South Sudan, but we had already known there's an outbreak. So that had also been contained in record time because we knew there was a marketplace, a market which takes place, an open market, a village market, where we attract all our neighbors. The final thing I will talk about innovation and leadership is about Mpox. After WHO declared Mpox a public health concern of international concern, we had not gotten vaccines in a long time, but we went ahead and mapped who are the people being affected. Two categories of people. The fisher folks were the first culprits, and then the commercial sex workers. We went ahead and registered all of these people. And as soon as the vaccine was available, we went to where they are. Working with Africa CDC, we went to what we call the red districts, got their colleagues to register special rooms in their workspace, and we had the people receive vaccines. Is that where you would want to giving vaccines? If we only wait for what is known, no knowledge will be provided. So we are able now to come to terms and reduce the trend or number of Mpox cases because we've gone out of the orthodox way of doing and giving healthcare to using the commercial sex workers to invite their friends in the spaces they feel safe to receive the vaccines in the two most affected cities. And that works. So going forward, and as I conclude, I think we need to be more innovative. We don't have to follow what is always known. The leadership must be bold to try new things, because out of these new ideas and innovative approaches, we are able to come to terms with what happens. So we need solutions which are tailored to the situation.
Excellent. Thank you so much. Very well said. So taking an unorthodox approach when it calls for it. Thank you very much, sir. This is now a good segue. To hear from partners and stakeholders in the EPR space. I'd like to pose a collective question to our partners here on the stage, starting with Dr. Elias. Can you share with us what are the most effective ways that partners like yourself, like the Gates Foundation, can come in to support and strengthen EPR in Africa, also to increase the capacity of the workforce here in the region?
Thank you. Let me start by first thanking the WHO Afro for the invitation to participate, as well as for our longstanding partnership. I mean, I think, moderator, to your question, you've kind of heard the answer. I mean, you've heard the Gates Foundation referred to by a number of the speakers. And that's, they've thanked us, but we really want to thank them for their partnership, because our work in EPR is really based in country ownership, partnership, and building the core public health capacities. While we sometimes, like other development partners, can acutely respond to an emergent outbreak or problem, our preference is to help invest in building the capacity and the coordination. We've had a number of particularly, I think, fruitful partnerships with the WHO. One is the Global Health Emergency Corps, where we've worked closely with Dr. Chikwe and his colleagues at the global level, but also at the regional level. We've also, to Dr. Salam's comments, that we were also very happy to support the survey that WHO Afro did to really bring in the perspectives of member states about how to respond to these shifts in the donor environment, how to respond to the learnings of the COVID-19 pandemic, and how to build the infrastructure in a more decentralized regional hub structure within WHO Afro. I was also particularly happy to hear the comments from our country colleagues from Uganda and Mozambique and Senegal. We've had the opportunity, particularly in Mozambique and Senegal, to help support the establishment of some of that response architecture, the emergency operations, public health institutional capacity in Senegal. And really, I think one of the other things, going back to Dr. Deo's comments from the TAG, to quote him, he said, coordination and alignment are non-negotiable. And so I think one of the best investments that we've made has been on the Joint Emergency Action Plan that our colleagues from the African CDC referred to. I think bringing together these important regional institutions to act in a coordinated way for MPOX and building on that in facing the numerous emerging crises. The background paper referred to the large number of outbreaks that have been seen, the number of health emergencies. I think Dr. Janabi yesterday said there were over 160 last year alone. Many of those, according to the background paper, over half of those had some component of climate change as a critical factor in terms of the determinants. And that trend is probably only going to get worse, whether it's in displacement of climate refugees, whether it's in the frequency of severe weather events, et cetera. So I think that it's great to hear about the coordination that's happening as the countries lead and the regional institutions like WHO Afro and the Africa CDC help to support that rapid response. And build a capacity so that there's early detection. Several people have said prevention's better than response. It's certainly less expensive, both in terms of financial resources and in terms of lives that are put in vulnerable and risky circumstances. So I think, we are happy as a funder to continue to support these kinds of country-led efforts, support the building of the capacity of national and regional public health institutions, and to be a partner with all of you as you confront increased challenges in the future from climate change and other conflict and other settings, as well as the current crisis in reductions of overseas development assistance. If I had a concrete suggestion, it would be to build on the momentum that you have and pick a couple of countries where the member states are quite keen, and who have been experienced in leading these kind of responses. We heard just recently from our colleagues from Uganda, and to really, build on that by trying to pilot and strengthen that coordination, to build the muscle, if you will, so that when emergencies occur, there's a rapid response, that we don't have to think about how we're going to respond. We just reflexively put in place a well-prepared set of responses, whether it's through the IMST or the EMTs or all the other acronyms that we've developed in the EPR space to get ourselves better prepared for the coming challenges of the future. So in short and in closing, the Foundation's ready to work closely with WHO, Africa CDC, the ministries and other regional bodies as you continue to build the African leadership and epidemic preparedness and emergency preparedness and response. And just want to thank you all again for your leadership and your commitment, and in particular for your partnership with the Foundation as we face these important challenges in the future. Thank you.
Thank you so much, Dr. Elias. I'd like to pose the same question to Ms. Gilpin. How can the UK FCDO strengthen its commitment to strengthen the capacity of EPR here in the African region?
Thank you. Dr. Ihe Kwazu, honorable ministers, fellow health professionals, Thank you for the opportunity and privilege to speak today as a representative of the UK, a long-standing partner in advancing health and well-being across Africa. I think we're all in agreement that increasing health emergencies are not simply a health issue. It's a development challenge, a security imperative, and a profound equity concern with global implications. So I'd like to add one more word. We've heard about sovereignty, we've heard about regional solidarity, but global solidarity is also important. We're not safe. No one is safe until we are all safe, as the saying goes. The UK remains committed to global health security, with our largest bilateral investment remaining, I stress remaining, the Tackling Deadly Diseases in Africa program, developed in the aftermath of the West Africa Ebola crisis. Despite the constrained funding environment, I'm sure you're all aware that ODA from the UK government will decrease to 0.3%. We see new opportunities, not least the adoption of the pandemic agreement, the momentum on the One Health approach, technological advancements, and most importantly, and what I have witnessed here being my first RC meeting, the drive of member states towards sovereignty and self-sufficiency. Now, turning to our approach and key priorities in this going ahead. First, we are prioritizing diverse regional partnerships to improve coordination, tackle cross-border issues, and foster innovations. I will mention some familiar partnerships that we have and hope to deepen and encourage through working through Africa CDC, WHO Afro, Institute Pasteur de Dakar, and IFRC, to name a few. We will continue to support surveillance, outbreak response, encourage innovation, including research, and are strengthening the enabling environment for regional manufacturing. We're deepening our efforts to coordinate within the UK government and leverage our deep expertise from public health to animal health. In the interest of time, I will not name the programs, but be assured that we're present and active in many African countries. Second, we're aligning our investments in multilaterals to integrate global health security approaches into universal health coverage and integrated primary healthcare systems. Hashtag Lusaka agenda. This is key as a pathway to sustainability. Third, and crucially, we will maintain flexible risk-based funding to rapidly respond to crisis, especially in fragile settings. This will include contributing or continuing to contribute to the WHO Health Emergency Contingency Mechanism and Fund. We note the Africa CDC's Africa Epidemic Response Fund and the need for member states to similarly establish and protect health emergency funds, So in short, we're encouraged by the shift towards more agile, locally driven models of emergency response. And we see that regional institutions like WHO Afro and Africa CDC are rightly the first external port of call in emergencies, and locally driven innovation should be encouraged. In terms of practical steps we're doing, I'll just go through six very, very quickly. We aim to work smarter. I've outlined the areas that we will focus on. It's no surprise that Gates Foundation is here. we are going to deepen our donor partnerships to provide support scale, drive efficiencies and impact. Like the Gates Foundation, we also support the first ever JEEP between Africa CDC and WHO Afro. Through our investments and all oversight of global health initiatives, I've talked about our championing of the Lusaka agenda, prioritizing country leadership and ownership and sustainable integrated primary health care. We will protect our investments in core health security enablers, as I've mentioned. On the health workforce, we have been supportive of surge models, field epidemiology training, and community health worker professionalization, and we'll continue to do so through AVOC, SURGE, and JEEP. We call on WHO and Africa CDC to harmonize approaches for classification of health emergencies team. And we also call on the cooperation of member states to unblock barriers that prevent rapid international deployment of continental emergency response teams. We have been supportive of training, and we are proud of the thousands that have been trained. But when you ask about the rate and the speed of deployment, ladies and gentlemen, we're sadly lacking. And that must change if it's to make any real difference. And I believe that it is within the power of regional institutions and member countries to really tackle these barriers and make it a reality. If anyone's interested, we've done an evaluation and there's a learning piece that may provide some insights into the aftermath and effects post-deployment. But I will hasten to say that we're proud of our support to this value for money, efficient response strategy. In terms of catalyzing domestic and private resources, let me just touch on some of the things we're going to do very quickly. Supporting local manufacturing via tech transfer. Pooled procurement, you've all heard about Gavi and Global Fund and the work they're doing with regional institutions and countries on this and prioritizing African producers. We will continue to advocate for costed national public health action plans, integration of climate. We've heard from many speakers of the advancing climate crisis and cross-border coordination, and not forgetting integration of One Health, all linked to health sector and national monitoring and evaluation frameworks. And because the UK is a government and we're using taxpayers' money, we will focus on clear metrics, but focused on outputs and outcomes. And as I've emphasized, a learning agenda to ensure accountability and impact. Colleagues, the next pandemic is not a question of if, but when. Our collective preparedness, I talk about in the UK as well, will depend on the strength of our partnerships, the agility of our systems, and the courage to act early. Thank you for your time.
Very salient points, very salient perspective, Ms. Gilpin. Thank you very much for that. And when we talk about EPR, of course, a very consistent stakeholder in the space has been the International Federation of the Red Cross. So I'd like to pose a similar question to the representative. How is the Red Cross strengthening capacity in the Africa region? And if you can also share any innovations that are in the future for us. Thank you very much.
Thank you so much. Good evening. Our protocol is duly observed. On behalf of the International Federation of the Red Cross, that is the IFRC, allow me to take this opportunity to express our sincere gratitude to WHO for giving us the invitation to participate in this meeting and in this side event. IFRC and its member national societies are on the front lines of complex humanitarian and public health crises. We witness firsthand the growing complexities, the systemic changes, the systems challenges, and the shrinking resources. These realities demand a fundamental paradigm shift among all actors at global, regional, national, and even subnational levels. I want to also remind you that the IFRC serves as a secretariat to 49 national societies in Africa. So our strength lies in a community network of over 4 million volunteers across 18,000 grassroots branches in Africa. These volunteers are consistently providing fast response actions during epidemics. Yet to sustain and scale these efforts up, we require strong partnerships and supportive frameworks. So here we highlight 6 key recommendations for this paradigm shift. First, the national societies officially serve as auxiliaries to their governments and ideally have access to fiscal budgets and inclusion in the national preparedness and response plans because they are established by Act of Parliament. These laws are very old. Some of them date as far back as 1970, and they do not reflect the current realities. So we urge governments to update these laws and operationalize them. I was happy to hear the Uganda Ebola story because specifically for Uganda, where the law falls short, we have an implementation framework or MOU with MOH, which gives us ease access, and we were not engaged ad hoc as in some of the other countries. Secondly, we recommend the scale up of community-based health workforce. In fact, these are the very key people in EPR. They are key in prevention, early detection, and response. And yet they're very under-resourced and lead fragile livelihoods. In alignment with AU's 2017 commitment to scale up a people-centered community health workforce, IFRC co-leads an Africa-wide REACH initiative together with Africa CDC. And with this, we urge governments to systematically integrate community health workers and volunteers into national health systems and preparedness plans. This way, you ensure that no community is left behind. Thirdly, we advocate for strengthening coordination and collaboration. Many of the speakers have said this before. With WHO, we have a 5-year framework which combines WHO's technical and policy expertise with IFRC's vast community reach and technical expertise. This is strategic. We have worked closely with WHO and Africa CDC in the MPOX Continental IMST, where IFRC co-leads the sub-pillar on capacity building for surveillance. We've worked closely in several ventures, the JEEs, resource mobilization, cross-border surveillance. So we urge WHO, Africa CDC, and governments to continue implementing such mechanisms, but also sustain them beyond outbreaks, intensifying their role in preparedness. Fourthly, the time to invest in preparedness is before the crisis. Many times, national societies are asked to respond with very limited preparedness funding. This actually just escalates small emergencies. So the paradigm shift here is that we have an increased budget allocation to preparedness and early investment in community readiness. Fifthly, it's very important that we link community-based surveillance to national systems. The IFRC's community-based surveillance systems generate vital early alerts for government investigation. However, these are not directly linked to the national health information systems. We urge that with digital transformation, these IFRC CBS systems are linked to national health information systems for efficient real-time data use as exemplified by the efforts that the Kenya government is working with us to link the Kenya Red Cross dashboard with the National Health Information System. And finally, we would like to also emphasize the importance of utilizing community feedback for behavioral change. Outbreaks like Ebola and COVID-19 have taught us that community insights on cultural practices and vaccine hesitancy are critical. A true paradigm shift here requires that deeper collaboration in social and behavioral change science is engaged to ensure community feedback directly informs all preparedness and response planning. In conclusion, IFRC affirms and reaffirms our commitment to actively strengthening these collaborations. We urge national governments, Africa CDCs, WHO, donors, and all the other partners to join us in building a more locally grounded and inclusive emergency systems with the communities at the center. Let us be intentional. I thank my fellow panelists for the critical role that you play as we build a healthier Africa together. Thank you.
Thank you, Dr. Kiza, and a very big thank you to the rest of our panelists. At this time, let's take it to the floor to hear from member states or any partner organizations. If you have any questions, remarks, or interventions, please keep it within the 2-minute range. Please feel free. Just raise up your member card and we can acknowledge you. We have about 10 minutes or so for some floor engagement. You can also feel free to pose any questions to the panelists here. We have Gambia. You may please share your remarks, Gambia.
Thank you very much, Madam Chair, and we thank the panelists for this thought-provoking discussion. Emergency preparedness is a very critical aspect of health care service delivery. The COVID-19 pandemic has really shown us really where the gaps are, and we are happy that it is being discussed. But certainly it cannot be discussed outside of health system strengthening. Because you typically respond based on your capacity, based on what you have at hand. I'm happy that our colleagues have touched on various areas. For Dr. Chike, yes, it is true. The tree that has been planted 100 years ago in some places, we are about to plant that. And that is the challenge, you know, because we are experiencing all these problems when some of those trees have still not been planted. But nonetheless, something needs to be done. Health sovereignty that you spoke about, I think is critical. But the truth of the matter is we have to be realistic. It has become a vogue. We say health sovereignty. Are the resources there? The same reason why our roads are not so good sometimes. Water is not in some of our villages, and we don't have electricity in some of the villages is because we don't have all the resources. So if we keep on saying health sovereignty, yes, we must do something. In the Gambia, we tried from national resources, building new health facilities, and so on and so forth. We should be seen doing something, and we should do something, but there are things that are beyond what we can do. That's the reality. So we still have to partner and complement each other as African countries. I think too often than not, Africans each person wants to do everything by himself or herself, rather than us leveraging on each other's advantages and complementing each other, as some other continents are doing. We have a center of excellence in something in Gambia, and Senegal has another one, and we complement each other. But otherwise, one wants to build everything, another wants to build everything, and the resources are still are not there. But I think WHO and Africa CDC, we are happy that you are working together. Because when Africa CDC came up, one of our concerns was some of the responsibilities, it looks like there was going to be duplication. In fact, at some point we thought there was going to be friction. But we are happy that you are partnering together, even though when it comes to surveillance systems, we still wonder the reporting mechanisms. Who do we report to as countries, Africa CDC or WHO? And harmonizing that, I think, is very, very critical, and we are happy that we are hearing that. But I think finally, because of time, when it comes to challenges in the health sector, the resources, you see, we are poor countries and we still buy items, medical products, and consumables at the same cost as the rich countries. WHO and Africa CDC come together, advocate for positive discrimination. The poor countries, so that we buy things at a cheaper rate. You know, when you look at the profit mechanisms, some multinationals, you know, we hear billion-dollar profits. Where do the billions come from? Some from the profit from the rich people and some from the poor. That's the problem. Some comes from the rich. So those profits are actually from countries, those who buy the products. So why can't people advocate for maybe people becoming multimillionaires rather than multi-billionaires, so African countries can also buy something? We are not anti-big establishments. We are just being realistic because we know part of our problem is because we buy medical consumables and medical items at higher cost. We simply do not have the resources. So WHO, Africa CDC, put forward a case for African countries so that there's positive discrimination. The rich can continue to buy at a higher cost, but let it be cheaper for the African countries so that we can also establish these systems. Another point, the very final one, is can we also look at debt cancellation for NCDs, for example? That's something you can come up with. Africa CDC, WHO, you know, debt relief for health services, so that whatever relief we get from that, all of it is plowed into health services. Because some countries, what we pay, what we spend on debt servicing is typically more than even the health service, the health sector budget. Thank you very much. We can go on and on and on, but I think I will take a break for now. Thank you.
Thank you very much. We appreciate those comments. Let's now hear from Ethiopia. And let's keep the comments to 2 minutes, please. If we can get the timer, that would be very helpful.
Thank you. Thank you, moderator. I will keep the time even without the screen. And thank you so much. Just this appreciation for the technical advisory group's recommendation that we really learned a lot of lessons and in different emergencies. You know, Ethiopia is a pioneer country involved in the Ebola in different sister Brazil countries. And so we are working inside in the capacity of emergency team to be deployed in country and throughout the Africa. Through AVOC, we certified about 300 people ready to be deployed in anywhere in Africa if the need comes, because we really totally believe that the free movement when we are in need to each other, and we are very open for others to be participated. Also, we built with WHO regional office and the headquarters, the emergency training center in Addis, that is very near to the Ethiopian Airlines, just a line with airline to be deployed and to be trained in the center. So the emergency management team are pretty good. We're going through WHO accreditation process, and almost they are and in the verge of certified globally to be taken out for anything. So we really plea for increased partnership and collaboration for emergency preparedness and response among countries, among the regions. And I really share that we don't need to duplicate everything everywhere. Wherever it is, we want to use. That's the main message I got from the panelists today. And I ask our partners also to really strategize, to help us to strategize on different countries. One last thing I want to emphasize is in the logistic management. You know, Japan Airline is a very, very good airline, and all other airlines we have in Africa as a sovereignty. We need to think about what we passed in the COVID for the hub, and the WHO and the Africa CDC should help us to move our strategic supplies from other countries to Africa. I know there are some in other countries which are not reliable. So we need to focus on among the teams on those supplies. Thank you.
Thank you very much for those insights and that perspective. And finally, let's hear from Kenya.
Thank you very much. And I want to thank our panelists for very fruitful discussions. Just to go straight to my point, we know that when we're talking about physical and fiscal, when I say FIS, fiscal financial constraints in our health response, we need to look at, if you're responding to something, it means it has already happened. So how do we mitigate it from happening? It's very rare that nowadays we hear about risk assessments. I'd like to hear from the WHO headquarters. What are they doing just to ensure that countries are able to not just conduct these risk assessments that we keep on doing through SPA, JE, and all that? How is all this going to come together so that even as an Africa region, we are able to track our risks, whether it's through dashboards or through event analysis or evidence and event-based surveillance, so that we're able to mitigate any events from occurring, because we know that once it occurs, then the cost goes up exponentially, but yet the cost of assessment and risk assessment is much lower than that. Thank you.
Thank you so much. Let's take the question. It's about mitigation. Perhaps Dr. Deo or Dr. Chikweazu can respond.
Thank you very much. Very happy to respond it, but also there is one gentleman in the room. Dick Kamla, I don't know, where are you? You are close to a mic?
I'm here.
You are here. Go ahead.
Okay, I really appreciate an opportunity to answer the question from the Republic of Kenya. It's true, in the WHO, we have a preparedness model in which it has two components, upstream level and in the downstream level. So on the downstream level, we have a risk or hazard assessment. So we have a capacity assessment in which we are talking about SPA or JE. And also we tend to use all the outcome from a risk assessment in which we have also another tool, STAR, and the capacity assessment creating NAFs, and National Action Plan of Health Security. As a result, it's the model in which is clearly articulated in IHR, actually as a part of IHRMF. And at the time I'm talking of capacity reviews, is actually to try and assess implementation of IHR core capacity. As a result, we have a framework and an IHR tool in which is able us to see actually progress of implementation of IHR core capacity, in which actually endorsed by our member states. Over.
Thank you. Just to add something, that we have some very interesting work in project, which is to use artificial intelligence to introduce all the data we are having on the risk assessment and the product, that even if you take one single country, it is almost beyond the capacity of human being to analyze it and come up with some very good information. Now we are building some relationship with many partners that I will not cite anyone because others may be unhappy, to develop artificial intelligence use in order to exploit those data and information. Thank you. I don't know if Dr. Chikwe, you have anything to add.
Would any of the other panelists like to respond to anything heard on the floor, just very briefly? Yes.
Yeah, thank you so much. I really want to comment the contributions from Gambia and Ethiopia. I think you are touching on critical points. The first one is, I think when we look at access to health commodities, and particularly access to medical countermeasures, this has been a critical point of debate in the negotiation towards the pandemic treaty. And I think you are touching on a critical dimension, which is ensuring that there's equity and fairness in access to medical countermeasure. And the point on the PABS, pathogen access and beneficiaries, which is still part of the annexes of the negotiations that are going on. will address that issue. And Africa CDC working with WHO are supporting our negotiators to ensure that this point is clearly articulated in the interest of our people. And the second point is the fiscal space. I think this is where the political dimension of our work becomes critical. And I think yesterday we were fortunate to listen from the wisdom of His Excellency President Ishelema, where he insisted that health is a determinant for economic, and he also insisted that it's not only about economic development, it's also industrial transformation. And we really want to advocate for looking at how our member state should face this chronic debt crisis. And yesterday, the President also insisted on a critical dimension of the definition of the risk and how risk determine the interest rate at which our countries are contracting debt. I think this is an important dimension of the negotiations that have to happen at political level. I want to reassure you that as part of our engagement as Africa CDC through the G20, Committee of Health, and Committee on Finance, these issues are being addressed. But I really want to reassure you that this is an important point of negotiations, because unless we reduce the pressure on our fiscal space due to debt servicing, it's going to be difficult for our member state to sustain the current crisis as they are mitigating its impact. I think the last point I want to emphasize on is how can we come together in this particular time, pooling our needs and negotiating a fair price. I think the point of unit cost around pool procurement was highlighted 2 days ago by His Excellency John Kaseya when he presented the African pool procurement mechanism, an innovative mechanism that the head of state have entrusted Africa CDC to put in place. And that mechanism is intended to negotiate fairer and equitable prices for our member state. In link to that, it's the need to foster the establishment of what we want to call, in a simple term, stockpiling. I think creating sufficient availability of commodities on the continent to better prepare for outbreak and epidemics. And I think the contribution from Ethiopia goes within that direction. Let me speak. Thank you.
Well received, Dr. Sake, well received. Thank you very much. And we have another comment here.
I want to first of all appreciate WHO for the funding they gave to Uganda to respond to the Ebola. And we, as to Oliver Twist, we need some more. But also to say that the way we look at funding for outbreaks should be as flexible and unpredictable as the outbreaks themselves. Because if you write a textbook on how you'll fund as if you have a grant and you keep to the later to how you wrote it, and you're not flexible because the outbreak don't have to time when they will happen, I think we shall find ourselves being as bureaucratic as the normal governments we have, which only have to pass through the specific laws to fund, to spend their money. Thank you.
On that note, let us get the closing remarks from Dr. Abdul Salam Gay. Thank you very much. Whichever you prefer.
Thank you very much, really, for everyone here. To start with those who contributed to the member state survey, those who use their expertise on the panels for the technical advisory group, and also for the strategic discussion we had about the hub. And particularly here also for all the panel members, I think your contributions are invaluable. And I just would like this to be the beginning of reflection and discussion. And any of you who go back to country may replicate it to think about what we're going to do now. And sometimes when there is a crisis, I think it was Churchill who said it will not be good to waste a good crisis. Now we have a problem of funding. It is having an implication everywhere, but particularly in emergency preparedness and response, we can find a way to do more with less. And it is true, it is not just a slogan. If we look for where we are less efficient and do more than where we are more efficient, we're gonna have more result. So thank you very much, everyone. And hopefully we're gonna continue this discussion to improve our response everywhere. Thank you.
Thank you very much, Dr. Gay. Lots of insights for us to reflect on. Let's not all forget that we have an invitation to move to Uganda. Thank you so much, sir. On that note, this session comes to an end. Thank you so much for your time and enjoy the rest of your evening.